I welcome our chairperson for this session, Dr. Praveen Page sir, Dr. S. Manzir Ali sir, and Dr. Rishi Lodaya sir. Now I invite our speaker, Dr. Abhishek Madura, and I request our chairperson to please introduce our esteemed speaker and the topic.
My topic for today is inhalation technique and aerosol therapy in allergic diseases. Inhalation therapy is not new to humankind. Since 2000 years, we are striving hard to have this inhalation therapy with us so that we can improve on our health. So right from Aztecs and the Incas from South America to the English people who have actually invented the inhaler, and the first pressurized inhaler was invented in 19th century. So today is a morning session, and we have to get a nice breakfast. And in Indian breakfast or snacks, samosa is the quintessential thing to have. Like samosa, without aloo, that is potato, we cannot have samosa. We can't even imagine it. Likewise, inhaler therapy is quintessential and the mainstay of asthma management as per the GINA guidelines as well. By the end of this talk, I intend to my aim would be to have this, the clinician should be able to match the correct aerosol delivery device to a patient and should be knowing the 5 Ds, which I will be talking about. So what would happen to the aerosol deposition if the patient breathes fast or slow? We need to know this. We need to know the question, the answer to this question, because we are dealing with inhalers, and inhalers, we have to know what happens with the aerosol particle which goes inside our airways. For that to know, we need to know the 5 Ds. Out of these 5 Ds, the first one is the disease, that is asthma or allergic rhinitis. Depending upon the nature of the disease, the deposition, the site of action would be chosen. Like for example, if a patient is of allergic rhinitis, we would select a nasal spray rather than a fine particle inhaler device, because we know we want to deposit the drugs, deliver the drugs to the nasal mucosa. Likewise, the drug, we know that there are various drugs which are available in inhalation form. In asthma and allergies, we have inhaled antihistaminics, steroids, and of course, salbutamol, a beta-adrenergic agonist. My talk would be concentrating on the last 3 Ds, that is the disability, deposition, and device. Disability means if the patient is having acute severe exacerbation, he won't be able to generate the inspiratory flow that is required for the inhaler device to act. So we need to choose a drug delivery system which will effectively deliver the drug to the intended site. For example, if it's a case of mild exacerbation and the child is around 3 years old, we would be using a spacer with an inhaler, pressurized metered dose inhaler. Deposition, this is a very important thing. The science behind this inhaler is the MMAD and GSD. I will be talking about it in brief time. And device, of course, there are various myriad of devices which are available in the market. We will be looking into that. So when I first saw this MMAD, AD, and geometric when I was studying pediatric respiratory medicine, this was the expression which I had. What is this? So MMAD is nothing but median mass airway aerodynamic diameter. It's just a way to know the size, particle size, where you can we decide what particle size is the best, which will be there in the aerosol, which can go to the respiratory, the bronchioles. Geometric standard deviation, again, it's a measure of particle size dispersion. It's like in your clinical terms, if you see the correlation, it's like the red cell distribution width. So there are some small particles, there will be some large particles, and these the mean of this, it's a measure of particle dispersion, and the GSD, that is the geometric standard deviation, should always be more than 1. Then based on these factors, the physical property of aerosol is determined, and the particle size is very important. In modern inhalers, we have the respiratory particle size is 1 to 5 microns. So we have 3 properties, physical properties, which lead to proper deposition of drug to the intended site. For example, if it is a nasal mucosa, we need a particle size which deposits in the mucosa rather than the airways. So particle size will be more than 10 microns. So more than 10, size of more than 10 microns, the impaction is in the oral cavity, the upper airways. Whereas the sedimentation, this property actually is the most important for asthmatics, because the particle size ranging from 1 to 5 microns, the sedimentation property is the one which helps the drug deposition at the airways, lower airways. And diffusion, this property of aerosol is basically seen with when the particle size is less than 1 micron. And these particle movements, or the sedimentation or the deposition, is governed by the Brownian movements. And as we know, the Brownian movements, it's the random movements in the gaseous mixture. And these are the particles which actually do not settle down to quite easily in the lower airways because of the Brownian movements. And that is why it is very important that the patient should not exhale out rapidly after taking the MDI. Of course, the inspiratory flow rates are important. We are dealing with children. So a child who is less than 7 or 6 years age, he's less likely to have an inspiratory flow of more than 30 liters per minute. And that is the minimum which is required to actually have a DPI or a pressurized metered dose inhaler. So ideally, the flow rate, inspiratory flow rate, should be around 60 liters per minute. Certain devices like the DPIs, they have some, they come up with a low resistance DPIs, so where even a 30 liter per minute is quite sufficient to deliver the drug. So basically, the aerosol is a mixture of small particles which are suspended in the gaseous propellant. So the MMAD and the geometric standard deviation, they actually tell us about the property of inertia, how well or how rapidly the particle is going to settle down on the mucosa of the lower airways. This is another model which was given by Kubrick. Here we can see that the particle size, which is between 1 and 5 microns, they are the ones which are actually settling down on the alveolar and the bronchial ducts and the airways. So we all know, we are pediatricians, we all know that inhalation therapy is very safe and very effective in children. So, and they are quite happy to have this because it is non-invasive. However, we want to know whether this is good for the patient. The parents, as a parent, I would like to know whether my child getting a steroid is not going to get affected by the side effects. How so? In this slide, you can see the drug dose is 20 times less as compared to oral medications. So these are the advantages. I will be skipping this slide. So we know we are using this MDIs and inhalers from a very long time, but still we have seen that the patients, the asthma control is not that great. Even in the Western world, where people are quite educated, there too, they have seen in these studies that only 55% patients of 45% patients actually are in well controlled, and uncontrolled asthma rates are very high. Even in India also, the survey, as per the Asia Pacific survey, 100% asthmatic patients in India are either uncontrolled or partly controlled. One of the reason is the patient and doctor asynchrony. What do I mean by that? So if you see this table here, this is the area where this is the actual real world facts, that how many patients or how many percentage of patients have these errors, device related errors while taking the inhaler device. And you can see there is quite a lot of discrepancy, except for the BA, that is the breath actuated MDI, where we actually have a concurrent perception about the device technique. So the most common problem with DPIs is the failure to exhale to the functional residual capacity before inhaling through their DPI device. That means just the patient has to just exhale out before taking the inhalation pump. Of course, the failure to use of forceful and deep inhalation is very important when it comes to DPIs, because DPIs is actually dependent on the inspiratory flow of the patient. Hence, less than 5-year children, we don't usually give DPIs because of this inability. Most common problem with PMDI, this is pressurized meter dose inhaler, the lack of actuation inhalation coordination and stopping inhalation due to the cold freon effect. Cold freon effect is nothing but when the CFC pump or a HFA pump is used, we feel a cold sensation in the throat, which causes early termination of inhalation procedure, so that the drug deposition, the inspiratory flow is not generated and the drug is actually deposited on the pharynx and the oropharynx. So there are reasons for poor asthma control. One of them is device design, characteristics, and technique. So poor inhaler technique and poor adherence will lead to impaired delivery of drug to the airways, and of course lead to poor asthma control. These are more data on this. So asthma control worsens as the number of mistakes in inhaler technique increases. More is the incorrect technique, more uncontrolled will be the disease. And if we improve on the device, and we educate the patient about the device and how to use it, now you can see the change in the technique. From bad, the FEV1 is quite low, but as we improve the technique of the inhalation device, you can see a drastic change in the FEV1. So Gina has come up with this technique called teach to goal method, where we explain the instructions, we give instructions to the patient, we explain them, we demonstrate them to the patient, and ask the patient or the child to demonstrate it back to us, how we use the inhaled pump or the spacer. And then we give some corrective actions if at all there is some changes to be made in the technique. And this cycle goes on in each and every visit with the child, when the child comes to you. It has to be done with each and every time, because over the time, as you can see in this previous slide, that the technique has to be consistently good enough so that the drug is delivered to the patient. So these are the steps which has to be taken when you are using an MDI or with a spacer or a DPI. The most important thing here is the point number 9 and 11, where you have to instruct the child to have a slow and deep inhalation through the mouth, not with the nose or mouth shut, and also hold the breath at least for 5 counts. In adults, we say it should be 10 seconds, but here in children, we say count till 10 or 5 breaths. Here in this slide, we can see the various MDIs which are available and DPIs which are available, and based on the age of the patient, we can select the correct device, match the correct device with the patient. So inhalation through mouth is possible more than 4 years age, and the sufficient inspiratory flow is generated.
Dr.
More
Abhishek,
than
last 5 minutes.
okay. So we can then select based on this slide or algorithm which patient needs the best inhalation device. These are the PMDIs. I will be skipping these slides. Only 2 things. The limitation of this is it is possible to get no drug in the lungs with a very bad technique, and this is very important. And the second one is the oropharyngeal deposition, which is high in PMDIs, because of which local side effects, especially with ICS, can happen. So this is the HFA, which is having a better profile with as compared to the CFC that is now outdated. HFA is hydroxyfluoroalkane, which causes slowing of the velocity and soft mist, which is better effective. As you can see, the deposition is 53% with HFA. Spacers are needed, as told you before, with patients who are not able to inhale or coordinate properly with the inhalation, especially in children as well as for elderlies. Breath actuated inhaler devices have come up in the market, and they are actually quite helpful because the spacer is not required, and there it can be used by each and every patient. There are DPIs. It contains a powdered form of drug which has got excipient. There are multiple devices, turbuhaler, rotadisc blister, and basically here the resistance is created by this mesh, and the inspiratory flow is needed to overcome this resistance. Lower the resistance, higher is the inspiratory flow which is required. These are the drugs and delivery devices, and nebulizer, as we all know, is our bread and butter. But nebulizers, they have to be given in a selected patients, especially who are incapacitated, either in ICU or having some neuromuscular disorder where they cannot inhale, coordinate the properly. These are the links where you can go and have more information about the technique of these devices. I would not be talking about inhaled intranasal steroids because Dr. Mohita will be having his deliberations. One point to remember, even in inhaled this intranasal steroid, is you have to point the tip of the nozzle towards the turbinates and not to the nasal septum. And you can ask the child to have an interesting way, like having a pharaoh type of position, left hand for right nair and right hand for the left nair. I hope my talk has added to the knowledge, and you will be able to actually decide for us, for the patients, which is the best solution which is available in the market. We are inundated with a lot of things in our plate. We have a lot of things in our plate with rivolizer and whatnot. But with correct knowledge of 5Ds, we can actually select the best drug for the drug delivery device for the patient. Thank you.
Thank you, Dr. Abhishek. Are there any questions from the audience?
Do you really feel MDIs should be used without spacers in children?
Actually, no. MDIs. Anyone? Any more?
No. Thank you, sir. Thank you, Dr. Abhishek.
Thank you very much, Praveen, for giving me opportunity, and thank you very much, the organizer, for giving me opportunity. Now I'm inviting Dr. Saib Al-Matar, who is the MD, PhD, MAMS, FCCP from US, FICACI, and DADA from CMC. He is an adjunct professor and senior consultant, Department of Allergy and Immunology at Apollo Gleneagles Hospital, Kolkata, and is a medical director of Allergy Asthma Treatment Center, Kolkata. So may I request you, sir, please give it.
Thank you and good morning.
And he is going to speak out the role of intranasal corticosteroids.
Thank you. First of all, thank you, respected chairperson. And I would like to thank the organizers for inviting me in this 10th annual conference and of the Pediatric Allergy and Immunology chapter of Indian Academy of Pediatrics. A very good morning to all who is over here and all who is online. So I'm really thankful that this time I got to come to Nagpur. When I came out of the airport, I saw this, welcome to the tiger capital of the world. Well, I was not aware of this. Well, thank you all. So I would be talking about the role of intranasal corticosteroids, which is in a way an extension of the talk which we just heard from Dr. Abhishek. So I have no confidential or actual conflict of interest to disclose. Now, when we talk of the intranasal corticosteroids, basically in the context of the allergic rhinitis, if you see that the allergic rhinitis burden is quite high, both in the high-income countries and the low-middle-income countries like India. So in the world, there are around 600 million people who have the allergic rhinitis. In the Asia-Pacific region, around 150 million people who suffer from allergic rhinitis. And in India, the incidence of rhinitis is in the tune of the 20 to 30%, which is pretty high. This is a very old slide. We all know this, that how we classify the rhinitis according to the area guidelines. We have the three main cardinal symptoms of the nasal blockage, sneezing, itching, and the runny nose. Basically, we classify both into either intermittent, if there is symptoms of less than 4 days a week, or less than 4 weeks a year, and persistent if it is more than 4 days a week or 4 and more weeks in a year. And depending upon that, whether it's having an impact on the sleep or the daily activities or bothersome symptoms, we have this mild or the moderate persistent. We usually talk that it's a seasonal if there is occurring in particular seasons in every year, otherwise it's a perennial, but in majority of the cases, we may have both the perennial and the seasonal symptoms occurring together in a particular patient. And as I've said, it's pretty high in all over in India also. And this becomes very high during the allergy attacks too. And the nasal obstruction and the ocular symptoms, they are associated very, very poor quality of life. As we see, that's a rhinitis quality of life questionnaire and other such questionnaires which can be used as a tool to evaluate at its impact on each and every patient. And surprisingly, it comes out to be very high. So what treatment options we have? Treatment options, basically, it resides on main three aspects, which are the allergen avoidance, pharmacotherapy, and the allergen immunotherapy. And on the top of that, very, very, very important is the patient and the parent education. As you have just said, that the compliance to the inhalation therapy, either it's the intranasal or the inhaled, is abysmally low. And that's because of the poor education, as I've just heard, that the poor patient-doctor asynchrony, means poor patient-doctor relationship or the rapport leading to asynchrony, as stated by Dr. Abhishek. And so far, there has been no biologic which has been approved for the treatment of the rhinitis. So we'll end up into the pharmacotherapy being the most effective of the treatment when they're properly implemented and the patient complies with it, and to improve the quality of life related to this disease. So that is what we end up with, because it's being the adherence compliance is poor, so education is of the paramount importance in all the patients and the children and the parents whom we deal with. And if it is not being taken care of and addressed adequately, we'll land up in the poor disease control, and which will significantly increase the morbidity and the suffering from this disease. So what treatment options we have? So there are many treatment options, but my talk would be centered on the one major treatment option, and which is the mainstay treatment of allergic rhinitis, is the intranasal corticosteroid. If you see that this intranasal corticosteroid, it significantly impacts all this is three, that is the rhinorrhea, that is the sneezing, and then nasal itching and the nasal obstruction. Means these major cardinal symptoms are very adequately taken care of by the use of the intranasal corticosteroids. And though it also improves the ocular symptoms. In the recent times, we are having the combination of the intranasal corticosteroids with an intranasal H1 antihistamines, which has also been shown to have an add-on effect on what we are getting with the intranasal steroid. I'll be talking a little bit about it in the end of my talk. So this schematic diagram is a reiteration of the fact which we all know. This is a typical, there's a classical pathway of the allergic inflammation, in which we have the allergens which gets bound to the IgE, and the IgE which is typically bound on the mast cells through the high affinity IgE receptors. And binding of the allergens to the mast cell bound high affinity IgE receptors, it leads to its cross-linking, leading to several downstream signaling pathways, and ultimately causing the degranulation of the mast cell granules. And these granules has histamine, various other proteins, leukotrienes, cytokines, and also those are the eosinoids like prostaglandins and the thromboxanes. And these are the mediators which leads to the classical symptoms of sneezing, rhinorrhea, congestion, and pruritus. Apart from that, and this constitutes the early phase reaction. Apart from that, there is a late phase reaction also, which occurs because of recruitment of the inflammatory cells, namely the lymphocytes, eosinophils, basophils, monocytes to the area of the inflammation, which also subsequently releases lots of cytokines, which brings about the typical signs and symptoms we see. Initially, we thought that the corticosteroids, they typically blunt the late phase reactions, but now we have more and more evidences which shows that the intranasal corticosteroids has an impact on the IgE-mediated release of the histamine from the mast cell granules, and it actually reduces the release of the granules. And also on the other hand, it decreases the activity of the interleukin-5 mediated eosinophil accumulation in the sites of the allergic inflammation in the tissues. So a short about how the glucocorticoid act. We know that the glucocorticoid acts through its receptors, which is the cytosolic receptors. And this glucocorticoid diffuses through the cell membrane. This is the canonical or the classical pathway. We have a non-classical pathway, which is also coming up and having its role in various settings, including the allergy, a control of the allergic inflammation. So it bounds to the glucocorticoid receptor proteins, and these are cytosolic proteins, which are in the inactivated state by being bound to some other proteins, which are like the heat shock proteins. So when this glucocorticoid comes inside, binds to the glucocorticoid receptors, the heat shock proteins moves away, and this glucocorticoid receptor and the glucocorticoid complex, it it just goes inside the nucleus, translocates inside the nucleus, and it binds to the glucocorticoid receptor elements, which are actually in the promoter sequences of the various genes, and that causes the activation and release of the various other mediators, which suppresses the inflammation. On the other hand, it also causes a repression, that is, it acts on the various other transcription factors. And by acting on the transcription factors, it reduces the action of the transcription factors and thus reduces the formation and the release of the various proteins and through the repression of the transcription factors. It's called transcription repressions. So this acts mainly, and the glucocorticoid receptors are ubiquitous. It is present in most and almost all the cells, or nucleated cells in the body. So we say the glucocorticoids have a very important role in the cellular mechanism, which is being tackled by the glucocorticoids and reducing the inflammations. So it causes a blanket anti-inflammatory medications, which is needed, which is actually used in the day-to-day life. So when we talk about the intranasal steroids, basically there are two groups. One of the older intranasal steroids and the newer ones. Older ones like the budesonide, like the triamcinolone acetonide, and the beclomethasone dipropionate. The newer ones, we have this fluticasone propionate, mometasone furoate. Now we have the fluticasone furoate and also the cyclophosphamide. Now we see that the newer these intranasal corticosteroids have much advantage in regard to the safety profile of these drugs, and also they are known to be more potent. So the therapeutic safety ratio is much higher with this newer intranasal corticosteroids. So, but the difference is actually what we see is mainly in the terms of the potency of the drug, the receptor affinity, the lipid conjugation, the lipophilicity, absorption, bioavailability, and the hepatic fast pass effect. So just a very brief on what do we actually mean by that and how does it impact the treatment in our patients. So we can see that potency, we can understand the more potent in the drug is, the lesser amount of it is needed to bring about the particular desired effect. Lipophilicity means how it is bound to the lipids, but there's a caveat in this is that the more lipophilic the medication is, it will be bound to the actually we have in the mucus, we have the sol and gel phase. It gets bound to the gel phase. It can be washed away. So it's a disadvantage in cases of where we're using intranasally. And volume of distribution, obviously, the larger volume of distribution for more lipophilic molecules will entail its retention in the body for a longer time and the side effects being there for a longer time. But also it's important is that it is actually makes this drug to have a once daily dosings. Fast pass effect and elimination half-life, I'll be talking about this shortly. So if we see the receptor affinity for the intranasal steroids, the highest we find it for the newer generations. That is the fluticasone furoate being the highest affinity for the GR receptors, and also the similar one being the mometasone furoate and the fluticasone propionate. All the other older generations and intranasal steroids have lower affinity towards the receptors. Now, this thing is very, very important to understand the systemic side effects, because when we're prescribing these drugs to the children, we are basically we want to understand what will be the systemic bioactivity and whether it's going to affect the growth of the child and other systemic effects. So if we take a 200 micrograms nominal dose of an intranasal steroid, we find that when it is given intranasally, 30% of the drug is retained in the nose and the 70% is swallowed in the gut. So of the 30% which is retained in the nose, it gets directly absorbed in the systemic circulation. So if we take 30% of 200, it's just 60 micrograms. It gets directly absorbed in the circulation without undergoing any fast pass effect. But of the 70% which goes into the gut, that means the 140 micrograms for this 200 micrograms dose, means those agents which have a very high fast pass effect, like the fluticasone propionate or the mometasone furoate, which are 99% hepatic fast pass, only very little amount of the drug goes into the circulation. But those which have lower fast pass effect, like it's inactivated to a lesser degree in the liver. So like the budesonide or the triamcinolone acetonide, they're around 14 micrograms will get absorbed. So means in total, if we see that for there's what is called this mometasone furoate, that means 60 plus 1.4, that means 61.4 micrograms goes into circulation, which is for budesonide is 74 micrograms. But there are two caveats in this. Number one is that not all drugs which deposited in the nose goes into systemic circulation, because we know there's a very good amount of the nasociliary clearance, and which actually again brings the drug to the gut. So those drugs which are very highly lipophilic, that means that is the mometasone and the fluticasone, majority will also again go to the gut, and they will be taken care by the liver by 19% first pass metabolism. So it is not the 60 micrograms which is going inside, it's much, much lesser than that. So these drugs are quite safe when they are actually given intranasally. So the systemic absorption rates is very, very low for the mometasone and cyclophosphamide. So we can say that these are pretty safe. So there's a negligible systemic absorption for all these drugs. But in clinical practice, all what I've said is of more of theoretical importance, because they do not show much differences in the activity in the clinical parlance. So the common side effects we get, like dryness, stinging, burning, and epistaxis, has to be kept in mind. So these are the newer generation of the intranasal corticosteroids. They have high degree of glucocorticoid receptor affinity, potency, specificity, low systemic bioavailability, high first-pass hepatic effect, and a once daily dosing. So it's quite near to one of the ideal intranasal steroid drugs which we can prescribe to our patients. So this is the proprietary names, generic names of and dosages of the common agents that we use, and this is actually available freely. So what is the allergic rhinitis landscape in our country? We know in our country, or means it's the world and the Indian burden. In world, it is moderate to severe allergic rhinitis is more common. In India, we also see that 35 to 36% of the patients have the moderate to severe allergic rhinitis. So we see that there's a growing burden of rhinitis patients with more moderate, severe, and the persistent disease. Why? Maybe because of various other epigenetic environmental factors which actually adding on and causing the perpetuation of the inflammation in the nasal as well as in the bronchial airways, and leading to more severe disease in these patients. So the control is of paramount importance if we want to reduce the inflammatory load in these patients. And these patients very frequently, they complain of the breakthrough symptoms, even when they are on the intranasal corticosteroids. It is in Europe, it is in the tune of 32.8%, and US 44%, and India, we do not have any data for this, but it has to be higher than this because of the poor air quality index in the cities in which we reside. So what the area recommends is that if the quality of life is poor, that means the visual analog scale score is much less than 5, definitely we need to step up the treatment and add an intranasal antihistamines along with intranasal corticosteroids to bring about more better control of the inflammation and the symptoms. And this will entail a better quality of life in this patient. So in the Indian guidelines, we see it is always the mainstay is the intranasal corticosteroids with or without intranasal antihistamines, namely the acylastine, for the use of the seasonal and the perennial allergic rhinitis patients. So we conclude that inhaled nasal corticosteroids are the mainstay treatment for the seasonal and the perennial allergic rhinitis. It has a faster onset of action, it's a long and sustained action. Single device actually provides a uniform distribution of the drugs, and it's a good tolerability and could be used safely in our patients, well, in conjunction with the proper education and obviously to some extent the environmental control. And by this way only we can achieve a better control of the disease in our children, in our population, and which will actually be important in halting the atopic march and also help in reducing the morbidity and later on the other complications of the atopic march and allergic diathesis in our children. Thank you very much.
Thank you very much, Dr. Saibal, for giving a very elucid talk on this intranasal corticosteroid role of intranasal, and you have made it evidence based on that. I have one query on the majority of them. They come in the pediatric practice. They have got a nasal block, and we usually give only the normal saline and all we give, and majority of them they are not improving on that way. So what we should think about that, whether we should give this a steroid or whether we should give other way around?
It is basically, if we see the intranasal steroids, they have a good action on the nasal blockage. So it's better to shift the patient off who are mainly complaining of the blockage, that's the blockers we call them, rhinitis blockers, to an intranasal steroids, and more so addition of the intranasal antihistamines in a fixed dose combination like the intranasal corticosteroid with an H1 antihistamines, namely the azilestin. It has been shown to have a better impact on the blocking symptoms of this patient. So these are the options. Definitely one has to be shifted to the INS, and one can, if you want, you can add an intranasal antihistamines in a fixed dose combinations to these patients.
So you advise them the intranasal, this
Corticosteroids.
corticosteroids with them, and
Yes.
that will be helpful on that.
Exactly.
Because it will be there. Then it is open for the questions. If anybody has questions.
One more, sir. I just want to ask whether intranasal is better or inhaled
For what?
for steroid only.
If you're talking for which disease? If you're talking about the allergic rhinitis,
Yeah.
it's the intranasal steroids. If you're talking about asthma, it's the inhaled corticosteroids. And you know, there is, interestingly, like if you just search the literature, it has been shown, there are several studies, it has been shown that in those patients who are having both the symptoms of the asthma and also the rhinitis, if they are not very compliant with the inhaled corticosteroids, even giving only intranasal steroids has an impact by reducing the lower airway inflammation, which subsequently also bolsters the unified airway concept that we all study these days. And there has been lots of papers which is coming up in this front too.
By inhalation also, sir, some drugs go through nasal.
If you're inhaling, yes, some drugs definitely go through the nasal, but important thing is that we want the drug to be deposited over there. So, and that's why the aqueous nasal spray is needed, because for this, the drug has to dissolve through the aqueous media, go into the mucosa where the inflammatory cells are there, and then go inside the cells and have its impact on the cellular mechanisms.
Thank you.
Sir, may I ask a question?
I would like to add to this regarding whether intranasal inhalational MDIs can be effective as an intranasal. As in my previous talk, I talked about the particle size. So the intranasal solutions, they have a larger particle size, which is intended to deposit on the mucosa of the nasal cavity. Whereas the inhalational therapy, the MDIs, they have a very small, fine particles. The HFA particles are actually 1.1 to 3 microns. So they actually don't get deposited on the nasal cavity because of the turbulent flow as well as their inertia, the MMADs and the GSDs.
Fine.
Thank you.
Sir, may I ask a question, please?
Yes, yes.
I wanted to know what are the implications of the intranasal corticosteroids for sports person from the dope test point of view?
As I've said, that the systemic dope test is basically we want to test what is the systemic bioactivity of these medicines. Systemic bioactivity of the newer generation intranasal steroids are extremely low. Usually we test the systemic bioactivity by number of tests. Basically, one is the lower dose corticotropin test, where we use the 1 micrograms of corticotropin and see how much it has been actually caused the repression of the HPA axis. Second thing is that the detection of these drug molecules in the blood. If you see these highly lipophilic molecules like the fluticasone propionate or the mometasone furoate, they have very wide distribution in the body because they're lipophilic. So their concentration in the plasma compartment is very, very, very low, almost negligible. And these drugs gets distributed mainly in the tissues because of its lipophilic characteristic. So actually, for any individual or a sports person who are undergoing a dope test, actually number one is that it's in micrograms, its systemic bioavailability is low, number two, and number three is that being a lipophilic, it is majorly into the tissue compartment, not in the vascular compartment. So it is below the detectable ranges, which is almost, it cannot be detected in the dope test, so it can be safely used in the sports person as well.
Thank you, sir.
Then if there is no questions to close this, thank you. Thank you very much.
Thank
very
you.
much.
Thank you.
The next topic is on biological drugs in management of allergic diseases, for which I would like to invite Dr. Leena Dhande Madam to deliver a talk on it. Dr. Leena Dhande Madam is Associate Professor in Department of Pediatrics, Indira Gandhi Government Medical College. I welcome Dr. Leena Dhande Madam to deliver a talk.
Good morning, everyone. Today, I've been given a topic of a drug which I've not used. So let me make this confession forthright. Okay, but I think it is a very interesting topic and we all need to know because it is upcoming and it is the future. So what are biologicals? So WHO defines it as a diverse group of complex molecules which are produced somewhere on the cell lines or derived from various tissues of animal origin. And interestingly, this is contrasted against several other medications that are primarily having a chemical origin. So that is what makes these different, more complex, and more diverse. This includes several vaccines, growth factors. In fact, insulin was one of the first biologicals to be used in medical practice. Now we have the monoclonal antibodies, to which I'll be referring to in this topic. So which are the biologicals that we'll be talking of today, which are useful in allergy? We have looked at the target regions like omalizumab will be acting as an anti-IgE agent. Dupilumab will be acting as an anti-IL-4 receptor alpha subunit agent. Mepolizumab and reslizumab will be acting at the anti-IL-5 method. And anti-IL-5 receptor alpha is a target for benralizumab. Another agent in the pipeline is tezepelumab, which is the anti-thymic stromal lymphopoietin agent. Several other agents are in the pipeline about which they have got mainly coding names rather than any brand names. As we very well know from the previous deliberations, these are the important key players in allergy. I will not be talking about it too much because I'm sure all the other speakers have deliberated on it. However, important players, namely eosinophils, mast cells, innate lymphoid cells, ILC2, these are to be remembered by us as well as the T helper cells. So this is how allergy, the whole cascade, the whole drama is taking place. Post-sensitization by the allergen, the antigen presenting cell is taking it up, processing and presenting it to the T helper cells, which are in turn secreting, producing interleukin-4 and interleukin-13, stimulating the B cells, causing their maturation and making them produce IgE, which will be acting on the mast cells, causing the degranulation, and another complete cascade of secretion of various chemical mediators, which will stimulate the eosinophils. Here we have got the IgE, which is bound by the allergen, degranulating the mast cell, and again, in turn, producing various cytokines. So these are the sites of action of our various biologicals that we just talked of. It's a bit of repetition, but we'll look at it. The mast cells, which are releasing the IgE, omalizumab is acting on it and thereby blocking it and preventing it from causing the various events which are occurring downstream. Dupilumab is causing blockage of the receptor, which is attaching to interleukin-4 and interleukin-13. Mepolizumab and reslizumab are anti-interleukin-5. We can see them somewhere middle of the slide. Benralizumab is acting on the interleukin-5 receptor alpha subunit. And we have got the other agents, tezepelumab, etc. So talking about omalizumab, most of these monoclonal antibodies which are being used in our human beings, we have got a term humanized. So though they may be produced in, say, various cell lines belonging to various animals, however, certain units are attached to them, which makes them compatible and administrable and appropriate for administration in the human beings. Therefore, we use the word humanized in them. And monoclonal antibody, you all know the concept. So what omalizumab does is it binds the FC, that's a cellular fragment of the IgE, and thereby prevents it from attaching to the IgE receptor. We have to do a very careful selection of patient. The patient should have allergen skin test positive, should have significant number of exacerbations in the previous year, despite of high dose inhaled corticosteroids and long-acting beta-2 agonists. And the total serum IgE and the body weight will be fitting into the dosage range. Actually, each manufacturer has their own tables as per the studies which have been conducted. And in that, there are zones in which the patient has to fit into. If he doesn't fit into those zones, then he may not be eligible for being given the medication. The dosage is again as per the tables, depending on the IgE and the weight category. Every 2 to 4 weeks, it is to be given subcutaneously. The duration is a minimum of 4 months. It is generally extended to a year or so. So what do we observe in studies? It is seen that omalizumab is causing a significant reduction in the number of severe exacerbations, up to 59%, and a 41% decrease in the use of maintenance oral corticosteroids and improved quality of life. This drug is also recommended by certain agencies, we'll come to that later, in the nasal polyposis, and there are improvement in the subjective and objective outcomes. There are certain adverse drug reactions, however, they are very minimal, mainly related to injection site reactions, and sometimes, very rarely, anaphylaxis. Now, how do we predict whether this drug will have a good effect, a good response in our given patient? So it is observed that children who are having asthma, which is uncontrolled, they are more likely to respond in a favorable manner as compared to older individuals, adults. And allergen-driven symptoms are found to respond very well to this drug, omalizumab. Looking at what are the guidelines for use in various countries, they differ. FDA has approved this drug for use in children. These are the age categories. If you're talking of severe allergic asthma as an add-on therapy in children more than 6 years of age, in chronic rhinosinusitis with nasal polyposis who are not responding to the INCs if they are more than 18 years of age, and in children with chronic idiopathic spontaneous urticaria not responding to antihistamines if the child's age is greater than 12 years. So the studies have not been conducted as yet in younger individuals. So FDA does not approve as yet for those age categories. But as you will see in India, they are not yet approved for use in children and studies are ongoing. Therefore, if we at all use, it will be an off-label use with all the issues. Still, in adult patients in India, this drug omalizumab has been recommended by the DCGI for use in moderate to severe allergic asthma, chronic rhinosinusitis with nasal polyps, and chronic idiopathic spontaneous urticaria. Mepolizumab, this is an anti-IL-5 humanized monoclonal antibody, as I already said. FDA has approved its use in children greater than 6 years of age with severe uncontrolled eosinophilic asthma as per the standard definitions given by GINA and other guidelines as an add-on therapy. So as you can see in the various slides that will be following also, the role is mainly as an add-on therapy for the biologicals. May also be used in eosinophilic granulomatosis with polyangiitis and hypereosinophilic syndrome, as well as in chronic rhinosinusitis with nasal polyposis. The dose, if the child is greater than 12 years of age, it is around 100 mg subcutaneously every 4 weeks. And in children 6 to 11 years, It is 40 mg subcutaneous every 4 weeks. Eligibility criteria for this drug: exacerbations of a significant amount in last year, as well as the patient being uncontrolled on the conventional therapy. Eosinophil count above locally specified levels. It may be 150 for some regions, 300 per microliter in another regions. The duration, at least 4 months, as I already said. These drugs have got a gradually graded effect, and therefore we cannot expect a get up in the morning and you'll be okay type of effect. So we have to be very patient. At least 4 months, you can extend it to 12 months or longer. Approved indications in India in adults, not for children as yet, for HES and EGP. Reslizumab is the next one in the line. Again, an anti-IL-5 humanized monoclonal antibody. It is recommended for use rather in children, in patients, adolescents greater than equal to 18 years of age. And those children who are having severe uncontrolled eosinophilic type of asthma as an add-on therapy. The dose being 3 milligram per kg IV infusion every 4 weeks, and eligibility criteria as documented here. Again, duration at least 4 months. Approved indication in India, none at all. Benralizumab, anti-IL-5 receptor alpha agent, 30 mg subcutaneously every 4 weeks for 3 doses, then every 8 weeks. So they have got a particular schedule to be followed. It has been approved by the FDA only for children greater than or equal to 12 years of age with severe uncontrolled eosinophilic asthma as an add-on therapy. Eligibility criteria: significant number of exacerbations, no response to the conventional therapy, and eosinophil count above locally specified levels. The duration, again, more than 4 months. There's something interesting about this drug. It is seen that there is an increased risk of infections, which is observed in the patients who are put on benralizumab, which could possibly be due to autoantibodies. In our country, the DCGI has approved its use in adults, however, not as yet in children. Dupilumab, anti-alpha receptor antagonist, that is humanized monoclonal antibody, as I told you, and it is useful in the severe uncontrolled eosinophilic type as well as type 2 asthma. So both the categories this drug can be used in. Those children who have got type 2 biomarkers above specified levels, severe exacerbations in the previous year, and requirement of maintenance oral corticosteroids is crossing the limits. These are those who are eligible for the use of this medication. The outcomes people have seen in their studies that up to 56% reduction in severe exacerbation, and nasal polyps, the size is decreased, as well as the requirement of surgery is decreased in these patients. As I said, other indications are CRWNP as well as severe atopic dermatitis. Good response is predicted by higher side blood eosinophil counts and higher fractional NO. It is not recommended to give this drug Dupilumab in children or patients who are having eosinophil counts going very high, more than 1,500 per microliter. There are no indications for use of this drug by DCGI in our country. Tezepelumab, another drug, as I said, coming up, it is acting on the thymic stromal lymphopoietin. And in the FDA GINA guidelines, all these say that this can be used in children who are more than 12 years of or 12 years of age in a dose of 210 milligrams subcutaneous every 12 years. That is a typo. The duration for 4 months at least. Eligibility: severe exacerbations in the last year. 30 to 70% reduction in the exacerbations has been observed in various studies, and higher eosinophil counts and FeNO predict a good response. So in a nutshell, GINA says that you can use these drugs for particular indications, age-wise. I've just put it down here. Now, how do you decide how to discontinue these biologicals. We have already started them. So it is not a good idea to stop them all of a sudden. If there's a good response, then it's a good idea to continue for at least 12 months and then taper down slowly. If it is stopped suddenly, despite of a good response in the initial phases, there's a likelihood of a relapse. If there is no response, then it is advisable to stop the medication. Are these biologicals? We have seen their profile, and we need to know whether they are really superior to the conventional therapy that we are using for management of allergies. The positive parts are that the frequency of administration is much spaced out. So every twice a week, every second week or every fourth week we'll be giving. So the compliance is much better. Improvement, significant. We have seen the studies which have shown that there is significant improvement. There is negligible interaction with other medications which are used in the various allergies. So it can be used as an add-on therapy where conventional therapy is failing, very high doses are required, or toxicities are developing. One very important point that comes to our mind is, can these biologicals be used as disease-modifying agents? So up till now, the research has not yet confirmed this. However, there is a thought in the research community that if these drugs, biologicals, are used in children, there's a good likelihood that it may have a disease-modifying agent. However, before such studies are conducted, we need to have a good enough confidence about the safety profile of these drugs. So up till now, we really do not know about the disease-modifying action of these drugs. What are the problems? Why are we so concerned about it? Why don't we go for it if they are so good? The first thing is that the cost is extremely prohibitive, and the exorbitant cost can be looked at in some way to be balanced out by the duration of treatment, the amount, the number of drugs required, the number of hospital visits, the wages lost, and other things which will probably balance out the cost effectiveness profile of this drug, of these drugs. The relapse of symptoms on stopping the agent is another thing which really is disturbing. How long can we keep giving the medication? Now, are these biologicals safe? We've been touching upon this point in the individual drug profile. Over here, in a nutshell, we can see that there are very few adverse drug reactions, just injection site reactions or anaphylaxis on a very rare, very low % way. But we must remember that some of these medications can result in appearance or manifestation of newer allergies as well as infections. Conjunctivitis is a very peculiar phenomenon seen in 14 to 19% of children on Dupilumab. In a nutshell, again, if you're talking of India, if you're talking of children, and we are looking at the DCGI approval, then none of these medications have been approved as far as my latest review of literature goes. I'm open to correction. We have got stalwarts sitting here. Studies are underway at various stages in varied populations, various age groups, pregnancy, etc. So the things are in the pipeline as yet. Another concept is about the biosimilars. How different are they? Yes, I'll be finishing soon. So biosimilar drugs, these are very similar to the reference biologic product that we'll be talking about with regards to the mechanism of action, whatever dose you're administering, the strength, efficacy, as well as the safety. This is how it is similar. However, they may be having certain minor differences. That is why we do not say that is the same drug, we say that it's a biosimilar. Another important point on which the biosimilar is similar to the biologic is that there are extremely stringent manufacturing norms which are followed for the biosimilar manufacture as just similar to what we are doing for the actual reference biological product. So how these biosimilars are useful? They cut on the cost, thereby increasing the access to patients. And also due to that, patients have wider options. Different companies offer at different rates, so they have an option to choose. All the same, we have to remember that being a biosimilar, the company, whoever is the manufacturer of the biosimilar has to take permissions with due respect to the patent as well as the intellectual property regulations. So these are my references. It's open to questions.
Thank you, madam, for delivering and highlighting on these biological drugs. Open for questions. So if there are no questions, thank you. I will invite all the speakers of this session for group photograph to please come on stage. Dr. Abhishek sir and Dr. Saibal Mohit to join.
So please, I request our chairperson also to please come over the stage for a group photo. Dr. Praveen Page sir, Dr. S. Manzir Ali, Dr. Rishi Lodaya sir, and Dr. Abhishek Madura, Dr. Saibal Moitra, and Dr. Leena Dhande ma'am. Thank you so much for a detailed session about drugs in allergies and asthma. Thank you. And we would request our speakers to get their mementos from the registration counter at the first floor. I also thank our chairpersons for chairing this session. Thank you so much. Now, heading on to our next session, that is a panel discussion on food allergy, for which I invite our moderator, Dr. M. Surendranath sir. I invite our panelists, Dr. Narayan Reddy sir, Dr. Nafeel Abdul Majid sir, and Dr. Mangaya Kashi ma'am.
Good morning, all of you. At the outset, I thank the organizers, Dr. Rajkumar, Dr. Vasant Kalatkar, Dr. Sukumaran, Dr. Jose, for giving this opportunity to discuss food allergy panel. In fact, this session should have been moderated by Dr. Soumya Nagarajan from the Bangalore. I was also one of the panelists, actually. Because madam was sick, she could not come to Nagpur. So she has requested me, maybe because of the seniority as per the age. So she has asked me, in fact, that is the advantage of having gray hair above 60 years. I think. Thank you for this opportunity. So now we are going to discuss about the food allergy, or just I'll introduce our panelists. Dr. Narayan Reddy sir. He is a professor of pediatrics from Hyderabad, and he is professor of pediatrics at the Deccan Medical College, and he has completed his fellow in allergy and clinical immunology from Savita University. And he has been teacher for undergraduates and postgraduates since almost 30 years. There are more than 30 publications and the research papers. And not only that, he was a central AOP member in the past, and he was the one national coordinator for the, I think, a CADE module last year, which was rolled out all over India. And he was also president of Pediatric Academy of Twin Cities branch of IAP, and he was vice president of Telangana State. And our next panelist is Dr. Mangai Sinha, who is from Mumbai. And presently she is pursuing the fellowship in allergy and clinical immunology. And she is a consultant pediatrician, assistant teacher, honorary, Navi Mumbai Medical College, Nerul, Navi Mumbai. And her interest is allergy, immunology, and adolescent medicine. And she has contributed a chapter for the care of the children in skin allergies in the last year Piyush Gupta's action plan of IAP parental guidelines. So our another panelist with a young, dynamic Nafil, who is from Kerala. He is a consultant pediatrician and allergist at Padmavati Medical Foundation, Kollam. And he is a consultant in skin and hair clinic in Trivandrum also. And he has completed his fellowship of allergy clinical immunology from Savita University. And he was a national faculty and faculty for most of the allergy modules and the state conferences. So with this introduction, we will go for the aim of the discussion. Most of the slides are made by Soumya Nagarajan. So in fact, I have little modified the flow of the events and little modified the case scenarios. So in this discussion, we will try to understand what constitutes a food allergy and spectrum of food allergy, case-based discussion we'll have, and how to identify different methods of allergy testing for the food allergy, and how to counsel the parents whose children are having a food allergy, and what are the principles of management, and finally some food for thought. So we all know that food allergy, most of the foods, the 8 foods which are very important as far as food allergy is concerned are peanuts, tree nuts, fish, shellfish, eggs, milk, wheat, and soya. These are the 8 foods which are, most of the times the food allergy is around these 8 foods. And as far as the mechanism of food allergy is concerned, Leena madam has beautifully shown the slide of how the allergy develops in the previous lecture. When an antigen enters into the body, it can be recognized and then TH cell line will be activated where IL-4, 5, IL-15 are necessary for production of IgE. And in turn, this IgE sits on the mast cells. Whenever some food with antigen is taken, then they directly go and stimulate the mast cells. Mast cell release will cause the food allergy symptoms. So most of the food allergy symptoms may be systemic or a local manifestation may be there. So any system may be involved, respiratory, skin, GIT. Any system can be involved in the food allergy. So the manifestations of food allergy may be very different. And not only that, they may be, sometimes it is difficult to pinpointly say whether it is a food allergy or not. So what are the food allergies in different groups? If you see in infants, the 4 foods which are most common are cow milk, soya milk, protein, and wheat flour. In the preschool children, usually the nuts will come along with the chocolates. And in the school children, the seafood also joins the food allergy group. And for the adolescents, so most of the seafoods, eggs, and not only that, the pulses also come into the picture, lentil and some of the cereals, and can cause the food allergy in the adolescent age group. So coming to the first question, what is the incidence of food allergy in children? Nafil, can you take this question?
Yes, sir. Like we all know that the food allergy is completely
Not audible.
Mike. Yeah. Am I audible? So if a single parent is only involved, the incident of a child getting allergic is around 40%, 30 to 40%. And if both the parents are involved, it's close to around 75%. And if the parents are not involved, both the parents are not allergic, then it's around 10, 15%. This is what study says.
So most of the times it is runs in the family. There may be hereditary factor associated with the epigenetics of the environment also. So what are the risk factors of getting food allergy in children? Dr. Narayan Reddy, can you take this question?
Good morning, everyone. Thanks the organizer for giving opportunity. And the risk factors are many. Of course, so males are more common than females, and Asian, black, and whites also. Family, of course, there is a genetic predisposition. Any disease, the genes are important. Both parents are involved. The 70, 80% the children are going to have. One parent is involved, 40, 50%. So only 10-20%, then no parents are involved. The family also important. Alter microbiota, gut is very, very important because first, like a brain development, first 3 years life, gut develop microbiota. If it's a healthy microbiota, the less chance to develop allergy diseases. That's why, unfortunately, most of the people are given unnecessarily antibiotic. And also, there are food habits. Breastfeeding, only unfortunately, exclusive breastfeeding, only 47%. Because bottle feeding and westernized food, this changes microbiota. That is another important factor. Of course, atopic dermatitis, as you know, skin is porous. When most of the allergens enter the skin, like dual hypothesis I said, when we same antigens, food goes to GIT first year, the tolerance develops. Same food goes through skin, they develop sensitization allergy. That's very important. Atopic dermatitis children are more prone for food allergies. Vitamin deficiency is proved. Deficiency vitamin, definitely they're more prone for allergic diseases. Reduce consumption of antioxidants and omega-3 fatty acids. Again, junk foods, westernized food, definitely it causes more allergy. Of course, obesity, children more prone for asthma. Thank you, sir.
Thank you, Naren Reddy, for excellent. What are the risk factors? What are the food allergies? Why do you think the food allergies are increasing, Dr. Mangai? Can you take? Because nowadays we are seeing the more of food allergies compared to the previous generations.
Yeah.
The newer generation are more exposed to the allergies.
Good morning, everyone. Rightly said, sir. Food allergy, like any other allergy, is increasing. My answer would partly overlap what Dr. Reddy sir said. Food allergies have been on an increase because of the modern lifestyle that we all have been adopting in the last few years. Urbanization that has taken place and westernized diet, where we have a lot of processed foods, which are very poor in fiber. Losing touch with our own culture or our own home-based food, including a lot of fruits, vegetables, and yogurt, curd, which we all know is very good. There's also the hygiene hypothesis, which we all are aware of. So the decreasing in infections has tilted the balance towards the Th2 pathway rather than the Th1 pathway. And so we are seeing more of allergies because of this. Also extensive deworming that has happened. So the old friend hypothesis, which is also another factor. Increasing incidence of cesarean sections, increased incidence of formula-fed babies, just like sir said. So the protective breastfeeding is no longer available, which is protective against food allergy. Also in the recent years, increased indiscriminate use of antibiotics, which completely alters the protective gut microbiome. Along with this, obviously, vitamin D insufficiency has some role to play. Extensive use of proton pump inhibitors, increased packaged food consumption, which has a lot of preservatives, additives, and coloring agents. I would also like to add one point that in a study conducted recently, where India and many other countries were involved, sensitization to the common food allergens in normal population, not the allergic population, in normal population is high to the tune of 26%. So if we don't really do something to alter this or change this, very soon we will be seeing an impending food allergy.
Thank you. I think maybe in the future we are going to see more of epidemic of food allergies compared to the infections, because the infection rate has come down. The chances of skewing the immune response to the Th1 is slowly changing to the Th2. So that may be the reason that allergies are increasing, not only other allergies, food allergies are also. Thank you, madam. So with this preliminary discussion about the food allergies, now we go to the case scenario, because to discuss entire food allergy, it is impossible in 40 minutes. So we will see some of the typical cases of food allergy and discuss how to go about these cases and how to go about the management of these cases. Dr. Nafil, can you take this case? 15-month-old girl having a diarrhea till almost more than 3 weeks in the previous month, which was followed by the mother has started avoiding all the milk products since 1 month, as she feels that child is having allergy to the milk. That's why she stopped feeding with the milk. And she was also advised by the practicing pediatrician to stop the milk feeds because the child was having a protracted diarrhea. And mother strongly feels that all the symptoms are due to the milk allergy. So what is your comment?
Sir, with this much being said, first of all, we have to think what the child exactly has. As an allergist point of view, we have to first differentiate what are the types of allergy the child can get. So coming to the allergy point of view, we have food allergy also and food intolerance also, and that is immune mediated. And we have in non-immune mediated, we have only like non-immune, like in immune mediated, we have food allergy, which can be IG and non-IG mediated, and we have food intolerance. We have to differentiate based on the symptoms, based on the clear-cut history. The child, when the child is getting symptoms after having the food, like if the mother is giving milk, it's talking about the milk. After taking milk, the child is getting diarrhea, sir. If it is food allergy, the response will be very sudden. Like onset will be around minutes to hours. And in intolerance, like it will be around hours to days it takes for the symptoms to happen. And in food allergy, that will be like the patient will be having symptoms like pruritus, urticarial type of rashes, and of course the gastric symptom like GIT symptoms also can be there. But in food intolerance, mainly gastrointestinal symptoms will be more. And one of the main differentiating features based on history, it's like when the child, like if it is food allergy, every time the child is getting, baby will be getting sick by diarrhea if the mother tries to introduce milk, and even minimal quantity of milk or any product which the child is allergic to, the child will be getting symptoms. But in intolerance, a bit more quantity, it's more quantifiable actually. Like the child should get more quantity should be given to get allergic to, and it is easy to prove it is allergic. And intolerance, it's again, it's differentiating. Like we have to stop, we have to wait for like 1 week or more for proving it is intolerance.
So as per Nafil, there are two kinds of food allergies. One is the IgE mediated and one is a non-IgE mediated. IgE mediated can be immune mediated and non-immune mediated. Immune mediated can be IgE mediated or non-IgE mediated or a mixed or a delayed hypersensitivity reactions. So non-immune mediated food allergies are known as food intolerance. They are not food allergies actually. The intolerance may be because of the metabolic product which is there in the food, like a protracted diarrhea in this child can be a lactose intolerance. It may not be exactly food allergy, it may be a lactose intolerance also. So this type of non-immune mediated food intolerance is entirely different from the food allergy. And there are certain toxic substances also can cause food intolerance. So Nafil has nicely brought out what is the difference between food allergy and food intolerance. So you have to differentiate whether it is a food intolerance or a food allergy. Allergy is always associated with the immune mediated mechanism will be there. Whereas intolerance, there will not be any immune mediated mechanism. So I think you have brought out very nicely all the differences. So you have to identify whether this child is having a food intolerance or a food allergy. So you have already told that IgE mediated usually presents with quick tests, anaphylaxis sometimes, and well-defined immune mechanism are relatively early to diagnose, tests are valid. So we have already discussed all these points. So by definition, food allergy is adverse health effects arising from a specific immune response, and occurrence is reproducible on giving the food. So by definition is this one. So what is the learning points from this case of protracted diarrhea or food allergy or a food intolerance? You have to differentiate to give a correct treatment. But even for food intolerance, to reduce the symptoms, maybe you have to avoid the food. There are different types of food allergies, IgE, non-IgE mediated. Advise the patient and family depending on the accurate diagnosis. When you diagnose it properly, then only you will be able to advise them properly. So you have to differentiate food intolerance from food allergy. And coming to the Narayana sir, so we will take another case, similar case in fact. So this is a case of 4-month-old baby, Nandita, born by emergency LSCS due to the fetal distress. And she was given formula milk in the first 2 days. And now after some time, now the child is exclusively breastfed. Most of the time child is doing well, but very cranky after taking the milk. No vomitings has been reported. There is occasional mucus in the stool, increased frequency of the stool since the last 10 days. Occasional blood streaks, received courses of antibiotic few days back with no effect. So what do you think? This is the case of
There's a 4 months old child born LSS. LSH are more for allergy disease. Started formula feed beginning. And child thriving very well. And only blood streaks are there. He received antibiotic also. So unlikely to be infection. So it is a more probable allergy. Allergy may be because it's not food into proctocolitis. It is because there's a farm stool, blood streaks are there, healthy child, active child. Cranky may be infantile colic like. So there's so many types of food into proctocolitis, enterocolitis. Enterocolitis is acute, they have vomiting, diarrhea, sick looking, dehydration, maybe acidotic breathing, failure to thrive. But in food into enteropathy, they have only diarrhea, they have failure to thrive, edema, hypoproteinemia. But here child is active, healthy, doing well, breastfed child. Most probably it is a food into proctocolitis. It's a very transient, very transient. So where we have to, mother is on, advise mother to avoid protein, the particular milk containing food products should be avoided mother particularly. So then definitely child will be all right. If child is on top feed, so then definitely we have to give extensive headless formula. In this child, if you avoid the mother, ask the mother to avoid milk products, definitely child will improve. It is only transient.
So a child can present with a diarrhea, sometimes occasional blood-stained streaks. A well child with who is on breastfed. So it is very unlikely that child will have a cow milk protein allergy because the differential diagnosis is CMPA is one of the things. Another thing is food protein induced proctocolitis, which is a benign condition. In fact, once you stop the milk feeds of the mother, usually the child will recover very well, diarrhea will reduce. Suppose if it is a cow milk protein allergy, what do you think, Narayan Reddy? I mean, how to differentiate a cow milk protein allergy from protein-induced
It's a cow milk protein allergy, particularly if it's IG, non-IG. So IG definitely they have multi-system involvement, respiratory involvement, skin manifestations. So most of it is a non-IG mediated. Non-IG mediated differences only history only and avoidance of milk products, they'll improve. After 4 weeks, reintroduce again milk product, they will again they have symptoms. That is the only confirmation. So rarely you do endoscopy and biopsy.
So if it is a cow milk protein allergy, most of the times it is a IgE mediated where multi-system involvement will be there. Skin involvement, respiratory involvement, and GIT involvement will be there. If it is only food protein induced proctocolitis, mostly confined to the GIT symptoms, which is a non-IgE mediated. So that's how we have to differentiate whether it is IgE mediated, non-IgE mediated, so that your management entirely changes and your counseling also changes depending on the case. So most of the times, cow milk protein, most of the symptoms are diverse. Usually the reactions will be very early and delayed reactions usually suggestive of non-IgE mediated mechanisms. So this is what Dr. Narayan Reddy was telling, food protein induced allergic proctocolitis in infants. Can you highlight it, Narayan Reddy? Anything else you want to add to this one?
This is a food protein proctocolitis is very benign. They have the healthy child. They will transient. Food protein enterocolitis very sick. They present with acidosis, vomiting, diarrhea, and shock. So it becomes an emergency. They may think of the sepsis how to roll out. They have to give IV fluids, restate the child. Most of the time they respond. Of course, where if the child is on top feeds, where you have to advise, particularly extensive headless formula. Most of the time they respond very well. If a child is on breastfeed, so advise the mother to avoid milk products. Very important. Okay. In role of other milk, no, there is no role of other milk. They are cross reaction. So all milk should be avoided. Only continue breastfeeding. Mother should avoid milk products, like even biscuit, chocolates, other ice cream. All milk products continue. Mother should avoid. definitely the dramatic improvement will be there.
So this particular case, definitely it is looking like cow milk protein allergy, but it is more likely to be food protein induced proctocolitis. Complete elimination of cow milk protein in the maternal diet. Diagnostic elimination of cow milk protein may take up to 4 weeks to appreciate the clinical response, and maintain an elimination diet for 6 months or at least 9 to 12 months of age. Usually by that time, child responds very well.
But particularly non-IG, they will improve. So after 6-12 months, definitely they develop tolerance. But IG will take more time.
Now we come to the third case. I think the differentiation is very important in the previous case to identify whether it is allergy associated with IG mediated, non-IG mediated. Okay. Coming to the next case, Abhay, a 5-year-old child, first of the 2 siblings, and he has a history of allergic rhinitis and wheeze previously. And he had episodes of breathlessness, urticaria, angioedema of the eyelids and the lips, vomitings, pain abdomen soon after eating a chutney for the first time at the age of 2 years. Okay, so this is the case. Dr. Mangai, can you take this case?
So this is a 5-year-old boy with definitely a personal history of allergy. He's had a history of allergic rhinitis and wheeze. And there is a history suggestive of very severe allergic reaction to chutney or one of the ingredients of the chutney when he was 2 years old. So this is anaphylactic reaction. Probably he's had a very severe anaphylaxis to one of the ingredients of the chutney at the age of 2 years.
So what do you think, it is IG mediated or non-IG mediated?
So it is IG
Obviously,
mediated because it's an immediate.
Yeah,
Yes.
the multi-system involvement is there, and the immediate reaction following the taking the food is suggestive of IG mediated. So what was the treatment advised for this child?
Here I would advise the mother to actually follow up and try and pinpoint, like to meet up with an allergist and try and pinpoint the exact ingredient in the chutney which would have been the culprit in causing anaphylaxis. What is also important is to properly counsel the mother that this identification is important. Also to tell her how severe this reaction was. It could have even been life-threatening at that moment. So to really work up the child, to investigate the child, take a detailed history to find out other associated factors which could be there along with it, and to do specific tests, identify the culprit, and then advise the mother to avoid that ingredient in future. Also, like all the lectures that we had yesterday, to always keep adrenaline, a loaded adrenaline with the child, with a note telling what he is allergic to, because it's a 5-year-old child. So the child will be going to school, there he would eat, he could get an anaphylactic reaction anywhere. So that time the caregivers, the teachers, everybody should be aware of how to give the adrenaline also.
And he had a previous history of allergy because of taking peanut butter. Now it is identified that maybe a peanut allergy.
Peanut allergy.
So
Yes, sir.
how do we diagnose these cases? SPT will be helpful?
SPT also will be helpful, but not immediately after an anaphylactic reaction. We could do that after 3 weeks. Here we could do serum specific IgE to peanut.
So this is an anaphylactic reaction for a food allergy which has been should be treated immediately as soon as possible. The allergic reaction comes, otherwise there will be a high amount of mortality will be there if it is anaphylaxis, definitely. So this is what we have already discussed, that how to counsel this child. Take a detailed history of food allergies, and serum specific antibody test or SPT can be done to pinpointly say that what is the allergen. Avoidance of allergen, and all the food should have what is the content of the food material, what are the likely content of the food material which can be allergic, and always should be a loaded adrenaline should be there in these children. Sudden exposure to the food material can lead to the anaphylaxis. So adrenaline is very important as far as treatment is concerned. Counseling and training of the caregivers, as Madam told, keep the school teachers informed about this incident. So, yeah, you can carry on.
It's anaphylactic. This child has had an anaphylactic reaction to peanut, most probably.
So how do you manage the anaphylaxis? I mean, these anaphylaxis has been discussed very well with Vikram Patra. Just you can highlight few points how to tackle these cases of IG-mediated food allergy, which presents as an emergency anaphylaxis.
Anaphylaxis is a medical emergency. It's been really discussed, and all the seniors have been highlighting mainly on the point of to give adrenaline. I would really like to emphasize that even if in doubt, please give adrenaline. An extra dose of adrenaline would do no harm to the child, but not giving adrenaline at the appropriate time or waiting or buying some time to see whether the child settles, that would prove to be fatal. So give adrenaline, even if it is not anaphylaxis, it will not do any harm. So this is the point which was emphasized yesterday. It will be, I am also emphasizing on it. This is the actual management, but like we all know, adrenaline once, it could be repeated after 10 minutes and again after 10 minutes. So 3 shots of adrenaline can be repeated. If still there is no resolution, then IV adrenaline drip could be started. All this has to be done simultaneously, taking care of the position of the patient and also taking care of the ABCs of resuscitation.
I think anaphylaxis is very well discussed yesterday. So we will skip this detailed discussion about the anaphylaxis. And this is what Vikram Patra has told us today.
This is what we are from the same branch in Navi Mumbai, and this slide has been extensively circulated. In fact, all of us in Navi Mumbai, not only allergists, but all of us are now carrying such preloaded 1 cc syringes with pre-marked labels for kids and adults. And such syringes, we keep it in these spectacle box, and the date is written when we have prepared. This can be very safely kept for 3 months, and it is extremely essential. Like Dr. Patra said yesterday, we never know when anaphylaxis will come knocking, and that time it will not give us any time to prepare or load or anything. So always be prepared.
So this is a Deshi EpiPen. We can call it as a Deshi EpiPen, definitely, because EpiPen is not yet available in the free market. So we can modify the EpiPen and keep the adrenaline like this.
Till we get our own indigenous pen, like as promised by Parmesh.
Okay. Like Nafil, another case. This is a different presentation. So 10-year-old child develops swelling of the lips, itching of the throat whenever he takes apples or some fruits which are not washed properly. Is it a food allergy?
So as we discussed before, any case which comes to us as an allergist, first thing what we emphasize is on the history actually. When the symptoms started, every time after taking the food, you are getting these symptoms or not. All these things, first of all, we have to ask. In this particular case, the child is not having symptoms anywhere, no sir. It is only confined to the oral cavity. So it can be like that to a vegetarian food, that is fruits and vegetables. Like he took apple, no. So it can be an oral allergy syndrome. This is a new term actually. Oral allergy syndrome is something which the child or an adult can get symptoms due to the child may be allergic, not allergic to apple, but the child will be allergic to any other inhalant allergens like pollens or something. And due to the cross reaction between these allergens like pollens and the something found in the vegetable or fruit, the child will be getting localized reactions confined to the oral cavity, mainly pruritus and mild edema of the oral cavity. This is called as oral allergy syndrome. As such, there is no treatment required for this, only just symptomatic treatment, and it's not life-threatening. And main allergens which we found, people who get is birch pollen and grass pollen and ragweed, all have cross-reactivity to certain foods like apple, pear, carrot, and also.
Yeah, thank you, Nafil. Yes, definitely it is a cross reaction, not an allergy associated with the fruit itself. So it is a cross reaction because aeroallergen sensitization leads to the cross reaction. Some of the pollen which has entered into the respiratory tract make him hypersensitive. So whenever he takes a raw vegetables or fruits, a local reaction of swelling of the mouth and the lips may be seen, which is known as oral pollen syndrome. So don't label him as allergic to the apple. He may not be allergic to the apple, but
we'll tell them to avoid
he's
actually.
yeah, he has to, because there is some cross reaction with the other pollen, so you have to tell them to avoid such thing. Okay, this is the oral pollen syndrome. And Dr. Narayan Reddy, a 5-year-old child brought to the pediatrician's clinic with severe atopic dermatitis, which disrupts the child's activity and the sleep. And mother is not sure if any food is triggering her symptoms, and she wants to get an allergy test done for this child to identify whether the food is causing the allergy, whatever symptoms she is having on the skin.
Because in atopic dermatitis, the food allergy is exaggerating factors. Even skin infection like bacterial, fungal, viral infection are the exaggerating factors. Because as I said, skin in atopic dermatitis is porous. The allergen enters through skin, the sensitization occurs. Same allergen goes with GIT, it will become tolerance. So we always suspect it is not responding to moisturizing or mild steroids. With child itching one, suffering, crying, like always think of food exaggeration, food allergy exaggeration atopic dermatitis is a very important point. Then we have to investigate, particularly common foods in children, infants, particular milk, egg, peanuts. So if you're not able to do skin prick test, you can do specific IgE. You can't do panel of foods, because if you do, because most children are sensitized, doesn't mean there's allergy. Whether 20-30, we get some panel of specific IgE outside lab, they will get 20-30 food allergies. Mother state says stop all foods. It leads to malnutrition. So only few foods, do important foods are milk, egg, peanuts. So if you do that positive, if mother avoid those food, definitely the dramatic improvement is there. If you avoid that particular food for 6 months, 1 year, definitely the dramatic response in atopic dermatitis, because they're not responding to routine management like moisturizing and mild steroids. So definitely you have to think of food allergy in the child, try to avoid those particular foods, and definitely there's a dramatic response, the quality of life improves. Atopic dermatitis.
As you know, yesterday there was a topic March discussion, was very good discussion was done by the Dr. Neeraj Gupta's panel discussion. Almost 30% of atopic dermatitis children may be allergic to the food. And not only that, the skin may be the entry of the food allergy. Later on, it may lead to the IgE mediated food allergies. So treatment of atopic dermatitis is very essential to prevent the food allergy. Atopic march can be curtailed if you treat atopic dermatitis properly. Even the future food allergy can be prevented. As Narayan Reddy told that sometimes food itself can cause manifestations of the skin as a dermatitis. So try to avoid those foods. Not only that, atopic dermatitis, at least some of the antigens, some of the food material has to be done. The test has to be done, as he just already mentioned that most commonest foods are egg, peanuts, and food corroborative history. If it is there, definitely these children should be suspected for the investigation. One more case, Dr. Mangai. This case, we have 5 minutes only. I think you be brief as far as the discussion is concerned. So he is 80-year-old child who has developed cough, breathing difficulty while playing at the school. And this happened immediately after the lunch break. And he was brought to the ER about 2:30 p.m. No past history of asthma and allergy. And there was history of similar complaints noticed by the mother 1 month back after taking chapati while playing at home and treated locally. On examination, child is dyspneic, respiratory rate is 60, SpO2 80, and chest bilateral wheeze is there. What is the possibility?
So this is a 8-year-old boy who's had an severe allergic reaction. There are 2 factors that are here, and this mother very nicely has noticed that after some activity and after having food, this is food dependent exercise induced anaphylaxis. Here, as the name goes, there are 2 factors that are important to cause anaphylaxis. One is a food, which will be the triggering factor, and exercise or any exertional activity done within the next 4 hours, which would lead to anaphylaxis. Food is one of the triggering factors. Most important is gluten. The others are lentils, prawns, and milk, which is there. the diagnosis is mainly a detailed history. Here the mother noticed, otherwise if when faced in practice, we would only talk about anaphylaxis, and here is a role of a detailed history of what activities the child did, what are the associate factors, did the child have any drugs which could all trigger this food dependent exercise induced anaphylaxis.
Yeah, this is a food dependent exercise induced anaphylaxis. So this sometimes we have to suspect whenever the child has taken some chapati, gluten food, followed by immediately after taking the food, if child does an exercise, goes into a bronchospasm or signs suggestive of anaphylaxis. So you have to diagnose food-induced food-dependent exercise-induced anaphylaxis. So coming to the treatment part, she has already highlighted that adrenaline is one of the mainstay of the drug for these children, and you have to instruct the mother in future. A child should not do any exercise after taking the food. At least they should avoid the exercise during the first 4 hours.
First 4 hours.
So coming to the end of today's discussion, we have only highlighted what is food intolerance, what is IG-mediated food allergy, non-IG-mediated food allergy, and some of the cases are associated with food allergy have been discussed. So as far as the management is concerned, can Narendra, can somebody take this slide and explain how to go about the food allergy?
So food allergy, particularly, main thing is history, sir. History is very important. And where if particular food is suspect, you give skin prick test, and you can go, or you're not able to skin prick test specific IG. So when if you confirm food, main thing is not able to confirm, of course, oral food challenge has to be. Oral food challenge is important, sir. Then, of course, you have confirmed that, try to eliminate that particular food. And if you restart after 4 to 6 weeks, if you again develop reaction, it is 100% that food is causing. They can avoid for 6 months to 1 year. So after every 6 months, 1 year, you can start develop tolerance. That's very important. So confirm, and also food allergy. One thing is actually Vikram Pata said the anaphylaxis, epinephrine has to be loaded, preloaded in a spectacle cover, because epinephrine is a light sensitive. It expires 3 months. We cover it. If color change, you can discard it. We cost only 20-30 rupees. Because our epinephrine, our EpiPen cannot afford our children, our parents, because it's very costly. So our adrenaline very cheap. It can be preloaded, can be kept in school bag, at home, in school also. Parents will be sensitized how to use. And also counsel is very, very important. And food avoidance is very important, sir. Avoidance and food diary should be maintained. And whatever food child eats, should read the, particularly if allergen, better to avoid outside food. In party, gala, dinner, should not eat outside. To carry his own tiffin box.
Mother is worried that the child is having food allergy. Can he overcome the food allergy over a period of time?
Definitely, certain foods can be overcome, sir. Like a milk, egg, wheat can be overcome. And of course, certain tree nuts, fish usually persist 80-90%. Of course, component result diagnosis can be 100% can tell which food going to overcome. This is very important. So particularly milk, 80-90% by 4-5-6 years they overcome. They develop tolerance. Egg also for 5-6 years. And wheat also. But tree nuts, fish, they persist throughout life, almost 80-90%.
Thank you. Thank you very much for enlightening us. When the food allergy discussed, take home point, sir. Food allergy is defined as an adverse immunological response to the food. Referral to the allergist is important for appropriate diagnosis and treatment. Diagnosis of food allergy requires a detailed history with diagnostic tests such as SPT, food-specific serum IgE measurement. In some cases, oral food challenge test may also be required. Last slide, right? Okay, no problem. No, thank you.
Thank you, sir.
And management of food allergy should be done by the history most of the times. And as you all know that most of the food allergies may be, in fact, can be diagnosed with SPT or a serum specific IgE. Don't do food panels, as Narayan Reddy told. If you do a food panel, they will give almost 10 to 15 foods. Child is hypersensitive. Hypersensitivity doesn't mean that child is allergic to the food. So you have to correlate clinically, then only avoidance measures should be done. Thank you very much, sir. Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, ma'am. Ma'am, please be there for the photo. Okay, sir.
Food allergy, especially when it's causing anaphylactic type of a reaction. Don't you consider sublingual immunotherapy as a life-saving procedure?
Immunotherapy can be done, sir, if it is recurrent episodes are there. Immunotherapy, oral tolerance induction also can be done in some of the cases.
Then you can also consider doing prick-to-prick test.
Yes.
Yeah,
can be done, sir. That can demonstrate. Most of the parents say the banana nahi banta, wo nahi banta, ye nahi banta. I can demonstrate in front of the parent. Dekho, reaction nahi hai. Now mother can be confident to feed the child. Most of the histamine content the fruits may be causing some sneezing, cough, but it's not allergy. Most of the parents they avoid fruits. The fruits are very important, antioxidants, particularly fruits. Most of the parents banana nahi dena, apple nahi dena, wo nahi dena. So they think that's causing allergy. That is not allergy, sir. They have to demonstrate prick to practice in front of the parent. Tell that is allergy nahi hai. The parents are very confident to feed the child.
Especially as sir has asked, cow milk protein, cow milk protein is a transient phenomenon, sir. I mean, usually after 3-4 years, usually overcome the food.
But if it's causing anaphylaxis,
Yes.
then I think you should consider sublingual.
Yes.
Anaphylaxis, very important point, sir. That food should be avoided. Number one, epinephrine should be loaded, kept in the pocket, bag, at home.
Absolutely.
And cannot be avoided, of course, immunotherapy. That is the answer, sir.
Skin prick test for food allergy, a negative response has a higher predictive value than a positive response.
Yes, sir. Yes, negative, that is more important, sir, than positive. Positive means everybody sensitized, sir. If you do test, everybody sensitized. Doesn't mean there's allergy.
Yeah, don't go by food
Negative is
panels.
important. Negative is more value than positive.
Because most of the times in diagnostic centers, if you do a food panel, they will do almost 20-30 foods.
Should not do, sir. Should not
So
do.
it is-
You'll be everything positive. Mother start feeding everything.
Yes.
You are asking me for food panel only for milk, they will not
Yes.
agree. That is the practical difficulty.
And CRD diagnosis is important as far as to know whether this allergy is likely to continue lifelong or it is going to be
That
tolerated.
component result diagnosis is going to help. Which child, which food allergy is going to have tolerance or persistence.
Thank you.
Okay. Thank you,
very
sir.
much.
Thank you, ma'am. Ma'am, please, for the photograph.
Question, sir?
One panel discussion regarding introducing hyperallergenic foods early in life. Today, apparently you said something else. I'm confused. So,
No. If you introduce the foods, according to the LEAP study, by 4 months, the allergenic foods, if you already know the elder sibling or if there is a family history, that would lead to less allergy less development of allergy to that particular thing. But if you avoid and if you introduce it after 1 year, there are more chances that the child would develop allergy.
why and how?
The leap hypothesis, sir.
Hello?
They say, when
Sir,
if you start
excuse me.
early,
We can-
they develop tolerance. If you start late, they develop allergy. That is important because gut, the microbiota start developing first 1 year, 2 years. If you start early, allergen food early, they develop tolerance. That's important point, sir. Earlier to say, wo nahi khana, ye nahi khana, avoid milk, egg, you start
I
after 1-2
think
years. That is
this
wrong.
discussion can go on and on. So we have to keep
Thank
to
you,
the
sir.
time. Thank you very much.
Thank
The
you, sir.
discussions can be continued during the lunch hours. Thank you, sir.
Thank you, sir. Thank you, ma'am. Now I request our chairperson for the next session, Dr. Joginder Singh, sir, and Dr. Praveen Dahake, sir.
Good morning, everyone. Now, the next topic is eosinophilic esophagitis. The technology has made our life so easy that our speaker is sitting thousands of miles away at Lincoln, Nebraska. And his Dr. Vinay Mehta is from his allergic asthma immunology associate at PC Lincoln, Nebraska. His hospital privileges are Bryan Health and St. Elizabeth Regional Medical Center. His academic appointments are Chair, Division of Allergy and Asthma, Bryan Hospital, Adjunct Faculty, Department of Tuberculosis and Respiratory Disease, Christian Medical College, Instructor, Lincoln Family Practice, Instructor, Union College. So I invite Dr. Vinay Mehta. Good morning, sir.
All right, good morning. Good morning, everyone, and thank you for the introduction. And I would like to thank the organizers for inviting me to participate in this conference. So what I'm going to talk about is a condition that may not be well known, maybe in India, but it is something that's well known in the Western countries, and that is eosinophilic esophagitis. So let's start out with a case discussion. So 15-year-old male, adolescent, he presents with intermittent dysphagia to solid foods for the past year. So whenever he eats chunky foods, they tend to get stuck. It requires liquids to flush them down. And as a child, he would frequently experience nausea, vomiting, abdominal pain, especially after meals. And in fact, he was often scolded for being a slow eater, being a picky eater. He denies any history of reflux, odonophagia, no chest pain. Past medical history is significant for allergic rhinitis, as well as food allergy to buckwheat. He currently doesn't take any medications, and his physical examination is unremarkable. So, as a clinician, you with this clinical history, I think most of it you would agree. You would perhaps get a barium swallow. And so here's his barium swallow, and what you see here is there's diffuse the distal esophagus. There's quite a bit of narrowing, and then you also go ahead and get an endoscopy, and this is how his endoscopy looks. As you can see, the esophagus has concentric rings around, along with longitudinal furrows. So this is very abnormal, and when you get biopsies from the esophagus, you see a lot of eosinophils. So all these areas here, these are all eosinophils, and when you do the count, it's 50 eosinophils per high power field. And so the patient is diagnosed with eosinophilic esophagitis, and he started on proton pump inhibitor, omeprazole 20 milligrams daily, as well as swallow fluticasone propionate via meter dose inhaler, 220 micrograms, 2 puffs twice daily. So we'll continue the discussion about this case, but first let's introduce the concept here of eosinophilic esophagitis. So what is eosinophilic esophagitis? It's a chronic immune/antigen-mediated esophageal disease. It's characterized clinically by esophageal dysfunction and histologically by eosinophil predominant inflammation. And so in order to make a diagnosis, you need both symptoms and you need histology. And the current threshold is greater than 15 eosinophils per high power field. And so that is a clinical, that is a minimal threshold. Also, the disease must be isolated to the esophagus. In other words, if you get biopsies from the stomach and the duodenum, those have to be normal. And obviously, you have to rule out other causes of esophageal eosinophilia. And so, if you look at the eosinophils in the gastrointestinal tract, you see that normally in the esophagus is completely devoid of eosinophils. You should really have 0 eosinophils. Sometimes, if a child has reflux, you can see a few eosinophils in the esophagus, and that is because in the stomach you have about 10 eosinophils per high power field. So sometimes in a child with reflux, you may see some eosinophils, but it should not be greater than 15. And then as you go down the gastrointestinal tract, the number of eosinophils actually increase. So in the duodenum, it's common to see between 20 and 30 eosinophils per high power field. And then in the colon, you see a lot more, between 50 to 60 in the right colon and between 30 and 45 in the left colon. In terms of epidemiology, we know that eosinophilic esophagitis, at least the prevalence in the West, has doubled in the past 2 decades. It is currently estimated to be about 1 in 2,000 in Western countries. But it is not just confined to the Western countries. It is present in all continents, including India. I'm sure you have seen cases of eosinophilic esophagitis in your own population. But we don't have, unfortunately, we don't have good statistics for India. In terms of epidemiology, it is more common in males, 3 to 1. And in terms of in the general population undergoing endoscopy for any reason, you generally see it between 2 to 7% of the time. But if a patient is specifically undergoing endoscopy for dysphagia, then it is found in up to a quarter, up to 23% of patients have eosinophilic esophagitis. It's actually the most common cause of food infection. So if you have a child that has food infection, the most likely diagnosis is eosinophilic esophagitis. And it is a disease that can start at any age. Even infants as early as a few months can develop eosinophilic esophagitis. Now we'll go over the presentation. The presentation is different in children than in adults. But nonetheless, the disease can occur very early on. It's more prevalent in adults, but that may be biased because there's often a diagnostic delay of a few years before these patients are given the diagnosis. And as you can see, even in the elderly, you can see cases of eosinophilic esophagitis. So it affects all ages. And what is most important is that many of these patients, 3/4 of these patients with eosinophilic esophagitis, have coexisting type 2 inflammatory diseases. So allergic rhinitis is very common. So is asthma. So is atopic dermatitis, food allergies, and oral allergy syndrome. In fact, oral allergy syndrome is about 50%. So when a child complains that when they eat certain fresh fruit and vegetables, like banana, melons, apple, if their mouth itches, that's typically a sign of oral allergy syndrome. And this is often present in patients with EoE. So what are the symptoms? What are the clinical symptoms of EoE? The classic presentation is dysphagia, but this generally occurs much later in life. It doesn't occur early on. And once you have dysphagia, that's usually a sign that there is narrowing of the esophagus caliber. With dysphagia, if it's severe enough, you may have impaction. Impaction is where it completely walks off. The patient has to regurgitate the food. Even taking liquids won't help. Some patients also complain with chest pain. They may have reflux-like symptoms. In fact, many of them are treated with PPI therapy. And erroneously, they're told they have reflux. But that may not be the case. In younger children, oftentimes you won't see dysphagia, you won't see food infection, but you'll see abdominal pain. So this is a very common cause of abdominal pain in young children. It's also associated with nausea, vomiting, anorexia, early satiety. In extreme cases, it can be associated with failure to thrive. And then in adults, oftentimes they'll have a global sensation. They'll feel like there's something in their throat area. Now, in children, very commonly, these children will have coping mechanisms for dysphagia. So they'll deliberately avoid highly texturized foods. They will cut foods in small pieces. They'll chew their food very extensively. And they'll get into the habit of lubricating their foods. So when they eat, they'll always have liquid to wash down the foods. And oftentimes they'll be very slow eaters. So they often are scolded for being a picky eater, for being a slow eater. But that is because that is intentional. That is a coping mechanism to avoid dysphagia. So as a clinician, what is a clinical presentation? Well, it really depends on the age. So when you're looking at infants, you should focus on, ask the parents, are there any feeding problems? Is the child having difficulty gaining weight? Is the child having poor appetite? These are common presentations in infants. As the child grows older, you'll see more nausea, vomiting. The child will avoid solid foods. They'll prefer soft foods over solid foods. And then later on, as the child enters school, you'll have, that's when you'll have abdominal pain, sometimes dysphagia. And then as the child grows older, you may have more dysphagia, you may have food impactions, heartburn, chest pain. And so the questions that you want to ask the parents, is the child eating slowly? Do foods get stuck? Are there foods that the child is avoiding intentionally? And so how to explain the difference in symptoms? Well, eosinophilic esophagitis first starts out with inflammation in the esophagus, but once the inflammation sets in, if it's not well controlled over time, you can develop remodeling of the smooth muscle. And so you can actually develop fibrosis, which then will cause narrowing the esophagus, and that will lead to dysphagia and food impaction. So in a sense, this is a progressive disease. You start out with inflammation, but eventually you develop fibrostenotic changes in the esophagus if the underlying inflammation is not well controlled. One of the objective ways of assessing dysphagia is the dysphagia symptom questionnaire. So this is basically a recall over the last 14 days. So every day, basically there are two questions that either the child answers or the parent answers. First question, since you woke up in the morning, has food gone down more slowly or has been stuck in the throat? Yes or no? And then for the most difficult time, you had swallowing food today in the past 24 hours. Did you have to do anything to make the food go down or to get relief? So again, this is scored out of 4. So 0 is no intervention, it cleared on its own. 1 is if the child had to drink lots of liquid to get it down. 2 would be if they have to cough or gag. 3 is if they've had to vomit. And 4 would be very severe if they have to get medical attention. And so this is scored on a daily basis. It's out of 6. This is scored over the next 14 days. So the maximum score is out of 84. And so the higher the score, it would indicate more frequent as well as more severe dysphagia. So this is a validated questionnaire. It's used in the gastroenterology literature, and it's also used in clinical studies to assess a degree of dysphagia. So what causes eosinophilic esophagitis? What is the underlying pathogenesis? Well, like most things, it is incompletely understood, but we know that it involves genetics. So there is often genetic predisposition, not necessarily for eosinophilic esophagitis, but for atopy in general. There's also the environment that plays a role. So a lot of these children are sensitized to foods as well as to aeroallergens. And then it assumes that the patient has an abnormal Th2 inflammatory response. So these are the 3 things that are involved in EoE. And so this is a schematic diagram of what goes on. So this here represents the esophageal lining. Remember that this is an epithelial barrier, just like on the skin. And similar to atopic dermatitis, there is a break in the esophageal lining. So the esophageal lining is discontinuous, and that allows penetration of not only food allergens, or foods, I should say, food allergens, and also aeroallergens to penetrate into the esophagus. And what this does is it causes the esophageal epithelium to generate danger signals, which we call alarmins. So IL-25, IL-33, TSLP. These alarmins, especially TSLP, will drive dendritic cells it will activate dendritic cells, it will polarize T helper naive cells into Th2 cells. Also, the esophageal epithelium itself can produce IL-4, and this, as you know, is a very important cytokine. IL-4 in turn is critical for class switching of B cells. So normally B cells, when they're activated, they produce IgG, but in the presence of IL-4, there's class switching. This results in IgE production, which in turn will bind to mast cells and basophils, which can then degranulate and cause allergic inflammation. We also know that IL-4 as well as IL-13 can directly increase barrier dysfunction. It can disrupt the epithelium even more. When the Th2 cell is activated, it can in turn release not only IL-4, but also IL-5 and IL-13. IL-13 is a very important cytokine in the sense that it can lead to fibrosis, it can lead to tissue remodeling. So this will result in the production of formation of esophageal rings, strictures, furrows. It will also cause increased smooth muscle contraction. So the smooth muscle around the esophagus becomes more contractile, and this will also lead to hypertrophy. And then IL-5, which is also produced by Th2 cells, IL-5 is the key cytokine for eosinophils. And so it will stimulate the bone marrow to produce more eosinophils, to release more eosinophils into the bloodstream. It also prolongs survival of eosinophils. And we know that ultimately eosinophils are important, one of the important cells involved in eosinophil esophagitis. Also, one last thing I want to mention is IL-13 has a role, direct role in terms of eotaxin. Eotaxin 3 is a cytokine, is actually a chemoattractant. So it's a chemokine that is involved in chemotaxis of eosinophils from the blood compartment into the tissue. So in patients with EoE, their eotaxin 3 level is upregulated, and this allows eosinophils from the blood compartment to traffic into the esophagus. And this is a very important mechanism for EoE. Now, obviously, just because you see eosinophils in the esophagus, it doesn't necessarily mean that patient has eosinophilic esophagitis. There is a differential diagnosis. So you have to consider, for example, there's other conditions like reflux that can cause a little bit of eosinophilia. Hypereosinophilic syndrome can cause, it will cause widespread eosinophilia, not only in the blood, but also in the tissue, including the esophagus, so that needs to be ruled out. Remember, Crohn's disease. Crohn's disease can involve any part of the GI tract, including the esophagus, so that is another disease that needs to be ruled out. Connective tissue disorders, infections, for example, several viral infections, fungal infections can also cause eosinophilia. Sometimes certain antibiotics like doxycycline can what we call pill esophagitis. So the doxycycline tablets can actually get stuck in the esophagus, can cause irritation, localized irritation, and generate localized eosinophilia. So these are all common entities that are part of the differential diagnosis. And there's also a condition called eosinophilic gastritis, where you have eosinophils in the stomach, or eosinophilic gastroenteritis, where you have eosinophils in the stomach as well as in the colon. And this also needs to be differentiated from eosinophilic esophagitis, where eosinophilia is only limited to the esophagus. Now I'm going to spend a little bit of time on talking about reflux, because I think that is a very important differential entity that is part of the differential diagnosis. And oftentimes children are mislabeled. They're given the diagnosis of reflux, where in fact the child actually has eosinophilic esophagitis. So it's important to understand that reflux, even when reflux is very severe, will not cause food impaction. So if the child has difficulty swallowing, you cannot attribute it to reflux. Also, reflux is not associated with food allergies. Although, reflux can cause abdominal pain, just like eosinophilic esophagitis can cause abdominal pain. With reflux, generally the prevalence is equal between males and females, whereas with eosinophilic esophagitis is predominantly males. So when you see a male child, think more EoE. And then keep in mind that eosinophilic esophagitis is often associated with other atopic conditions. So when you see a child who has having symptoms, but also has allergic rhinitis, atopic dermatitis, food allergies, asthma, think more EoE. Now, obviously, if you do further investigations like a pH probe, the pH probe will be abnormal in reflux, it will be normal in EoE. And if you are to get an endoscopy with biopsies, you'll see the classic signs in EoE, such as furrows, rings, exudates, and the biopsy will show greater than 15 eosinophils per higher power field. Whereas in the case of reflux, the endoscopy will look normal, and the biopsies will show less than 15 eosinophils per higher power field. One thing that is interesting, in the past we used to think that only reflux responds to PPI therapy, and that actually is false. Up to 50% of patients with EoE also respond to PPI therapy. So just because a child gets better with PPI therapy does not necessarily mean that it's reflux. It could be EoE as well. So again, these are I think important in the differential diagnosis, distinguishing between reflux, which is certainly a lot more common, but also keep in mind that EoE is also can be a diagnostic possibility. Now, in terms of EGD, it's very important as a clinician, when you ask for an EGD, make sure that the gastroenterologist takes biopsies, because in EoE, the endoscopy can look normal in up to 30% of cases. So just because the endoscopy looks normal does not mean that the child does not have EoE. So you really need to get biopsies. Ideally, you need at least 6 biopsies, 2 from the proximal esophagus, 2 from the mid-esophagus, 2 from the distal esophagus. Because EoE, just like Crohn's disease, can be patchy, so it's important to take biopsies from the proximal, mid, and distal esophagus. And in order to make the diagnosis of EoE, you just need 1 positive biopsy. In terms of endoscopy, what are some of the endoscopic changes you see with EoE? This is actually can be scored. This is what we call the EREF score. This is the EoE endoscopic reference score. It's characterized, you're looking for edema, rings, exudate, furrows, and strictures. And this is graded. So for example, grade 0.
2 minutes more.
Okay.
2 minutes more.
Yeah, this will be, so here's an example of edema where you lose vascular markings. This is an examples of rings. So this is graded 0 to 3. Then you have presence of exudates. These are signs of inflammation. Again, it's graded 0 to 3. Presence of furrows, and then presence or absence of strictures. So this is the EREF score. The higher the EREF score, generally the greater the dysphagia in EoE. So obviously, as an allergist, you are not going to be doing the endoscopy. So what is your role? I think primarily your role is to evaluate for other allergic disorders, such as atopic dermatitis, allergic rhinitis, asthma. Food testing for identification of EoE triggers is actually no longer advocated. And the reason for this, and this is a recent change in the guidelines, is that the response rate to empiric elimination diet is actually superior to test-directed elimination diet. So we don't do food testing to identify EoE triggers. The role of food testing is done primarily to identify patients who are at risk for anaphylaxis when foods are reintroduced after empiric elimination diet. So what are the main triggers of EoE? Well, in children, it's cow's milk followed by wheat. In adults, it's wheat followed by cow's milk. Okay, so these are when you're doing elimination diets, these are the common foods that you may want to avoid: cow's milk, wheat, egg, soy, and peanut. This is for children. And what is the goal of treatment? Well, obviously you want to resolve symptoms of dysphagia, but you also want to you want histological resolution of the underlying inflammation, and you want to see improvement in the endoscopic findings. And so this is really a spectrum. Ideally, to have some response, ideally you should have less than 6 eosinophils per high power field. And that's sort of the guide, the gold standard for histology. For symptom reduction, you want at least a 30% reduction in symptoms. And in terms of endoscopy findings, you want to see at least an improvement in the EREF score by at least 2 points from baseline. So here's the treatment algorithm. So once a child is diagnosed with EoE, what are the treatments? Well, there's PPI therapy. These are all first-line therapy. So PPI therapy, or swallow topical corticosteroids, or elimination diet. And these are not mutually exclusive. You can actually do one or more at the same time. If for some reason you don't have a response, for example, it may be due to very advanced disease. You may have, especially if you have stenosis, fibrotic changes, stenosis, then you actually may have to dilate the child. But keep in mind that dilatation alone, it doesn't cure the disease. So even after dilatation, you still have to treat the underlying inflammation. And then more recently, and I'll share with you, there is a biologic called Dupilumab that's actually been shown to be effective in the treatment of EoE. So let's start out with a PPI therapy. So this is very inexpensive, effective, and safe. It can achieve histological remission and clinical remission in about 50% of your patients. And this has nothing to do with acid suppression. What this does, PPI therapy actually suppresses Th2-mediated eotaxin 3. So that is the primary mechanism of action. It also improves esophageal barrier function. And again, this effect is independent of acid suppression. Generally, when you give PPI therapy, you give double the standard dose. You do it for at least 8 weeks, and then you gradually taper to the least effective dose. And this is a meta-analysis of different studies. And basically, you see that there's about 50% response rate. So 50% of patients who are on high dose PPI therapy, they develop histological remission.
Sir, if you can conclude it.
Sure. So PPI therapy is, I guess, first-line therapy, also topical swallow steroids. So this would be things like fluticasone and budesonide, which, unlike the child with asthma, in this case, you're actually swallowing. And this has about a 68% response rate, so a little bit higher than PPI therapy. And then finally, there's actually what we call elimination diet. There's several elimination diets. The one that we recommend is the empirical elimination diet, where you can either eliminate a single food, which was cow's milk, or a 2-food elimination diet, cow's milk, wheat, 4-food elimination diet, and 6-food elimination diet. And you can see the various response rates. And generally what we do is we start out with a 2-food elimination diet, which gives you about a 40% response rate. If the child is not doing well, you can step up and do a 4-food elimination diet. If the child is still not doing well, you can step up again to a 6-food elimination diet. And conversely, if the child is doing well, you can step down. So this is a little bit like an asthma guideline. You can step up and step down depending on how the child does. And then finally, there is now a biologic called Dupilumab, which is approved for EoE for children 12 and older. The dose is 300 milligrams weekly. And it's shown to have a very, very nice response rate in terms of histological suppression. About 60% of patients at week 24 achieved histological remission. And also at week 24, there was a substantial decrease in the dysphagia score. Finally, just a quick thing about esophageal dilatations. So if the child does not respond to any of the therapies, then the next step would be to dilate the child, to dilate the esophagus. But keep in mind that this alone is not a treatment. It does not have, it has no anti-inflammatory properties. So if you just dilate the esophagus, only 50% will remain symptom-free 1 year out, and only 40% will remain symptom-free 2 years out. So this has to be done concomitantly with other therapies. All right, so just to summarize, EoE is a chronic immune antigen-mediated esophageal disease. It's characterized by esophageal dysfunction as well as histological eosinophilia. The exact pathogenesis is uncompletely understood, but we know that genetics play a role, as do environment, as do host immune responses. What is new about EoE is the utility of food testing. So we generally don't do food testing. Its role in identifying EoE triggers is unclear. Rather, we try to do empiric elimination diets. The goal of treatment is both clinical and histological remission. First-line treatments include PPI therapy, swallow topical corticosteroids, and oral elimination diet. But in the future, we know that biologics may play a role. And I think what is important as an allergist is that we can play a pivotal role in the co-management of EoE by also taking care of the associated allergic disorders. All right, so thank you very much. This is actually me. I myself have EoE, so I have first-line experience of this disease. This is actually one of the gastroenterologists that I saw when I was at the Mayo Clinic, and this is us 20 years later. So I was one of his first patients with EoE. All right, so thank you very much.
Thank you, Dr. Vinay Mehta. Thanks a lot for a very elaborative and informative talk. And we are really sensitized for this new entity, eosinophilic esophagitis. We may be now diagnosing much of the cases in India also, as we have a lot of food allergies here. Thanks a lot.
All right, thank you very much.
Thank you, sir.
Next is the lecture on presentation on food-induced anaphylaxis in children by Dr. Nihar Ranjan Mishra. Dr. Nihar Ranjan Mishra is Associate Professor, AIMS, Kalyani, West Bengal. He is the Fellow of ACI, PhD DCR, Fellow AIMER, DPSM. He has established IP CPR Center at AIMS Kalyani. To his credit, there are more than 40 publications. He is author of 8 books, and there are more than 9 projects he has been involved in. So I welcome you, sir. Please start your presentation. I would also request you to restrict in 20 minutes. Thank you.
Thank you, madam. So very good morning, everyone. First of all, I would like to thank the panel discussion led by Surendra sir. He has covered most of the topics, so I will not go into detail. So my today's learning objective will be what is food allergy, what is food-induced anaphylaxis, food allergy already detailed by the panel discussion, then present burden, types, clinical features, management, approach, how will you approach a case of FIA, what are the differential diagnosis, how you prevent this, and finally, what is the take-home message. There are 3 case scenarios. One is 5-year-old Sarthak attending our OPD with history of rashes and itching all over the body after attending a birthday party within 30 minutes. 2 times, 2 episodes. And the last episode was associated with difficulty in breathing. So what may be this case? Second is 7-year-old Dev attending our OPD with history of abdominal discomfort, followed by loose motion, most often, not always, when he attends any restaurant, attending outside meals within 3 to 4 hours. He is very fond of eating fried fruits and snacks. And the third one, these are all real cases. 12-year-old Pooja attending our OPD with history of generalized urticaria with severe pain abdomen every time after eating nuts. The episodes were so severe that she got admitted or hospitalized and recovered. She is the only child and parents were very anxious. All allergy workup were normal. Now doing well with taking nuts, but in a blinded manner. So in these 3 case scenarios, first one will be as per the panel discussion led by Surendra sir, it is obvious that it is a case of food allergy. The second one, that is same type of reaction, but there is no respiratory involvement and there is no immediate reaction. So it may be a case of food intolerance. And the third and the interesting one was, it is a case of food aversion. Because I have very bad experience with this case, and Dr. Kausevi also knew this very well. So with this background, now we'll just refresh the classification of food allergy already told, the IG mediated and non-IG mediated and mixed one. So the anaphylaxis part, as per my topic is concerned, we will restrict to our discussion to only IG mediated one, which is the immediate onset. So then yesterday, Dr. Bikram Patraj very well narrated the types of anaphylaxis or anaphylaxis, what is anaphylaxis, how to explain it, how to approach the case, how is the drug of choice. So I will not go into detail. Just as per the topic is concerned, I am just throwing some few lights, like anaphylaxis is defined as the any emergency clinical medicine satisfying the any of the three, only one of the three criteria, like involvement of skin or mucosal tissue, along with either associated respiratory or circulatory components, or respiratory or circulatory or GI, or only circulatory. So what is coming to, what is the topic proper, what is food induced anaphylaxis? So that occurs soon after eating certain food, mostly biphagic in nature. Then generally anaphylaxis two phases, early onset and late onset, that is separated by 1 to 8 hours. Types of foods varies from country to country. In India, cow milk is the most common. And as per late Dr. Nagaraju sir, as per his version, in India, still cow milk predominates, but in Asia, shellfish, peanuts in Western countries. Worldwide, most common allergen in infants are cow milk and hen's egg. And death occurs at any age, and most commonly the accidental ingestion of food without any prior knowledge. What is the present burden? Data are very scarce in our country. So also in outside country also, but whatever I tried, I have mentioned it here. It accounts for 30 to 50% of all cases of anaphylaxis in children. And it occurred in first 2 years of life with a frequency of 20 cases for 1 lakh children, followed by adolescent age group, 2 age groups, earlier 2 years, then late adolescents. True prevalence is unknown. The frequency is estimated to be variation from 0.19 to 30 cases for 1 lakh children per year. Incidence worldwide, it varies from country to country, region to region, ranging from 1 to 77 for 1 lakh persons per year. There is 7-fold increase in hospitalization in children due to food-induced anaphylaxis has been observed in Europe, and 2-fold increase in US in recent years. Despite sharp increase in incidence, but mortality rates are still decreasing, that is 1.35 to 2.71 in million person years. The cause may be the awareness or the advance in the treatment modalities or advance in the diagnostic approaches, maybe. And incidence is comparatively less. We are a bit luckier. It's less in Asia as compared to the Western Asia. Why? Because of the high humidity of our country or our Asian region, high consumption of vegetables and fruits, as already told earlier by experts, exclusive breastfeeding, less bottle feeding, poor food hygiene, large family and overcrowding, vitamin D level. So these are the factors why we luckily we are escaped from food allergy as of now. Then these are the prenatal epigenetic changes. Like last time, Neeraj sir told regarding the epigenetic changes. I just put a slide over there. That is, these are the factors. So that from the child from mother's womb till delivery, these are the factors he has to cross. And these are the factors over the long period of time. The changes will occur. It is called epigenetic changes, like tobacco smoke, pollution, then positive like folate, antioxidant administrations, PUFA, N3 PUFA fish, then prebiotic, probiotic, pets in the family, and farming. So I just remember the Nagaraj dictum. Sir told when you go older, you will see lots of peanut allergy cases in India. Not now. So luckily, 1 month before I have 2 cases peanut allergy, and both the child were born in USA. They were Indian. They are Indians, but they are born and brought up there, and they are classic case of peanut allergy. So just reminding me the Nagaraj versions. So these are the common foods already discussed by the panel discussion: peanuts, milk, shellfish, tree nuts, egg, finfish, and wheat and soy. So in different age groups, in infancy, cow milk, followed by soy-based. In preschool, egg, fish, cow milk. School-going children, egg, fish, prawn, nuts, shellfish also. Adolescent, same, but prawn and brinjals and chickpeas. These are the commonly encountered fruits in different age groups that may cause FIA or food-induced anaphylaxis. What are the risk factors? Change in the lifestyle, because we are gradually going to a westernization lifestyle adaptation. So it may be a factor for the epigenetic changes. Then boys are most responders. Then adolescents, particularly with chronic comorbidities. Then uncontrolled or poorly controlled asthma. Monovalent sensitization. Vitamin D insufficiency, the role is controversial. That is, some studies support and some studies equivocal. So lack of immediate access to adrenaline. So these are the factors which promotes which are the risk factor for food-induced anaphylaxis. So what are the triggers? Trigger is that suppose you take some food and you have some trigger like sleep deprivation, or there is menarche or menstrual period, or exercise, or alcohol or NSAID use, then only anaphylaxis occurs. This is called food induced or trigger induced or triggers. The same food, if you take without these triggers or catalysts, then nothing will happen. So here we need to think about the foods as well as the triggers, which will precipitate the reactions more severely. What are the clinical manifestations? The same as the anaphylaxis per se, the GI, vomiting, diarrhea, abdominal cramp, and colic, swelling of the oral mucosa. In the dermatology, urticaria, itching, redness, wheals, angioedema, respiratory, cough, rhinitis, then wheezing, laryngeal edema or stridor, cardiovascular, hypotension, tachycardia, and arrhythmia. If these are the symptoms you get immediately after taking any food, there is a clear-cut case of anaphylaxis. So what are the types? So first is the gastrointestinal anaphylaxis or immediate gastrointestinal food allergy. Second is food-dependent exercise-induced anaphylaxis, or you may tell us wheat-dependent exercise-induced anaphylaxis. Third is delayed anaphylaxis by mammalian meat, that is alpha-gal syndrome. Fourth one is the oral mite anaphylaxis or pancake anaphylaxis. So coming to the gastrointestinal anaphylaxis, is IG mediated. Like any other anaphylaxis, clinical symptom it will appear. Symptom will appear within minutes to 2 hours. Diagnosis by typical clinical history, supported by skin prick test or serum septic IG. But it is the test you have to do after certain duration of time, like 4 weeks, not immediately. And complete elimination of suspected foods up to 2 weeks with the resolution of symptoms and oral fluid challenge. Then food-dependent exercise-induced anaphylaxis. Dr. Nagaraj sir's research center, he has approximately 80 cases of food-dependent exercise anaphylaxis till now. I think this is the highest number of cases in India he has. And I have the data, all the data of him, and we are in planning to publish the data. There are all complete follow-up cases of 80 cases of food-dependent and wheat-dependent. Most of the cases are wheat or gluten-based, and it is mostly stimulated by exercise within 2 to 4 hours of injecting the food. But in the absence of exercise, there will be no reaction, as I have already told. 30 to 50% associated with triggers, and most common in adolescent female up to age of 30 years. But exact mechanism is not known. And most common implicated food is wheat, that is omega-5 gliadin, but others like shellfish or fruit or milk can also occur. Diagnosis typically by history, like in the early panelist, one of the panelists told that after taking chapati, going for exercise, symptom develop. This typical history we need to extract from the parents. And all the investigation in the case of food-based anaphylaxis or food allergy, as already told, history to be supported by certain tests. And hospital-based, physician-supervised fruit challenge can be done, but by experts. Delayed anaphylaxis by mammalian meat, alpha-gal syndrome. This is history of tick bites, means alpha-gal is a cross-reactive carbohydrate determinants present in the tick as well as some animals like beef, pork, or lamb. When you have the history of tick bite, you don't know you have any past history of tick bite, you have alpha-gal in your body. Once you take the food, then it will cross-react and there will be the anaphylaxis, but it will be a delayed one, that is 3 to 6 hours, because alpha-gal after ingestion, after taking into your stomach, it will take some time, take some time to go to the circulation and create a reaction. So diagnosis is by creating a typical careful history, same SPT to milk extract and a specific IG to alpha-gal. So avoidance, tick bites and animal meat consumption is the only treatment. And this group of children patients also sensitive to cetuximab because it also contains a carbohydrate moiety. So before giving cetuximab, you have to work out on this or have some history regarding this. Oral mite anaphylaxis or pancake anaphylaxis is a house dust mite or dust mite cross reactivity between aero dust mite and storage dust mite. Like you have already sensitized to dust mite, but when you are taking some cakes contaminated with mites, that is storage mites, so that will be the reaction and that got anaphylaxis. So there is some prevention, how to prevent this. You can store the flour of wheat or rice flour in the refrigerator in the low temperature. And another subvariety of this is also can be triggered by the exercise. And this is called dust mite ingestion. Is dust mite ingestion associated exercise-induced anaphylaxis. Similarly, like food-dependent exercise-induced anaphylaxis. A new aspirin trial that is proposed by Borges in 1997, that is aspirin allergic rhinitis, NSAID or aspirin sensitivity, and oral mite anaphylaxis. Diagnosis, history, and physical examination. Serum tryptase level, that is at IV online, 2 to 3 hours. Then after 24 hours, to know the baseline, normal value, as Dr. Vikram Patra told, it is up to 10. Basophil activation test like CD63, CD107A and CD107B, these are the markers. Knowledge about the cross-reactivity. Last time, Dr. Kassepi has detailed on this. And supportive tests like screen prick test, serum-specific IG, after the child is stable, that is after 4 weeks. Management is only epinephrine, IM epinephrine, and IM epinephrine. I am not going to detail of the management of anaphylaxis. It is same, that is for other anaphylaxis also. You have to give for a supportive management. Then epinephrine, if not responded with the 3 doses, then you can start IV epinephrine. Resistant cases or refractory cases, you can go for norepinephrine and IV glucagon also. And currently, EpiPen is not available in India. So, and Parmesar yesterday told, they are trying to launch it by the December. If it is come, it is very good. And it will be really very beneficial for all the other allergists and the patients. And this is the, then coming to the how to approach. First, stabilize the patient. Then
Dr.
careful
Nihar,
history,
3 minutes more.
physical examination, history, typical symptoms, same symptoms every time with same food, then timing, then quantity, associated factors, then physical examination. Most of the time it will be normal, but maybe the signs of atopy may be there, or rhonchi is there is asthma. Then you go for SPT or serum IG after 4 weeks. If positive and correlates with your history, and maybe negative, but history is suggestive. If positive and correlative history, you can go to avoid that particular food and periodic follow-up for tolerance. And if negative or the history is suggestive, you can go with the elimination diet, elimination test. If there is improvement, you go for double-blind placebo-controlled food challenge. And if it is positive, then avoid. And if it is negative, then reoccurrence. But if elimination test is negative, then there is only reassurance. So this is the overall how to approach a case of food-induced anaphylaxis. Means you have to approach through food allergy. If there is a history of allergy, then anaphylaxis, chance of anaphylaxis is more. The neurodiagnostic modalities like a serum tryptase, basophil activation test, and CRD and microarray technique. Differentials: food-induced acute bronchospasm, food protein-induced enterocolits syndrome, and food aversion. So these three can be differentiated on basis of careful history, but in case of food aversion, there will be adolescent girls and there is no symptom on giving the food on blinding, and careful history, there will be uncontrollable fear. So these are the factors, and F5 typically history, the baby will be very okay and all right in the ICU, otherwise he will be sick at home. This is the typical
Please
history.
conclude.
Prevention, avoidance, family education, leveling of ingredients. Patients with egg allergy can be immunized with influenza vaccine, and yellow fever or rabies vaccine should be contraindicated in a person with history of urticaria angioedema, and establishing a food-induced anaphylaxis group. What are the myths? According to Yaki Task Force 2020, breastfeeding prevents food allergy. Restricting the consumption of potential food allergen during pregnancy prevent. Supplementing the cow milk formula in breastfeed milk infant, regular cow milk based infant formula, and introducing soy protein formula in early past 6 months, vitamin or fish oil supplementation, BCG vaccine, prevent food allergy, and pre-probiotic. These are the myths, they are cleared. And prognosis already told by the panelists. I am not going into the detail. Most of the food allergy vanish by 10 years, except peanuts and fish and tree nuts. Problems: ignorance, lack of diagnostic facility in our country, and not considered a specialized subject. Take home message: food allergy and food intolerance is different entity. Food-induced anaphylaxis is increasing in our country due to change in the lifestyle. Diagnosis mainly careful history and physical examination. Diagnostic workup for supportive evidence only. IM epinephrine is a drug of choice. Patient, parent education and society awareness is the main motto. So these are the suggested reading. Thank you.
Thank you, Dr. Mishra, for that lucid and elaborative presentation on food-induced anaphylaxis. He also touched upon various types of food-induced anaphylaxis, gastrointestinal, FDIA, delayed type, oral mite, and within short time, he has covered almost every topic. So thank you once again.
Thank you, sir.
We would request our speaker to come on the stage with our chairperson for a group photo. I request our chairperson to please come on the stage for a photo. Thank you, sir. Thank you for chairing this session. Now, coming on to our third session, our chairpersons are Dr. Pradeep Pazare, sir, and Dr. Manish Jain, sir. I request them to please take their seats on the dais, and We invite our next speaker, Dr. Sushil Pandey. He will be talking on classification and cutaneous manifestations of drug allergy.
Welcome, Dr. Sushil.
We request our speakers to collect their mementos from the registration counter at first floor.
Good morning. I said good morning. Sometimes difficult to tolerate such talks, and most of the time we are allergic, particularly on Sunday morning post-banquet session. I'm sure all of you are awake. Yeah, fine. So I'm going to be as brief and as specific as possible. And we'll be mostly concentrating on the clinical aspects of cutaneous drug reactions. The only thing is computer has become allergic to my presentation, I think. Good, it's sorted out. Thank you very much for your kind invitation. And in the next 20 or 25 minutes, I'll be speaking mostly on the classification and the cutaneous manifestations of adverse drug reactions. So this is the profile that led me here to talk on the subject of drug allergy that I have been very associated with the drugs that are used by dermatologists and has been holding certain key positions where I am conducting most of the research and my work in the field of adverse drug reactions. Now, why these drug reactions? You know that drug reactions are very common in your clinical practice, be it is a pediatric practice, be it is a dermatology specialty practice, or be it is an adult physical practice. These drug reactions are fairly common because they just don't produce the cutaneous side effects. They also produce the systemic side effects. And sometimes they may be life-threatening. And if you look at the medical legal suits across the country, many of them are related to this life-threatening, severe adverse drug reactions. And therefore, it's imperative for us to be aware about these drug reactions. And it's not just a job of a single physician. Most of the time, you require an interdisciplinary approach. And the timing is extremely important. You need to make a very early and a very prompt and a precise diagnosis, and you have to refer the patient. And I'm saying this because this is a treatable disease. I just came across a patient which was looking exactly like pemphigus vulgaris, and we know we deal with pemphigus vulgaris a lot. And it's a very severe autoimmune condition requiring loads of corticosteroids. So the moment I thought on the left was a pemphigus vulgaris, and I was surprised when we took in history, there was only one thing that I suspected, that can this be a drug induced, and we could identify this drug, and it ultimately turned out to be a case of sorafenib-induced pemphigus vulgaris, where this patient was for hepatocellular carcinoma. So with just single intervention without anti-inflammatory or immunosuppressive therapy, the patient gets better. So important and so rewarding is this for a physician. And many a time when we came across a patient of a severe adverse drug reaction like Stevens-Johnson syndrome or toxic epidermal necrolysis, when we make a prompt diagnosis, earlier this patient used to die, but with now the advent of this therapy, this patient gets absolutely better after 15 days, and that is what something is rewarding. Therefore, to have a knowledge of drug reaction is extremely important. Just 15 days back, I had a patient, 45-year-old male, who was treated for methotrexate subcutaneously for psoriasis vulgaris. And surprisingly, he landed up with this subacute onset of severe cough, which was requiring an admission. He went from one doctor to another, was subjected to various tests like PFT, CT scan, and everything was done. And ultimately, no one could find out a cause. On the careful history, the patient told that he has received these similar tablets a few years ago and was landed up with a similar problem. So we could actually conclude that this was a case of methotrexate-induced hypersensitivity pneumonitis. So with just a very clinical judgment and the suspicion, we could really do wonders in our clinical practice. So before that, certain terms are there, adverse event, that we know that ADR is adverse drug reaction, and ADCR. So when the ADR is presented on the skin or with the cutaneous manifestation, we call it as an ADCR. So I may be uttering this term frequently in my lecture. The scope of my presentation has been actually divided into two parts, where in the initial part, I will be covering about the classification of a drug reaction. And the second part, which is my main domain, is the cutaneous manifestations of common ADCR, because it's a very huge science, and we are going to restrict ourselves to very common cutaneous adverse drug reaction. And we will be discussing mostly the diagnostic approach, that to clinical, no laboratory approach, and we'll be briefly touching the treatment, but that is not actually is the scope of my presentation. Because after syphilis and HIV, 20-25 years ago, it was a great imitator. Earlier, if anything abnormal is there on the skin, we used to suspect that it could be either syphilis or it could be HIV. So gone are those days now. In dermatology, we have also cutaneous T-cell lymphoma as a great imitator. But now the number one position is taken by the drug. So anything and everything is possible with the drug. And slowly, as some of people say, internal medicine is becoming a small part of our drug allergy. So that this science is advancing very fastly. So the classification of a drug reaction, we classify it into this part, A, B, C, D. It's a very fairly and very easy classification to remember. It's a mnemonic, augmented, bizarre, chronic, and delayed. And the words itself are self-explanatory, and we'll be touching on this. So what is augmented ADR? So if we take an overdose of any medicine, the drug effect gets augmented and we develop an augmented adverse drug reaction. And this overdose can be because of an accidental also. If somebody is advised methotrexate once weekly and he takes a tablet every day, obviously there is going to be an adverse event, and therefore your patient is going to land with the problem like this. So it's augmented, is augmentation of the drug side effect. Then second is a bizarre. Bizarre is unpredictable. You cannot predict it. If I give a medicine, sir, somebody said if we give a food or a drug, patient develops reaction on an urticarial rash, and this cannot be predicted because it is by immune mechanism and everybody reacts differently, as we know. So Stevens-Johnson syndrome in urticaria and dermatology are called as bizarre ADR. C, as we label, is as a chronic. So when a drug is given for a longer period of time, slowly the drug accumulates in the body and produces a reaction. So it's a self-explanatory, it's a chronic ADR. And same is also delayed ADR. That means suppose we give cyclophosphamide and 3 or 4 years later, patients develops bladder carcinoma. So we could label it as a delayed ADR. So delayed and chronic perhaps may be similar. So what you have to remember is predictable and unpredictable. Predictable is augmented and unpredictable is bizarre. And where in this case, the causality is very difficult to prove. So having said that, and having seen the classification, how to identify a drug reaction. It's very easy to say identify a drug. In the clinical practice, when patient is on so many medications, how to identify it. And I wrote a review of this in one of an Indian Journal of Dermatology, what is called as causality assessment, as to how to identify a drug reaction. And therefore, no matter there are so many classifications, we ultimately boils down to a very important classification, that is clinical judgment. That the judgment of a physician is extremely important. So whenever you are doubting a drug reaction, look at all these 4 points. Temporal correlation, whether the reaction happened after starting a drug. If something develops today and tomorrow we start a drug, it's very unlikely to be a drug reaction. Second thing we need to look is a biological plausibility where the drug is capable of producing that particular side effect. And third is the D challenge. You stop the drug, your patient gets better. That's a very important judgment that one needs to have in our practice. And last is, and perhaps most difficult ethically, is a re-challenge. We cannot start a particular person on a drug to see whether this is a drug reactions or not. So ultimately, D challenge and the very careful history is a clue for the diagnosis of adverse drug reaction, and the experience of a clinician matters most. So in today's thing, we are going to discuss this few reactions which are very common in dermatology practice induced by the drug, that is acute urticaria, maculopapular rash, Stevens-Johnson fixed drug reaction, and the drug hypersensitivity syndrome. We are not going to touch many of these aspects like drug-induced psoriasiform eruptions, pityriasis rosea, lichenoid eruptions, and anagen effluvium, because I know it's too complex and beyond the scope of today's today's conference. So let us come actually to this particular picture that this patient is presented to us, and this was a case of acute urticaria which was induced by drug. Many people takes a lot of things and they develop a reaction in the form of urticaria. So you may be saying it's very easy to diagnose urticaria, but sometimes not. You have to go by real careful history. You have to ask really the wheals are transient or evanescent. If you are lasting for 24 to 48 hours, and if they are disappearing, that is the way you confirm that this could be a case of urticaria. I'm sure anybody must be aware of this urticaria, but sometimes we might be confusing it with urticarial vasculitis or urticarial bullous pemphigoid, or there are so many other diseases in dermatology which looks like urticaria but may not be the urticaria. And it is where your clinical history and judgment helps us most. Now, when it comes to drug-induced acute urticaria, they are invariably acute onset. And unfortunately, when you look a wheel like this, you cannot make a judgment that it's a drug-induced urticaria or food-induced urticaria or viral infection-associated urticaria. But remember that the viral infections and the food-induced urticaria are more common in the pediatric population, while drug-induced urticaria perhaps is more common in an adult population. Most of these points are almost similar, except in viral infection, you have a history which is suggestive of fever, sore throat, and coryza. Maybe conjunctival congestion, enanthem is there. But one important clue is that if you are suspecting a drug-induced urticaria, you stop the drug and your patient gets better, or there is a dramatic improvement. And that is a very important clue. Unlike in a food-induced urticaria, where we stop the drug and it takes some time for food maybe to get washed out of your body. So the results are very dramatic in drug-induced urticaria as far as the clinical history and examination is concerned. This is what we always discuss. Whenever you are in doubt or you want to establish the etiology between a drug and a reaction, always follow these 4 important parameters. They will help you throughout your life. So for example, we had this patient who had landed up in casualty with acute angioedema and urticaria with stridor and signs of anaphylaxis. She told, or her relatives told, she took azithromycin and spironolactone. So out of this, which is more likely possibility, because we deal with these patients day on out. So I can say with my clinical experience, azithromycin is less likely to cause urticaria. So we zeroed out on a spironolactone. So ultimately, once again, it comes to the same thing, that is the clinical judgment perhaps is most important, as we can see in this patient. So as I said, we are not going to discuss the treatment part. It must have been amply covered yesterday and today only. Stoppage of the drug, give antihistaminic and injection adrenaline whenever it is acute. So after acute urticaria, which is very simple to diagnose, another common presentation that we oftenly see in practice is fixed drug reaction or fixed drug eruption, what we call it as. The history is very typical. Most of the time, in 90% of the cases, this is drug-induced only. You don't have to suspect any other etiology, and the drug also is very commonly known. Somebody has a diarrhea, takes a tablet O2 and develop this. So majority of the cases in dermatology practice are because of fluoroquinolones or imidazole group of the drugs apart from the NSAID. So why it is called fixed drug eruption? Just to revise, that this site becomes fixed. Every time patient takes the drug, it develops at the same site. It's a pigmented necrotic patch. Maybe there is a blister there, and it's very easy to diagnose. And many times a confusing part is sometimes can be confused with Stevens-Johnson syndrome also, when it is very extensive. And at that time you will see, or there is also a mucosal involvement. So this can be also associated with the mucosal involvement. So fixed drug reaction, next time patient takes the tablet, it develops at the same site. Sometimes when it is very extensive, and we have reported this in our journal as a case of generalized bullous fixed drug eruption, instead of remaining a localized to one particular point, it becomes extensive. You have also mucosal involvement, and sometimes you see like it can be a Stevens-Johnson syndrome. It is not. It is a case of generalized bullous FDE. As we can see, a diagnostic clue in all these cases is the pigmentation. You will not see the pigmented part, mostly in Stevens-Johnson syndrome. If you take a biopsy, you will see that there is a pigment incontinence. So the disease will disappear, but later on the pigmentation will tend to persist. So this is the way we diagnose the fixed drug eruptions. To stop the offending drug, antihistaminic and oral and topical corticosteroid will do the job. Now, coming to this, another part of cutaneous manifestation, which is drug-induced, is the drug-induced maculopapular rash. And many a time I envy of my pediatrician colleague because they are not faced with this dilemma, whether it's a drug-induced or a viral-induced, because majority of the cases of maculopapular rash in the pediatric population is viral unless proved otherwise. So, but in adult population, sometimes we have to make a distinction whether it is a drug-induced and the viral-induced, because the treatment is entirely different. So how can we differentiate between the two based on the clinical judgment? So if it is a drug-induced rash, it tends to come initially in the trunk and the upper extremities, in contrast to viral maculopapular rash, which comes on the face. It goes in a cephalocaudal position. And one important clinical clue is the presence of pruritus. So if it is a drug-induced etiology, you have more pruritus, while viral rashes are typically asymptomatic or what we can say very subtle. No constitutional symptoms, and we have a corroborative history of constitutional symptoms along with that. Enanthem, that is what we always look for. We always ask patient to open the mouth and see whether there are any eruptions. If it is a viral-induced maculopapular rash, many a times you will find that there is an enanthem or the presence of similar maculopapules on the palate and the mucosa, while in majority of the cases, this enanthem is absent. So this is how we differentiate. I made it more simplistically. So this is how the presence of pruritus and the presence of enanthem differentiate between the drug-induced maculopapular rash and the viral-induced maculopapular rash. So you don't require it. It's not a life-threatening. It's a manifestation of internal immune mechanisms. You stop the drug, you treat the patient symptomatically and with the antihistaminic, and your patient gets better. Now, after this, let us come to a more severe cutaneous manifestations of drug allergy. And this is Stevens-Johnson syndrome and toxic epidermal necrolysis, very severe and life-threatening. And again, here also, just like FD, majority of the cases are drug-induced, and the non-drug, very few times can be mycoplasma infection, acute SLE or acute graft versus host disease, which is relatively less common as compared to drug reaction. The onset is very acute and the course is very dramatic in case of Stevens-Johnson syndrome. You all have constitutional symptoms, and many a times whenever there is a confusion, whether it's a SSSS or whether it's a Stevens-Johnson, always look at the mucosa, because you will find typical hemorrhagic crust in patients of Stevens-Johnson syndrome. So this was the patient I saw on the first day, and on the second and third day, his skin is detaching like anything. So this is a case of a toxic epidermal necrolysis, and you just put a hand on your skin and the skin comes out. So this is how we diagnose Stevens-Johnson syndrome. I get sometimes queries from pediatrician colleague that whether it's a Stevens-Johnson syndrome or whether it's a staphylococcal scarlet skin syndrome. Remember, in staphylococcal syndrome, you have a very superficial involvement because the blister is subcorneal. It is a superficial peeling of the skin, while in Stevens-Johnson syndrome, you have the whole skin which is coming out. So this is a very simple distinction that we can make. Again, here is a Stevens-Johnson syndrome, a typical hemorrhagic crust, and the two mucosas are invariably involved. While in case of SSS on my right side, the mucosa appears to be fairly normal. So this is how we distinguish, because both have entirely different course and a very entirely different outcome. Believe me, with the advent of cyclosporin that we have been using so frequently these days, that our patients of Stevens-Johnson syndrome are getting much and much better at a very early stage, and they are surviving, unlike in the past where we have to put them on loads of corticosteroid and they used to die of septicemia and hemodynamic failure. So the cyclosporin has done wonders, and it has become a sort of first-line therapy in the management of Stevens-Johnson syndrome. Now, this is a patient. Why I'm put this slide? This is the same patient. But many times in drug allergy, we are so obsessed with the drug allergy that we tend to forget the primary etiology for which the patient had come. This patient had come for the URTI. Probably we were so focused on management of Stevens-Johnson syndrome that this patient from URTI landed with LRTI and was on a tube for some time. Luckily, he came out of it. So in all cases of drug reaction, do not forget the primary cause for which the patient had taken drugs earlier. And this is my last cutaneous manifestation of drug allergy, which I feel is again more common in pediatric and adult population. Is sometimes we have such patient who come with a high grade fever. This was a patient who was a known case of seizure disorder and was started on phenytoin 30 days back. And after say 30 days back, when it goes to a physician will flatly refuse that this cannot be a drug reaction, because we always say it's either 1 or 2 weeks after starting a drug. 30 days after starting the drug, we say the drug is well tolerated and well, it's not a drug reaction. This is exactly opposite in drug hypersensitivity syndrome, whether drugs like phenytoin or aromatic anticonvulsant, they tend to accumulate in the body for some period of time and then they produce a drug reaction. It's very severe, and you stop the drug, this patient doesn't get better in a short period of time. They require months of therapy. So this patient was found to be febrile with hypertension. He has a lymphadenopathy. He has a hepatosplenomegaly. But what he was having, a clue for drug hypersensitivity syndrome, is early facial edema and periorbital puffiness, which is very striking in this patient. So first of all, you have a facial edema and the rash starts from there. This starts as a maculopapular rash. In a short period of time, it can assume any morphologies. And this patient, we have to take care of internal organ involvement, because this is one drug reaction which has an internal organ involvement. Most of the time we have these patients of hepatitis, drug-induced hepatitis, and very important to treat this patient. I have seen patient because of the drug, there is an en masse hepatic failure. Majority of the portion gets damaged, maybe suddenly, and the patient may land up with acute fulminant hepatic failure and may die of hepatic coma. And therefore, this patient had to be treated very carefully. They have a lung involvement, they have the involvement in the form of hepatitis, and they also can have interstitial carditis. So these are the patients which are popularly called as DRESS, drug reaction with eosinophilia with systemic symptoms. Typically starts 3 to 4 weeks after starting the drug. And this is the common culprit drug. There's a definite set of the drug that causes, that is anticonvulsant, INH, pyrazinamide, rifampicin, dapsone, allopurinol, nevirapine, abacavir, minocycline, leflunomide, and the list is increasing. But this is mostly aromatic anticonvulsant and AKT in the practice. And of late, we even have stopped using dapsone for the similar fear, because the DRESS syndrome can be life-threatening. So what is the criteria for this? I'll just finish in a minute or two. We are at the fag end of my lecture. This is one criteria, but we generally don't go by this criteria. I always say, whenever you have a fever, you have a skin eruption, you may or may not have eosinophilia, we have a lymphadenopathy. So anything when patient has a drug rash, febrile illness, and with or without eosinophilia, but with symptomatic or asymptomatic internal organ involvement, you are probably dealing with a patient of DRESS syndrome. The treatment, I'm not going to this thing, but we put this patient on intravenous dexamethasone, and this patient got extremely better after that. So coming to the summary of my lecture, that ABCD classification is there for a drug reaction. In dermatology, we have urticaria, maculopapular rash, and these are the common cutaneous manifestations of drug allergy in our practice. And I'm emphasizing this point again and again, that the clinical judgment and the experience-based approach is more important than the evidence-based approach, because in drug allergy, you have a very objective laboratory evidence, and therefore you have to go by your experience. You need to make an early diagnosis, treatment, and referral and interdisciplinary approach is extremely important. And only way to achieve this is by sharing the cases that I'm sharing with you. We have a platform in the form of Indian Journal of Drugs in Dermatology, of which I am a chief editor, and we always report effects and the side effects of the drug in this particular journal. So thank you very much for your kind attention.
Thank you, Dr. Sushil, for such a nice presentation on ADCR. You have correctly shown the classification as A, B, C, D, E, and F, the various manifestations.
The E and F, fortunately, is added by me, so it's not there in the book.
Yeah. And correctly said that the way to identify is your clinical judgment.
Yes.
Absolutely. And various how to approach to a diagnosis. Thank you very much, and thanks a lot for sticking to time.
Thank you. Thank you.
And now I would like to invite Dr. Moitra to enlighten us with his knowledge of perioperative drug hypersensitivity. And Dr. Moitra is adjunct professor and senior consultant, Department of Allergy and Immunology at Apollo Hospital, Calcutta, and is also medical director of Allergy Asthma Treatment Center, Calcutta.
Thank you, respected chairpersons. And I must thank the organizers for inviting me in this program. So I would be talking on one of the most exigent and situation in drug hypersensitivity, that is the perioperative hypersensitivity. And why do I call it exigent? We'll understand that the challenges and demands it actually puts forth to the clinicians who is dealing with the cases is really shows that how important it is to understand that how we go about evaluating these patients and prevent such incidents from occurring in the future. Are we ready? So you have just heard a beautiful and lucid presentation by Dr. Pandey, where he has so nicely elaborated the various cutaneous manifestations of the various drugs. Perioperative hypersensitivity is basically, this talk is tagged with his talk so that you understand that what type of manifestations the patients can have and what others. Yeah. Oh, yeah. Thank you. So this topic says perioperative immediate hypersensitivity. But we should remember 2-3 points that when we talk about the hypersensitivity, it may be immediate, it may be delayed, depending upon the pathomechanism. So maybe the immediate, when the patient presents immediately, but there can be delayed manifestations. But the immediate manifestations, which are IgE mediated, are the most life-threatening ones. So today's session is basically concentrated to identify the major life-threatening perioperative hypersensitivity reactions, which are mainly IgE mediated. Okay. It's not moving. Okay. So yeah, I'm really sorry for that. So why the thing becomes so difficult? There is actually the combination of the disease process, number one. Number two is the surgical procedure, which is to be undertaken in the OT. Number three is the anesthetic drugs. Number four is the simultaneous administration of several drugs which takes place. Number five is the hidden exposures and the numerous differential diagnoses which we can have in these patients. And what the hidden exposures, like the latex, hidden exposures, like all the antiseptic solutions which we use for sterilizations and things like that. And along with that is a very important component is that the patients may not be in a position to actually tell about the thing. That is, patients may be anesthetized. So all these issues or the points make the situation extremely difficult to detect and then to proceed forward. So this hampers the identification and the early treatment and causes high mortality, which can happen. And this usually is catastrophic. And again, the same thing, the lawsuit cases increases more in this type of patients because they are quite unprecedented, happen suddenly. And that's why neither the physician nor the relatives, they are prepared or they understand that what has happened. So the UK 6 National Audit Project, which was in 2015 and 16, they have said that its incidence is very high, but there's still lots of underreporting. And there's a perioperative hypersensitivity incidence ranges to the tune of actually, it is 1.353 to 1 in 353 to 1 in 18,600 procedures. We are preparing our own hospital data and it is still unpublished. And we have found it to be high, astoundingly high, to be 1 in every 786. And this have started to occur when we have deliberately started to take records of what are the incidences of the perioperative hypersensitivity that we are getting in our OTs. Pathomechanism, we know that it could be an allergic, it could be a non-allergic. When we talk about the immediate, non-allergic is basically, it could be a direct mast cell degranulation, which can occur by a number of mechanisms. Like one is those coming up is the MRGPRX2, as in the opioids or in various fluoroquinolones, and direct mast cell degranulation by these receptors. And its polymorphism in the Indian and other populations is being coming up to be one of the important factors for the direct non-allergic mast cell degranulation immediately. But the major important is the allergic manifestations, which can be IgE mediated, and also we can have the IgG mediated mast cell degranulations in the immediate phase. Clinical symptoms ranges from mild reactions to very severe reactions leading to the circulatory failure. So the mild reactions are mostly the skin reactions, that is maculopapular eruptions, but the life-threatening can be an anaphylaxis and with the various organ failure. Isolated cardiovascular collapse or cardiac arrest, it may be the presenting feature in these patients, and that is the most severe form. And this is we usually see in cases of the neuromuscular blocking agents or maybe the beta-lactams and maybe the NSAIDs. There is always a thing like a paradoxical bradycardia which can occur during extreme hypovolemia, and it has been reported, and this has to be kept in mind because these are the vital parameters and which actually guide us to the patient situation after the patient has been anesthetized. Bronchospasm is a feature, and that can be evidenced by the increase in the plateau pressure when the patient is ventilated. The majority of the reactions, they occur during anesthetic induction. That is the most important phase, but they may occur during any phase of the perioperative course, depending upon the time it is taking for its manifestation. So this is for all of us to understand, even during the time when the patient is being taken off the anesthetic drugs, or maybe the patient is put on the medications which is being used to reverse the effect of the neuromuscular blocking agents like the Sagamadex. It can also lead on to this as reactions. Basically, we all know that anaphylaxis we classify reactions classified by the typical Ring and Mesmer classification, but any other, the Brown's or any other classification can be used. This is most commonly used and graded in grade 1, 2, 3, 4 reactions. One is basically the maculopapular eruptions. 2 is with maculopapular eruptions with some amount of the cardiovascular and the respiratory instabilities. 3 is basically the cardiovascular collapse, which may be associated with or may not be associated with the skin signs and the signs of the respiratory failure. And 4 is basically respiratory arrest. So typically 3 and 4, what we term as an anaphylaxis, and these are the most dreaded things to happen. And it happens with the majority of the drugs, which is used specifically during the induction phase. But the non-allergic differentials list is huge. So I'm not going to detail into it. You can see it's a huge list. So that makes the decision very, very difficult. Only one thing I will just mention, that is the vasodilatory effect of the neuroaxial blocks, because last week only we had a patient who underwent a block with the lignocaine, and then patient presented with the cardiovascular collapse sometime, just 2-3 hours later. And this was related to that block. And basically we call it the local anesthetic related systemic oxidative LAST. LAST is basically one of the common mimickers of the perioperative drug hypersensitivity, and mechanism is totally different and mainly manifest as the cardiovascular instability, and most commonly with the neurological symptoms of seizures and all. So what are the common drugs which we find in the perioperative hypersensitivities? First and foremost are the beta-lactam antibiotics, which are the major drugs causing this POH. Along with that, neuromuscular blocking agents, the hypnotics, which could be the barbiturates like the thiopental, or the non-barbiturates like the propofol, ketamine, etomidate, benzodiazepines, and also the inhaled anesthetics. Opioids, NSAIDs, local anesthetics, they are also known to cause, because in the local anesthetic, we use it very frequently in our daycare procedures, in the OPDs, in the OTs and all, we every day use it. But we know that there's mainly 2 groups. One is the amide group and an ester group. Ester group we don't have in India. Amide, basically, it's a rare cause. The amide, that is a lignocaine, bupivacaine, it's a rare cause, but it actually also has the potential to cause this perioperative hypersensitive reactions. And we must not forget the high molecular weight agents, dyes, latex, that is the natural rubber latex, though its use has reduced very much, antiseptics, ethylene oxide, oxytocin, excipients like the polyethylene glycol. And all these are important hidden factors which can lead on to the POE. So how do we evaluate? So you see that there is so many things which is into it, the patient's disease, the differentials, the many medications. We need to have a proforma for evaluating a POH. And this proforma is extremely important and which actually guides us. So first of all, investigating principles are identify the culprit drug, which at times can be very, very onerous. There can be identify the safe alternatives, because that has to be given to the doctor, and the patient should know about it, and ensure safe future anesthesia. Even if no culprit drug is identified, one has to ensure the safe future anesthesia. This is actually the duty of the allergist or means the physician who's taking care of that patient and who is in that team. And the complete documentation is important. Otherwise, we won't understand or know that what are the agents which caused it, and so that we cannot be able to prevent the future such exigencies. So we need to look at the anesthetist note. So it's very important to understand the perioperative hypersensitivity team anesthetist plays a major role, and any surgical or other perioperative exposures like the disinfectants, LAs, dyes, and all has to be taken into account. And details of all the procedures like putting a catheter, the stents and everything has to be meticulously put into that note. So this is a prototype of the data collection form for the POH. This is published by Laguna in a good journal. We are using a similar for our hospital. It is our hospital prototype, but this is a common freely available, and it can be used and modified for each and every hospital where one is and has to be there in the OT. So the most important thing is, if you see, is along with the identification, that is the date. Most important, if you say, that is the time it started and the time of the reaction starts. So temporal association, there has to be one of the key factors which help us to identify the culprit drug, along with the other, like the features of the causality, which Dr. Pandey was talking about, the biological possibility and all. But first and foremost is the temporal relationship when the drug is given and when the reaction started. And all the drugs has to be mentioned over here, dosages and time. This is usually a sister helps it, but no matter whether you know that it cannot cause, but it has to be put into the proforma if the patient has got during the time of induction or during the surgery or during the time of the reversal. It has to be put over there with the dosage and the time, and all the symptoms has to be mentioned very meticulously, because this proforma actually guides the future decision making for these patients. And the investigations, I'm just coming to it, the investigation, only few which we can do at this juncture. So routine investigations really pertaining to the allergy has to be deferred. It is not done during that time. So usually these investigations are done maybe 1 to 4 months post the event, when the mast cells have actually, it has regranulated, replenished itself, and patient is at safe of undertaking that investigation. And obviously we say that 4 to 6 weeks is the minimum time period. We do not investigate for the drug allergies before that. But what we do at the time, we actually can send a tryptase level, because tryptase is a marker for the anaphylaxis. But we know that the tryptase are in 2 forms, that is the pro-alpha tryptase, which is a marker of the mast cell burden we see in mastocytosis. In anaphylaxis, it's basically the beta tryptase, which goes up. So it has to be sent, usually it has to be within 1 to 2 hours, maximum 6 hours. And again, a repeat sample has to be taken 24 hours later to see that whether this level has come down, and also to understand what is the base, what was the baseline for that individual patient. Normally we take that anything less than 11 to 13 grams per liter is the normal values for the tryptase level. So we have, these are the, like the skin tryptase, the intradermal, and the in vitro, that is the serum tryptase and the immunocap. And all these things are basically has to be done later, except the tryptase value, which has to be sent at that juncture. That is basically of a research tool. We do not do it, but we need to have an understanding that it can be done. It's useful in the neuromuscular blocking agents. And though we have this marker upregulating CD63 and CD203C, a recent report says that CD203C is itself can be a marker for the upregulation of the basophils. So while we are doing the skin prick test, always remember the non-irritant concentration of the drug. So SPT and the IDT constitutes the main diagnostic allergic evaluation, which has to be taken 4 to 6 weeks later. So it is how it goes. If there is a clinical history, then and the history of the peri-anesthetic allergic reaction, and we have the data on the culprit drugs, the things are easier, so we can go on like this. But if we do not have any data, then we do for a standard the test, a standard test batch we have, so that we can employ on most of the patients, and that's what we do. But remember one important thing: if there is no history of the peri-anesthetic allergic reaction, allergology study is not needed to be performed. We get numerous calls and numerous requests by various departments, like to perform, this patient has a food allergy, this patient has an allergy to the pollens, the patient allergic rhinitis. So this patient, can we take on the patient, have a drug allergy test done before the patient is taken for the surgery? No, it's not needed. Only if there is a history and suggestive of some drug allergies, or there may be a history of the perioperative hypersensitivity before, we usually consider the patients. Otherwise, it is unnecessary. It is not needed, because that usually increases the cost and may give rise to the false sensitizations, which is actually not allergy, which has no clinical relevance for that matter. So if we do not have any drug, so this is usually the drug list which can be used. There is all the muscle relaxants and the hypnotics and the opioids, including, always we should include the chlorhexidine and the latex in the protocol. So management is basically the anaphylaxis management. There is no need for iteration. Epinephrine, epinephrine, epinephrine is the treatment. And that is how we do the management according to the ACLS protocol. And we just check the patients up. But at times it's important to understand that these patients may not respond to the epinephrine. And there's an alternative that we have to keep in mind is basically it is the glucagon. And another important thing we have to keep in mind while giving the epinephrine, at times it happens that the patient of a perioperative anaphylaxis, given epinephrine, patient deteriorates. So this is the epinephrine induced, usually this is the term which will come up, that's the Takotsubo syndromes. And we have reported 2 cases of the Takotsubo syndromes, where basically there is acute reversible dilatation of the left ventricles, but that is caused by the drugs. And the 4 variants, the common one is the balloon dilatation of the left ventricle. It is a reversible thing, manifests exactly like an acute coronary syndrome. So prevention is the most important thing. We pre-medicate the patient can H1 antihistamines, but remember, all this pre-medication does not prevent anaphylaxis. Okay, so we can give only slow injection of incremental doses of the drugs. It can reduce the reactions and make it a more milder. And the basophil-induced histamine-releasing agents like the opioids, NMDAs, we should be very cautious about it. And always antibiotics should be given before the anesthetic agents. Otherwise, we won't be able to understand, because anesthetic agents may mask many of the signs and symptoms. And this natural rubber latex-free environment in children with myelomeningocele, but we know these days we are hardly using this. And there is no place for preoperative screening when there is no history of drug allergy. It's very, very important, because you will get maximum number of referrals for this. So we conclude that POH is the most challenging of the drug allergies. Involvement of the anesthetist is essential during the workup. Workup of a POH needs an anesthetist, because the anesthetist understands and the perioperative environment much better than a physician or a pediatrician, or for that matter, a pulmonologist. So his or her involvement is of paramount importance, and the patients needs to be informed properly, and the Indian data needs to be generated for the same, which is basically lacking. And this actually is an impediment towards the development of the treatment plans, which can be implemented all over the country, and we can give specific directions for all, which will be helpful for all of us in managing, detecting, evaluating, and also preventing such incidents to happen in the future. Thank you so much.
Thank you, Dr. Moitra, for a wonderful talk and enriching our knowledge on a less traveled path. Any questions? Because we have time left.
The anesthetic agents are known, which will be causing the anaphylaxis as such. So is there any provision to do test dose or any prevention purpose?
Yeah, see, the thing is that for a particular patient, okay, if you know that this agent has caused the anaphylaxis in the past, then we do not say that you do the test dose. You can use the alternatives, like for the NMBAs, as you have, apart from like not using the steroid moieties, like the rocuronium or pancuronium, you can use the benzyl isoquinolines, that is the etracurium. Similarly, for the local anesthetics, use something, you don't use amides, use the ester, but we don't have ester in India. That's a drawback. So that is what we use. Test dose, actually, what do you do in a test dose? You give a test dose, okay, that's a prick test or maybe an intradermal test, and you see the reactions within a short time. Number one, non-irritant concentration of all the drugs is not there. That is important. So that means for the drugs for whom you do not have a non-irritant concentration as given by the ENDA guidelines, so you need to do a serial IDTs, which is not possible. So you're not doing a serial IDTs, there are 2 problems. You can get a false positive reaction because of the irritant concentration of the drug, or because maybe the direct massive degranulation through the various receptors. So which will lead on to a false positive, and you may land up not using that drug, which would have been safe in that patient. Another thing is that we do only a test dose and see the reaction within say 10 minutes. But you do not see the delayed reaction, which can occur some hours later, maybe 1 or 2 or 3 hours later. So that means that the delayed reaction at times can be life-threatening. So you get a false negative result and you give the drug to the patient. There's a false sense of security that you get. Give the drug to the patient. Patient lands up in a severe reactions, and that makes the scenario more difficult to understand.
Thank you, Dr. Moitra. And I would like to take this opportunity to thank the organizers for giving us this chance to be the chairpersons for the panel. Thank you.
Thank you, sir, for chairing the session. Sir, please be there for the photograph. Dr. Sushil Pandey, sir. Dr. Rajkumar Kiratkar, sir. Dr. Kiratkar, sir. Please collect the mementos from the registration counter. Now we go ahead with the next session. I would like to invite our chairpersons for the next session, Dr. Suchit Bagre, sir, and Dr. Rakesh Gupta, sir.
A very good morning. Hello. A very good morning. Welcome to the fourth session of our conference. We have two talks in this session. The first one is by Dr. Arif Ahmed, sir. He is MBBS MD from CGS Medical College, Mumbai. He has done his clinical attachment in allergy and immunology at the Royal Manchester Children's Hospital. He is certified by European Academy in Allergy and Clinical Immunology. He will be speaking on CMPA, Diagnostic Dilemma. Over to Dr. Arif Ahmed, sir.
Hear me? Good morning to everyone. So they said it's a cow's milk protein CMPA diagnostic dilemmas. Perhaps slightly with due respect, I've slightly changed the topic to dilemmas because everything is a dilemma about cow's milk protein allergy. And as we go through, I will explain to you. Okay, so now the background for this is the cow's milk protein allergy is a common food allergy encountered in childhood, infancy, and is a challenging task, okay, for both the practitioner as well as for the parents. In exclusively breastfed infants, children, they have milder reactions, and usually it is associated with the family history or other atopic conditions. Now, if you look at the prevalence, it is 5 to 15% in normal normal infants will have symptoms such as cow's milk protein. 16 to 42% of the infants may present with a gastroesophageal reflux, and in 5 to 7% of children who are formula feeds will have CMPA, and in exclusively breastfed infants, it is just 1%. So, and it has got a very high remission rate, 45 to 50% of infants by the age of 1 year, 60 to 75% at 2 years, and 85 to 90% at 3 years. So with this background, I would ask the audience, how many of you have seen, say, more than 3 to 5, more than 3 to 5, one, everybody may have come, more than 3 to 5 cases in your practice? We have one. Anyone? We have only one person who has 2, okay? More than 3 to 5. One, not 1, 2, more than, I say. So the reason is, for this, I'll explain in the next slide why you are not seeing the cases. Say the presentation is like this. We can acute IG immediate reaction occurring within less than 2 hours with rash or urticaria, wheeze or vomiting. It could be as a delayed reaction, non-IG mediated or mixed, which will occur more than 2 hours with mild to moderate eczema or reflux. Or it can come with a severe CMPA hypersensitivity, anaphylaxis with severe eczema or faltering growth. And the last one is a subtle reaction with behavioral-like changes like hyperactivity, GI symptoms like diarrhea, constipation. And this is the problem out here in the presentation. You are expecting mainly as an acute IG-mediated reaction or as a severe CMPA hypersensitivity. That percentage is very, very, very low. And that's when the child will present like this, then you will think of cow's milk allergy. But the majority of the cow's milk protein allergy may have a subtle presentation or may present with delayed reactions which are non-IG mediated. And it is high time that you start suspecting CMPA and looking for CMPA in your practice. So there are different protein components in the cow's milk, casein and whey fraction of milk, which may be sensitized to various proteins. And cow's milk allergy may persist till late adulthood if it is associated with other food allergies. But if it is isolated, just only cow's milk protein, then it will resolve by itself by 4 to 5 years of age. Now, there's another entity which is a non-IG mediated reaction, and this is where the crux of the problem comes. Non-IG reaction which occurs within few hours to days. Abnormal symptoms are more common like gastroesophageal reflux, infantile colic. If you have infants coming with stool in blood, okay, mother says the child is passing, start thinking in terms of CMP, cow's milk protein allergy. Anemia and failing to gain weight adequately, exacerbation of atopic dermatitis or the involvement of the respiratory system like cough or wheezing rarely. There may be, when there's a causal or correlation with cow's milk, exclusion from babies and mothers' diet, if exclusive breastfeeding for 2 to 4 weeks, the symptoms will get much better. And then after 2 weeks, the symptoms will get better, and then you can reintroduce after 4 weeks. So if you want to establish cow's milk protein allergy, the best way clinically is to exclude cow's milk from the diet, okay, from the baby's diet, and if possible, from the mother's diet, okay, and there'll be a resolution, the improvement in the symptoms within 2 weeks. Now, what is the differential diagnosis? It can be extensive, okay? I mean, it could be other food allergies, it could be a lot of GI disorders, cystic fibrosis, pancreatic, and many infections. We are not going to get into that. So IG on non-IG mediated reactions cause either type of reactions or in combinations, okay? Symptoms will occur for IG within 2 hours, which may be form of urticaria, angioedema, vomiting, diarrhea, or it may be a respiratory symptom, sneezing, rhinorrhea, cough, wheezing, or chest pain. It's a broad range of symptoms can be there. The skin symptoms will be present as rashes and eczema. If it's a severe allergic reaction, then anaphylaxis. That is very easy to pick up in that case. So if it is the IG-mediated reaction, then you can diagnose it by a skin prick test or a specific IgE. Now, with the problem with the specific IgE, there is a problem with specific IgE, which can be solved with the CRD, which is a new test, component resolved diagnosis, because it also helps in the prognostication of whether you're going to outgrow the food allergies or not. So the final confirmatory test is the oral food challenge. So children may undergo challenge tests every 6 to more or 12 months to assess if they can be able to tolerate the milk. Few days for the reaction to appear in non-IgE mediated CMPA. You undergo a challenge test in phases in hospital settings under the supervision of allergist or a person who is trained for it. And why do you do the challenges? It can be done for various reasons. Assess tolerance to a particular foods. If avoidance of any foods are happening, guide the parents to reintroduce the foods again in the children's diet. In cow's milk protein allergy, the challenges initially we do with milk containing foods, which are least likely to cause reaction, and slowly moving on towards the milk. So what are these milk containing baked items? Biscuits. These are the milk containing foods. Once the baby is tolerated that, then you get on to the milk. So there's a milk ladder. Lack of time, I cannot tell you what is a milk ladder. We can work it out in a workshop. Okay, that's milk ladder will be helpful in subsequently doing the challenges, re-challenges at home as well as in the hospital or in the home setting also it can be done. So if you think there's a reaction, severe reaction is likely to occur, then you should do it in a hospital setting. Otherwise, for certain cases, you can do it in a home setting also. So now take the first case scenario. So we have a 10-month-old NRI girl. She comes to me with atopic dermatitis, was bottle fed for the first month, then went to breastfeeding, weaned at 6 months. Diet is strictly vegetarian. She's on pulses, wheat. Look, this is important. She's on wheat also. Rice diet, vegetables, and occasionally fruits. Both mother and baby are off milk since reacted adversely in the form of severe rash and vomiting. That's what she was when she came. Now, this is the picture. On one side, you have the specific IgE. The other side is the skin prick test. So milk you are seeing is 51. And the skin prick test was not tested. Now, if you look very carefully over here, that milk is 51. Almond is 89.40. Skin prick test 3 mm. She's taking milk comfortably. Gluten is 91. She's taking wheat very comfortably. So milk is far less. So in a way, your total IgE, specific IgE is not able to help you out. You understand? So this, how do you explain this? The clinical one ultimately is the best. So in such scenarios, what will really help you out is this new test known as component resolved diagnosis. It's for the first time in India. Now you can predict whether the child will develop anaphylaxis. You had a lecture yesterday on this, whether you will outgrow your allergy, whether you can enjoy the food in the baked form, cooked form, whether the dust mite allergy will respond to treatment or not also. And that's 300 component resolved diagnosis with 300 allergens using a microtech technique with just 3 ml of blood at the molecular level. So now you take the first case. This is Thansi, 5 years, 9 months, skin prick test was 6 mm. She reacted to milk. Now this is the component resolved diagnosis, CRD report for milk. BOS-D is more than 50 strongly positive. This is negative, BOS-D4. Casein, that is D8, is very strongly positive. The most important thing in the milk, which will help whether you are going to develop anaphylaxis or not, whether you will outgrow your allergy or not, is casein. So you really have to know whether this casein is positive or negative. If casein is positive, there's less chance of this child outgrowing the allergy. There's a high chance of this child developing anaphylaxis. Okay. So camel milk is also positive. Goat's milk also positive. Now mare's milk is negative. Why is mare's milk negative? That is the donkey's or the horse's milk. Is because the mare's milk is the closest to the human milk. It has the lowest of the casein content, and that is why. So this child, if you ask, although the guidelines do not recommend mare's milk in such situations, but there are enough papers which have shown the help that mare's milk can be given in presence of cow's milk protein allergy positivity, provided your skin prick test or your specific IgE is negative. You could have done a challenge in the office setting, okay, or a home setting, and to mare's milk, and that is negative, then the child can comfortably take maize milk. Next case, okay, Aran Khan, 1 year. This child also from US, this reacted in the form of wheezing at the age of 9 months, okay, to severe, on ingestion of milk. Earlier, there was no wheezing. And this is his report where he has shown positive for all, including casein, which is 4.30. So it's a much lower, but here also maize milk is negative. So they also can try maize milk in this patient. And then the last one is this case 4, where the cow's milk is partially 4.5-year-old female, strictly breastfed, strict vegetarians, reacts even to the skin contact. Okay, the milk will touch the skin and the child will get rash. And it's more than 50, strongly positive for all the components, including to all types of the milk. Maize milk, goat's milk, sheep's milk, every milk is positive. So this child is, should be just left alone, keep away from all milk and milk products strictly. So now that this is a case 5, making your case more and more complicated. Harshita is a formula-fed, day 15 episodes of few small, loose, watery stools. Over 3 months, persistent motion requiring IV fluids, settle only with protein-based formula. Motion recurred on reintroduction of milk in any form, including soy-based. So what do? You do the CRD, you do the IgE, everything is negative. Okay, that's what it is. So what is it? Food protein-induced enterocolitis syndrome. That's an entity you should keep in mind and start thinking and the child on that basis. So what would be the management? The management would be basically allergen avoidance. Okay. Symptoms will resolve within 2 weeks of stopping the cow's milk protein. Continue breastfeeding in infancy till 2 years of age. Mother exclude all milk and milk products from the products from the diet. But mother in that case should be given calcium and vitamin D supplements. Formula is the baby. The problem comes if the baby has been formula fed. Okay, then what are you going to do? Then in such a case, because you can't give mother's milk, so you have to give extensively hydrolyzed milk formula. It's been advised. And what is the extensively hydrolyzed milk formula? It is a cow's milk formula where the proteins are broken down into smaller portions by heat or enzymatic reactions. And this will help in faltering the growth in the children on formula feeds. So even if the symptoms persist on this hydrolyzed formula, then what you it is a case of CMPA, then you should give a trial of amino acid formula. But over there, the biggest problem is palatability. Palatability is a huge problem. You should refer to a pediatric dietitian to maintain the balanced diet while excluding allergies. You should have a well-written action plan, okay, outlining the steps in case of allergic reactions, when to use adrenaline, mild reactions. You can just use oral antihistaminics. And patient and caregiver should regularly review with the emergency action plan. There are alternative milk sources like soya. I'll come to it later. Other milk, mammalian milk like buffalo camel have been advised be avoided in children with cow's milk allergy because of the biosimilarity, as I mentioned. But there is some exception, I said, with donkey's milk or the horse milk. Other sources of milk are the oat, coconut, or almond, which can be done up to 2 years of age, depending on child's nutritional status and concomitant allergies. Rice milk is not recommended in children less than 4.5 years of age. You should always be giving calcium fortified supplements. Symptoms of CMPA with persist beyond 4 to 5 years of age. Patients need to avoid milk and products for a longer period of time, and their nutrition should be stressed under the supervision of a pediatric dietitian. Now, what about soy milk? This isolated soy milk based formulas provide nutrition for normal growth and development term infants. They are suitable alternatives for infants over 6 months of age. Before 6 months, they should be avoided. The reason is because soy formulas contain this phytoestrogen content because of that. The other problem is 10 to 35% of children with CMPA are also sensitive to soya. That's the other big problem. So if soya is negative, you can safely give soya milk. The newer modalities of treatment is what we call is oral or sublingual immunotherapy, but you can try it out with some companies giving you the reagents for doing it, but otherwise none of the international guidelines do not recommend it at the moment. right? And for further reading, you can go through my book, Winning Over Allergies, Myths and Facts. Very soon I'm coming up with another book called Overcoming Food Allergies in a matter of short time. You should go through that. And with these words, I thank you. And that's my website. Thank you.
Thank you, Ahmed sir. Though this is a very common problem, but we miss because we don't keep a vision to diagnose the cow milk allergy and going into the depth. And most of the time we treat the patient symptomatically. That could be the one of the reasons why we miss and label the cow milk allergy in our routine practice. Thank you, sir.
Questions we can take.
Hello, sir. Good afternoon for the wonderful session. Thank you. I would like to ask on a case. You mentioned a case number 3, Arif, a 1-year-old child with cow's milk protein allergy. The SPT was positive. So I would like to ask, do you do a skin prick test on a 1-year-old child? If you, then how do
Skin
you?
prick test can be done at any age, but the lower the age, the lesser the reactivity of the skin. That is the problem. Okay. The lower the age, the lesser is the reactivity of the skin. So CRD would be a better test or a specific IgE.
So in the SPT, do you do any sedative? Do you give any
No
sedative
sedation
or
required.
any-
Never sedate.
So at a
Just do it-
1-year-old child, is it?
Yeah, you can
is
do
it
it very safely. No sedation for any children. And I have never done a sedation ever in my life.
We were taught like it is safe above 4 years.
No, you can do it at any age. We do it in 6 months, in 1 year, or all ages.
6
You can,
months.
yes, we will show you videos also if the time permits, but it's not. Don't worry about it. Any other? Yes. Best age to? Yeah, at any age you can do CRT. Whenever you suspect, just like a suspect, you do a CRT.
Sir, what should be the normal age to introduce the cow's milk?
Normal age. So as I mentioned over there, at every 6 months interval, you can, depending on how the child is doing, you can challenge reintroduction, but ideally at 4 years of age.
So
4 years is the right age. Usually most of them will outgrow by 4 years of age, but now cow's milk allergy are 2 types, the IG mediated and non-IG mediated. Non-IG mediated at 2 years of age. IG mediated at 4 years of age. But if the parents are this one, at every 6 months interval, you can try in office setting. Hospital setting will be very costly. I mean, and that is in a milk ladder. It's like they start with a drop of pea drop, like grain size milk. Then you take a pea size milk. Then you take a 1/4 spoon. Then 1 spoon, like that you go. First, you have to start with a rice size. That's milk ladder is a very important thing. Okay. So any others?
So does it vary the results due to the physiological factors, like if the child is having fever or any viral infections, there can be variations.
The previous, you have heard the previous lecture on anaphylaxis.
Still the gold standard, the book of thought says the SPT only.
What your question is for?
My question is, you said a 6-month child can also be done, the component dissolved method. So does the value vary according to the physiological components of the same child? Because one book of thought says SPT being the gold standard still. So are you trying to convey the message that we can go on the specific serum IG values?
The thing is, SPT will say whether you're positive or negative. That's all. Nothing more. Does it say whether it's BOS D1, BOS D2, BOS D4, BOS D8, that is casein, that is D8, which is the most, that is casein, which is the most important. Does it give that information?
If we use SPT of the same only casein, though it is not available, theoretically, if we try to do the SPT
You
for
can,
the same,
as I said,
then that
SPT
would
also can be done at any age. Any age it can be done. And SPT, I agree with it, is the gold standard. There is no doubt about it. Okay, I'm not trying to change that. But if you want further information about your positive skin prick test, then what is it? Is this CRD, and they're finding whether casein is positive or negative is important. If your casein is negative, you're lucky.
Then we can
Child will
introduce.
outgrow.
Hello. Hello, sir. Better than cow's milk, I should prefer the buffalo milk.
No. Yeah, I said. Now what all the guidelines say that if it is cow's milk protein, that's I'm talking about guidelines. CMPA,
Okay.
if it is positive, then all other mammalian milk should be avoided.
Okay.
Okay, that is what the guidelines recommend. But there are a lot of papers which have shown that mare's milk, that is horse or donkey, which is quite costly to obtain, can be given if your test is coming negative, skin prick test or the CRD report, and if you have done a challenge in office setting because it has come negative, you can safely give him that, and that will really help the child.
Okay, sir. Thank you.
Thank you, sir. Thank you very much.
Thank you.
We extend our thanks to the organizer for giving us a chance to chair this session. Thank you.
Thank you, sir. Now, going ahead, we will have our panel discussion first. The topic is under 5 asthma and asthma mimics. And our moderator for this panel discussion is Dr. Vinod Gandhi, sir. I request him to please come on the dais. And the panelists for this discussion are Dr. Jayant Joshi, sir, Dr. Anjali Edbor, madam, Dr. Sandeep Golar, sir, and Dr. Manish Jain, sir.
Good morning, friends. At the outset, thank the organizers for giving us an opportunity for this panel discussion. I would like to call my panelist, Dr. Jayant Joshi. He is from Pune, senior pediatrician from Pune. He is attached to Sahyadri Hospital and Dinanath Hospital. Dr. Manish Jain, he is attached to Sevagram Medical College, Wardha. Dr. Sandeep Golar, he is attached to Government Medical College, Nagpur here. And Dr. Anjali Edbor, she is yet to join, but she is attached to Lata Mangeshkar Hospital, Nagpur. So we have distinguished faculties, all of them are professors. Should we start? Madam is yet to come. She is on the way. Madam, हम चालू करें? अच्छा. Dr. Anjali is on the way. Anyway, we'll start with the panel discussion. So, friends, all of you know that asthma, we know all the definition of asthma. It's a chronic inflammatory disease of airways, which is typically characterized by inflammation, obstruction, and hyperresponsiveness. The pediatric asthma differs from adults in the sense that the lung is growing and the children have smaller airways as compared to adults, and they have lower inspiratory flow rates. And for this reason, they will show manifestations of airflow obstruction to various other triggers, not necessarily to the disease. And because of the small children, there is always a difficulty in performing objective lung function test. So in adult asthma, it is always, nowadays it is always said that you have to document this airflow obstruction by doing lung function test. And these lung function tests are very difficult in children less than 5 years. And that makes all the more the asthma below 5 years all the more difficult. Now, why should we discuss under 5 asthma? In under 5 children, asthma is many times labeled as wheeze, because wheeze is a clinical manifestation and asthma is a diagnosis. So many times in under 5 children, the asthma is labeled as wheeze. Wheeze and cough, they are common symptoms of many other diseases, including viral infections, foreign bodies, tuberculosis, everything, anything which produces any involvement of airways can result in cough as well as wheezing. And therefore, it is difficult to diagnose asthma in this age group. Because again, in this age group, the asthma is heterogeneous. There are a lot of different presentations. And therefore, we should see how to manage these symptoms before labeling them as asthma. The first question was to Dr. Anjali, but she's not there, that how common is asthma in under 5 children? Anyone else? Dr. Sandeep?
Good morning. Asthma, around 20 to 48% of under 5 children have reported exacerbation in the first 12 months. 23 to 42%, these are all the statistics of under 5 Vs as compared to 15 to 1000 in 6 to 7 years. Many are diagnosed and treated as pneumonia. Almost half of these children may outgrow asthma. So wheezing is quite common. Asthma is common, but to say asthma, you have to be very careful and judicious whenever you are diagnosing asthma.
Thank you. Sandeep, you can continue. How will you suspect asthma at this age?
So cough and wheezing is not a symptom for asthma. All that wheezes is not asthma. So to diagnose asthma, you need a few things. One is whether the child has cough, which comes mostly at night, which is non-protective, whether the child wheezes and has cough or is breathless, whether the child has infections which are going to the chest without cold, whether the child has any responsiveness to a supposedly trial of inhalation corticosteroids, which is given for a period of 2 to 3 months, after which, if you remove the trial, then the child starts worsening. So reduced activity, difficult breathing with exercise, laughing, crying, wheezing, and cough, which is non-productive, more at night, mostly we should be suspecting asthma.
And a supporting family history.
Yes.
That would also help.
Yeah. Obviously, you need to exclude the alternatives for diagnosis of asthma.
Before we move ahead, we should always make a point that if any of the possibilities, what we call as asthma mimics are possible. Dr. Joshi, what are the different asthma phenotypes? They say in preschool age, asthma has different presentations. So what exactly is meant by these different presentations?
So actually, this has been an exercise to qualify and to classify asthma below the age of 5 years. However, there are no sacrosanct definitions. Earlier, Tucson suggested a definition which was based on the episodic viral wheezer and or a transient wheezer and a frequent or persistent wheezer. So he was trying to essentially categorize on the basis of a young age where the child probably gets a wheezing episode only in relation to the upper respiratory infection. And most of the times these episodes would not last beyond 7 or 10 days. And the child would be absolutely normal between the 2 episodes. So that was considered as transient wheezers. And then the other category, which was probably the ones who were symptomatic even in between the attacks and they were getting it frequently. But again, there were fallacies in this classification also. Then came something which was called as early wheezer, on a persistent wheezer or a late onset wheezer. So the late onset wheezer were essentially the ones probably who carried on as asthma in the later life. Of course, they had other qualifying criteria like a family history or some kind of an atopy besides respiratory allergy. So all these features were there. But I think the more composite classification now is proposed by the GINA guidelines, and that classifies it as the probability index. And on that probability index, probably it is a very clinically oriented classification wherein probably you can make a fair assessment of how the child would progress over a period of time. And that deals with the number of episodes per year, that deals with the duration of episodes and how the child behaves between two episodes. So suppose the child has got more than 3 or 4 infections in a year and the episode is lasting less than a week and the child is absolutely normal, probably this is the category which probably is the ones who probably will not have asthma. Then there is a category wherein probably you will have little more frequent symptoms. They probably would require some kind of an intervention at that stage, but eventually probably would outgrow the asthma by the age of 5 years, as you mentioned in your first slide. And the last category are the ones which are frequent wheezers, and they are the ones probably would have probably a classification of being called as asthma, and they would carry forward as asthma. So, but one thing very important to emphasize is that if you see this chart, which is taken from GINA guidelines, there is a arrow which is directing. So as you know, asthma is a dynamic condition. A child can go from first box to other. And that's why you must keep the options open. Some children probably would have uneventful recovery, even though they're frequently wheezing, but some children probably would have a worsening in spite of their atypical status. Thank you.
Basically this is a dynamic, the criteria are interchangeable. The conditions are interchangeable. A child who may be having a low probability of index of developing asthma now, maybe in future, if he is exposed to more triggers, may go on to go into the third box and will have a high probability of development of. The treatment will depend on which category he is at that moment.
Yes.
So basically one important thing in asthma, the treatment is directed towards current symptoms. Exactly. It may not alter the progression of the disease. So what is the current status that will decide what is going to be the treatment.
Yes.
Dr. Sandeep, is out of all these cases, is there any way we can predict which patients are, because this is a question parents are always going to ask you, which patients are going to develop persistent asthma in future? Even if right now they qualify in the high probability index, are there any other points?
Sir, as has been mentioned that asthma is a very dynamic process and most of these categories are interchangeable. The hyper-responsiveness, which might be there initially, might respond later. So to predict persistent asthma, they have a questionnaire. The predictive value of this questionnaires has not been so well proven, but still, for most of the cases, we still use asthma predictive index, which is a very good predictive tool. It helps to differentiate what is an early and a persistent wheezer. And asthma predictive index recommendations are valid for children less than 4 years of age. The totality of patients who might get asthma is 76% for future risk and 95% will have negative risk for asthma in future. So one of the very good clinical tools which we can use in office practice is an asthma predictive index, and it helps us to differentiate whether this will have a persistent wheezing or this is an episodic one. So what it necessarily says that you have to have more than 4 episodes per year of wheezing lasting for more than 1 day, affecting a child's sleep with 1 major and 2 minor criteria. The major criteria being parents with asthma, a physician diagnosed condition of atopic dermatitis, allergic sensitization to allergens, and minor criteria which are allergic sensitization to food, eosinophilic count which is more than 4%, and wheezing which are apart from cold.
This asthma predictive index was first reported by Castro Rodriguez in the year 2000, and it kept on modifying. So the earlier we used to have different major criteria and minor criteria. In the current GINA guidelines, they have changed the major criteria, allergic sensitization to aeroallergen. This has been added and the history of allergic rhinitis has been removed. And in minor criteria, the allergic sensitization to food has been added
recently.
And something has been removed, but I don't remember exactly. Now, Dr. Jain, once we have seen the history and the presentation, what are the ways by which at this age we can come to a reasonable diagnosis of asthma?
So remember, one has to remember that at very first interaction, it is not easy to label patient as asthma patient. And history is most important in labeling as asthma. Suppose if you have more than 3 episodes of wheezing per year, then that is one of the indications that patient may be having asthma. And remember that wheezing is very common and cold is one of the commonest trigger. But if you have other triggers apart from cold, which triggers wheezing, then again, it is an indication towards that patient can be a asthmatic patient. And symptoms usually lasting for more than 10 days suggest that it is likely to be asthma. And if you have favorable family history, that is, if any other person in the family has history of allergy, atopy, or may asthma, then again, it is a strong pointer towards the diagnosis of asthma in that patient. And best thing is the response to the controller treatment. Suppose if you start on short-acting beta agonist for control of wheezing, patient responds very well. And the moment you stop that drug, the symptoms reappear. And these are the strong indications that this may be a case of asthma.
So typical what Dr. Joshi had described in the high probability box, these are the children who are more likely to develop asthma. But in this also, if there is a positive family history, if alternative diagnosis we have reasonably ruled out, and most important, response to controller treatment with a low dose inhaled corticosteroid. So if we start in low dose inhaled corticosteroids and the child improves, that probably proves that this child is asthma. But how can we be sure? If we stop the treatment, the child remains stable for a few months and then again reappears with the similar symptoms. And that time, again, if we start the treatment, again responds. So maybe in younger children, we may give 1 or 2 or 3 therapeutic trials before we come to a conclusion that no, this child definitely responds very well to low dose inhaled corticosteroid. Once we are sure that this probably is asthma, in that case, we may, Dr. Anjali, please join on the panel. In that case, we can continue with the controller treatment for a long time. So once we are sure that it is it has been diagnosed as asthma, in that case, we will continue the treatment for pretty long time. Then it will not be therapeutic trial. In that case, we will call it as a treatment.
So I think if I may just add to what you said, most important thing is to rule out the alternative diagnosis.
Yes.
And that is something. So there are a few tips which probably will point towards the possibility of a so-called atypical wheezer. And those are the ones probably you will have to shortlist and mark out. A child presenting at a very young age, a child presenting with more of a upper respiratory complaints, the child who has got failure to thrive, a child who has got a recurrent persistent wet cough, and a child who probably does not respond in spite of a correct supervised inhaler treatment. So these will be the pointers wherein you will think of atypical wheezers. And these are the categories wherein you think of all other possibilities like cystic fibrosis or primary immunodeficiency or all those anatomical features. And these are the ones which must be ruled out before you label someone as an asthmatic.
Yeah. So definitely in under 5 children, at each step, we have to make a diagnosis of whether they are asthma or whether they are not as asthma. If they are not behaving as asthma, we should always make it a point to identify this atypical presentation, what you said. And these patients may be having something called as asthma mimickers. In young children, viral infections are very common. And these children react so much to viral infections as wheezing. And therefore, to label them as asthma, we have to be pretty sure. And that is the reason this therapeutic trial has come. We may have to give it repeatedly before we come to a conclusion. If there is a marked clinical improvement and deterioration after stopping, this supports the diagnosis of asthma. As what we saw in first child, 50% of these kids are automatically going to improve without developing into wheezing later on. What you said in Tucson classification as early wheezers who by the age of 6 years, they were free of
transient wheezers.
Transient. Yeah. Beyond that, early wheezers. Early wheezers. They did not persist. They did not persist beyond 6 years. So there may be more than 50% of kids less than 5 years who will behave like this. And that is the reason we have to give this therapeutic trial and stop it whether before we coming to any conclusion whether these kids need long-term treatment. These small kids are not capable of performing objective lung function tests. And this is the reason why we have to give therapeutic trial and again. The only tools available to us are history, examination, and response to therapeutic trial. This had been reported by Mr. Andrew Bush, who is the father of under 5 wheezing. All of us know, and as Dr. Joshi had just said, all that wheezes is not asthma, because there are many other conditions which may present as wheeze in under 5 children. So Dr. Anjali, first question now to you. What are these asthma mimics and how can you pick them early?
I think what are asthma mimics has been recently just briefed up by Dr. Joshi to us. So the conditions where usually children present to us with breathlessness are the viral infections. So we should always consider viral infections in under 5 to be asthma mimics. The second most important thing what we should think of in children is GERD. Then now which has come up in this era is obesity also has, though it is a comorbid condition also for asthma, but even obesity has been considered now as an asthma mimic. Then further, if you go for more chronicities, then cystic fibrosis, you have foreign body aspirations for acute conditions. You have, so these are some of the conditions where we need to know that these are asthma mimics and these need to be ruled out. And as Dr. Joshi and Dr. Gandhi has already said that we don't have enough tools to diagnose asthma. What we have is our clinical examinations. So a therapeutic trial and reversibility. Main important thing is the reversibility, which is a known symptom or a known pathognomic feature for asthma. So that has to be seen to diagnose asthma. Otherwise, we have to think of alternate diagnosis.
Yeah, as we see at this age, because the airways are small and they are hyperreactive also, so they may respond to many other triggers which are going to affect the airways. And the possibility of doing a wrong diagnosis in under 5 age is very high. Common. And that is the reason many a times it happens that if we are in a hurry, we may diagnose it as asthma and start the treatment. So we may miss if we have not taken a detailed history. And later on, when the child is not responding to our inhaler treatment, then we start suspecting what was the problem. So it is better that we take a detailed history before we start the controller treatment. And when we start the controller treatment, again, the child may be responder or a non-responder. If the child has not responded initially, then always a possibility of asthma mimic is there. Even if the child has responded, but the response is not continuous. Over a period of time, he keeps on coming again and again with manifestation. Possibility of some asthma mimic may coexist. As we have seen, GERD and asthma may coexist also. So it's not that asthma mimic is just a differential diagnosis. Many of the times, this asthma mimic may coexist as a comorbidity, as you said in obesity. So obesity, GERD are quite common conditions which may coexist along with asthma. Obesity probably leads to GERD and psychological factors which can manifest as asthma features.
Sir, another thing is that patients of asthma will never present to you as failure to thrive. So that is again one thing, like we can say that if there is a presence of failure to thrive as well with the manifestations of asthma, we need to consider alternate diagnosis.
And another thing is very early presentations. So if a child is presenting as 2 months or 4 months with very frequent or very severe wheezing, chances of alternative diagnosis are very high. Now, Dr. Sandeep, what are the common asthma mimics? There are many. You can enumerate some of them.
Which has already been spoken, that recurrent viral infections under 5 years of age, lasting for a lot less than 10 days, which are responsive to therapy, they are the most commonest cause of asthma mimic. GERD, cough which is with feeding, where there is where there are symptoms like hyperextension of hands, feet, post feeding, where there is evidence of failure to thrive. something which is coming very acutely, cough which is not responding with stridor, most likely to be a foreign body, or you might have infections which have not been treated, which are overlooked. Tracheomalacia, a child with multiple episode triggered wheezing who is not responding to bronchodilators. Think one of the differentials as tracheomalacia. Tuberculosis is a very common etiology in our setup, but to diagnose tuberculosis, there has to be a history of contact. There has to be failure to thrive. Congenital heart diseases likely to be picked up if you auscultate clearly, if you are able to demonstrate any cyanosis. Cystic fibrosis, primary ciliary dyskinesia, and immunodeficiencies. If there is affection of two systems, respiratory as well as GIT, in Indian setup, try to think of cystic fibrosis, immunodeficiencies as one of the probable etiologies. Vascular rings will have poor breathing, will have poor response to meditations, will have persistent noisy breathing. And for a child who is born premature, was ventilated, BPD has to be ruled out as one of the differential and atypical manifestation which can mimic asthma.
The cough in asthma is typically dry and it's non-productive. So it occurs at certain, more common at certain time like night time or after exertion, but it is typically dry. So whenever we are encountering a wet cough, the child may not have fever, but whenever we are encountering a wet cough, always think of some infective condition is occurring. Maybe lower down as persistent bacterial bronchitis, or in upper airways as chronic tonsilloadenitis or chronic sinusitis or something, which may also present with cough and wheezing manifestations. So, Dr. Joshi, GRD is one of the important mimic of asthma, especially in younger age. What is the relationship of GRD in asthma? Is it only mimic or any other?
No, there can be relationship in regard to the acid reflux per se. And because of the anatomical proximity of the upper of the lower respiratory tract with the GI tract, there is a possibility that there could be an anatomical pressure also. So sometimes in situations when there is a tendency to overfeed the baby, there is a possibility of regurg. But we are talking essentially about the small babies, preterm babies, who probably have a little error in swallowing reflex. And there is a palatopharyngeal incompetence because of which there is a likelihood that the reflux can happen. And these are the ones probably will not respond to your inhalational therapy because there is an element of continuous acid reflux. And that's why you need to, first of all, document it by means of pH manometry or some 24-hour studies. But then I think proton pump inhibitors play a vital role here. And over the period of time, as Madam rightly said, obesity in an older age group has a totally different mechanism. There, the possibility of overeating and causing hyperreflexia is a different part. But in small babies, where there is a palatopharyngeal incompetence, then there the association of GRD and wheezing episode are different. So you have to, depending upon the age group, your approach will change.
So in younger age group, GRD is quite common.
Yes.
And there it may present as a asthma mimic.
Yes, and more often than not, it will recover with age.
Yeah. Later on, this may present as a coexisting condition that many of asthma may have a comorbid condition of GRD. Sometimes GRD can also occur as a complication of asthma drugs. So most of the bronchodilators or even steroids which you are using, they can also produce.
Yeah, but that used to happen when you used to use more of oral bronchodilators.
Yes, definitely.
Theophylline and all these are probably now completely outdated. It has been a universal consensus now that the mainstay of asthma treatment is inhalational therapy. So now even giving oral bronchodilator, even the short acting ones are now coming into question ever since we have inhalers.
Now, as what we have seen till now, that early diagnosis of mimics is very important. The diagnosis of asthma is based on typical symptomatology and spirometry evaluation. A detailed history and good clinical evaluation is needed to clinch this diagnosis. So any patient who is showing atypical signs in the beginning or poor response to the inhaler treatment or inhaler low dose steroid treatment which we have started, clinicians should try to ruling out asthma mimickers at every step. We should maintain a high index of suspicion for early recognizing this patient, because this will avoid misuse and unnecessary exposure to asthma medications and their side effects. Dr. Jain, what are the red flags in history clinical examination which can point out to these mimics?
Dr. Joshi sir has very well covered this point. And to be very more specific, the red flag signs are like failure to thrive. And as you said, the very early onset of symptoms, and you have vomiting with respiratory symptoms, continuous wheezing, not responding to your inhalation therapy. And then you have not associated, the wheezing is not associated with the typical triggers, which we usually see in cases of asthma. And then you have some focal signs suggestive of serious involvement, like you have clubbing in that patient, and you have hypoxemia outside viral illnesses. So these are some of the red flag signs. And as far as the investigations are concerned, it depends on the age. Like if you want to do pulmonary function tests or you want to evaluate pulmonary expiratory flow rate, it might not be possible in small age, like under 6 or under 8 years, you may not be able to do that. So we are left with X-ray test. And if we are dealing with the older children, then we have PEFR. And we may ask the patients to do regular PEFR on daily basis. And if patient has 80 to 100% of his personal PEFR, that means patient is absolutely normal. That is a green zone. And if the personal PEFR is around 50 to 80%, that means he requires short-term treatment. And if the PEFR goes below 50%, that is an indication of severe asthma or exacerbation of asthma, and that needs intensive therapy.
What Dr. Jain was talking about, peak expiratory flow rate. Yeah. But in spirometry also, something which may be possible in little older children of 4 or 5 years, if we are unable to document obstruction, we should always, obstructive manifestation, we should always think of possibility of alternative diagnosis. And most important, as we have been repeatedly saying, if the child is not responding to therapeutic trial, always make an attempt to identify asthma mimics. Now, let's come to a case. This is about a child, Vikrant, 3-year-old child, who presents with cough, cold, low-grade fever, and breathing difficulty. On examination, he has a lot of wheezing. He has had 5 such episodes in last 1 year, and 3 such episodes were without fever. Episodes most of the time lasted for more than 10 days. Most of the times they were precipitated by, the cough was precipitated by running, laughing, or playing in early morning in the ground. Father has a history of allergic rhinitis. Now, what is the impression after seeing this case? What investigation should we plan for this child and why? What is the impression, Dr. Joshi?
Yeah, so I think if you look at the history, it probably qualifies into a frequent visitor category, the 3rd box of GINA guideline. This child has had more than 3 episodes in a year. They are afebrile episodes. They are lasting for more than 10 days. There is a family history of atopic tendency in the allergic rhinitis in father. So this child probably qualifies for receiving the trial of inhalational corticosteroids. Now coming to investigations, I think one important emphasis is that asthma below 5 years, after you have ruled out alternate diagnosis, is essentially a clinical diagnosis. So probably one would not advise any test for any confirmation here. Perhaps if the presentation is stormy or if there is no response as expected, one would think of doing a chest X-ray. But chest X-ray is to be done only for ruling out any alternate diagnosis, not for confirmation of asthma. And I think this is a child probably should go for a therapeutic trial of inhalational corticosteroids.
This is typical of what we call as multiple trigger ways.
Multiple trigger ways.
Typical multiple trigger ways. So ideally, or the 3rd GINA box of very high probability. So this kid should automatically go for a trial of low dose ICS. However, what Dr. Sandeep said, that if parents ask what if there is a what is the possibility of this child going on to develop asthma in future, maybe to qualify that asthma predictive index, we may get a eosinophil count done. But with a father having family history of allergic rhinitis and child having so many episodes of wheezing without fever, chances are that he has allergic induced symptoms.
But sir, it will confuse you more. First of all, it's a very non-specific indicator. And second thing, even if you get an eosinophilia, what are you going to offer? You can't treat them.
Nothing. As such, you are going to do treatment. So basically, no investigations are needed for this child. The only investigations which we are going to have is a response to therapeutic trial. If the child is responding very well to therapeutic trial, that probably would mean that he qualifies for long-term management of asthma. Dr. Joshi, what are the key goals in asthma? Now, suppose now we have come to the regular treatment of asthma. So as we say, stepwise treatment of asthma, what has been propagated by Jima. What are the key goals in asthma management?
So I think the key goals are basically, we have to ensure that the child has a comfortable respiratory pattern. The child does not have respiratory symptoms which are coming into the day-to-day activity. They are not disturbing child's sleep. The child's schooling should not get affected. We must also make sure that the child doesn't get acute flare-ups, because flare-ups can really disturb the child's schedule. And for that reason, I think we need to counsel the parents in a proper way. Once that confidence lines between you and the parents is established, and if you are ensuring that the proper compliance is achieved, probably the children will comply well. For small children, the treatment should be always done under supervision. Even the older children should not be allowed to take self-treatment. And you must make sure that the normal activity, we don't restrict diet, we don't restrict exercise. What we try to let them is to overcome the problem with the short-term solution. So even if someone is on a maintenance therapy, we don't really discourage sports activities. So essentially the idea is that the child should have minimum symptoms as much as possible, should have a quiet, nice sleep, and it should not affect the academics and the schooling pattern.
So basically, the goal of management is mainly two:
yes,
to control the symptoms and to prevent damage neither to the lungs, nor to the health of the child, nor to his regular day-to-day activities. Now, Dr. Anjali, how will you assess these kids before starting any treatment? Basically, continuing what we have just discussed.
When we come to the goal of assessing asthma, it has to be done at two levels. So one is the current risk, what the child is at, and how we will control the current risk of the child. Whether the child will respond to our short course of inhaled corticosteroids or not. And the second and the most important part in assessing asthma in this, the goal of treatment for these asthma children are the future risks. Because that is the future risks which are associated with comorbidities, which are associated with limited lung function tests, which can further go into restriction of lung function tests. So this is the most important thing where we need to assess the current one, whether what is the therapeutic trial, how is the child responding to the initial therapeutic trial, and then depending upon whether PFT can be performed in that child as per the age or not, we can assess the future risk of these children going in for chronicity.
Yes, excellent. Now, we have separate GINA guidelines for under 5 children. The GINA guidelines are for under 5 children, for children between 6 to 11 years, children, adolescents and adults. So basically adolescent and adults, they behave similarly, but the guidelines are different for under 5 children and children between 5 to 12 years. Now, these are always updated. So we'll talk about what are the current guidelines. Now, in this, there is a stepwise treatment, step 1, 2, 3, 4. Dr. Jain, will you tell us about what is exactly a step 1 treatment? In which patients do you need this step 1 treatment?
Sir, step 1 is usually in infrequent fevers. And this has these kinds of patients, they do not require regular treatment. And the treatment given is need-based. If patient is wheezing, then you can go for short-acting beta agonist till the symptoms they subside. And as we have already discussed, that role of oral short-acting beta agonist is no more there. So these patients basically require need-based treatment with short-acting beta agonists.
Are there any alternative treatment in step 1?
Sir, inhaled corticosteroids.
Other than inhaled
corticosteroids may be used, sir.
Inhaled corticosteroids. Basically, there is a lot of confusion. In India, we have been more using oral SABA, like oral salbutamol or terbutaline we had been using. All the guidelines say that we have to use inhaled bronchodilators. One is because of the side effects and probably more easily bioavailable. That was the reason. However, in poor countries, maybe because of cost factor, we are still using oral bronchodilators. Another important point which most of us see is giving intermittent high dose steroids. We see so many children. Now there are a lot of studies which are coming, and even GINA says that giving intermittent high dose corticosteroids is effective. However, it is associated with side effects. So suppose we have a very infrequent visitor, he is not on any regular treatment and has a significant symptoms at the beginning. So instead of giving oral steroids, he can be given a long dose, high dose corticosteroid. I think this one question Dr. Meenakshi had asked in one of the patients. So that time we were not very aware, but now it has come in guidelines that intermittent high dose steroids can be given at this age. Now, step 2 treatment. These are the children who need regular treatment. Now, what are these patients? What is the optimum treatment and what are the alternative treatment for this step 2 category?
Sir, before I go on to this question, just one clarification. This intermittent high dose therapy is to be done only by inhalational route.
Only inhalation.
Yeah. Second thing is that oral steroids in a routine OPD patient is not recommended. As like now we have almost banned using a oral bronchodilator. It is not a good idea. Even if there is an acute wheezing episode, they have to be always treated with the inhalation therapy first. Oral steroid only has a role for a child who has had an admission in a PICU for an acute flare-up or acute severe episode, wherein as a part of your parental plan or as a part of your action plan, we tell them that these are the measures and it's only a rescue steroid you will give. So I think in our society, it is not a good idea to just propagate this idea of giving an oral steroid for every anticipated wheezing episode. High dose inhalation steroid, still the last word is not seen, but up till now we were saying that inhalational corticosteroids in nebulized form have no role. Now again, GINA is changing.
GINA is changing. These
So,
are GINA's guidelines.
I think as you rightly said, the guidelines keep on getting updated every year. So I think there is no last word written on that. But I think what we have been following up till now is a reasonable standard. Now coming to this step 2 means that, as Dr. Manish said, that if a child is an infrequent wheezer, you will only advise as and when required inhalational bronchodilator in the form of a short-acting beta-2 agonist. But suppose this child is getting frequent symptoms more frequently, or it is taking a little longer than the prescribed 10 days time, you would probably require to give them additional inhalational corticosteroids. More often than not, it should be a budesonide. It should start it in a low dose. Important point to remember is minimum 3 months is what we emphasize. And that should be discussed with the parents at the initiation of treatment so that we take them into confidence. There is, again, you mentioned about the alternative role of the leukotriene receptor antagonist. But even if there is a questionable role of montelukast in some forms of infrequent or intermittent or seasonal asthmas, one thing is for sure that it cannot be used as a monotherapy. They are always used as an add-on, and they are always used for sparing the dose of steroids. So the role of montelukast in terms of wheezing episode is not as a monotherapy. It is just as an initial supplementation you can try if you are doing an intermittent high dose at the onset. But again, they have to be given for a short period of time.
So basically what people used to say earlier,
Sir,
that montelukast
only
can
2
be given
minutes
at the beginning. Yeah,
please.
we will just need 2 or 3 minutes more. A montelukast can be given at the beginning of viral episode. That is no more true. Montelukast, if at all it is to be used, it is to be used as a controller treatment. So it has to be used as a long-term therapy. And it is a very, very, very poor alternative to inhaled corticosteroids with lot of side effects, which nowadays we are going to think. Now, step 3 treatment. This is just giving a low dose steroid is not sufficient. So, Dr. Anjali, what are the other what are the options available in step 3 category? Which patients will qualify, and are there any other alternative treatment?
So as already discussed, that 3 months trial is must of short beta-2 agonist, short-term acting beta-2 agonist. So the children who don't respond, who have no control after this 3-month trial of short-acting beta-2 agonist, then we have to think of adding something for a long term. And here comes the role of either doubling the dose. We can try for doubling the dose of your inhaled salbutamol and
Inhaled steroids. Inhaled steroids.
inhaled steroids. Then next, if even that is not getting controlled, then as he says that we can think of adding a LTRA, that is a montelukast. But that also will come only after giving a trial of doubling the dose of inhaled corticosteroids. That is one of the things which has come up in step 3 of adding leukotriene receptor antagonist. And but first is that you need to double the dose of inhaled corticosteroids.
So basically in step 3, what we do, instead of low dose, we give medium dose. So medium dose is called as doubling the dose of inhaled corticosteroid. In under 5 children, there is nothing called as high dose. What we have is either low dose or minimum dose.
Just to add briefly, now people are using long-acting beta-2 agonist in the form
So
of
that is what I was going to ask. Is there any role of inhaled corticosteroid plus LABA, that is 4
No,
or
I think it
in
has
this
been,
age group?
It has been accepted. Yeah, it has been accepted above the age of 5 years. Till now, there is no official approval to be used below the age of 5 years, but clinicians have been using off-label, and the combination of budesonide and formoterol seems to be the best option. Now, I think we are shortly in the process of revision. There is something which is now called as a smart therapy. So what we were earlier propagating as separate short-acting beta-2 agonist as a rescue therapy, in older children, we are recommending that to be used as a rescue as well. So a child who is probably on a regular combination of SMART means single maintenance and reliever therapy. So SMART is the short form of SMART. And that is now the option. But for the sake of discussion, we restrict saying that as of now, long-acting beta-2 agonist is not recommended below the age of 5 years.
There is not enough data on use of LABA in this age. However, this guideline of 2022 of GINA mentions that if your child is not under proper control on doubling the dose of steroid, instead of adding a oral steroid, we may give a trial of ICS and LABA, but with a clear idea that there is not sufficient evidence for use of LABA at this age. Now, step 4 treatment at those children who have not responded. Dr. Sandeep, what are we going to do in this?
Step 4 is slightly a gray area concern. If you are not working with 3 steps, then you have to review and reassess again. Review means you have to review the diagnosis of asthma, you have to reassess it, and as far as possible, try to get an expert advice regarding how to manage this child. So now something has to be done. So we ideally double the dose of inhaled corticosteroids and further add something more. So long-acting leukotriene receptor agonists are added with inhaled corticosteroids. You can add even a LABA for a child who's more than 4 years of age, or you can give an intermittent therapy with oral steroids for a few weeks, or you can even add high-dose inhaled corticosteroids at the onset of every respiratory tract illness. But all these options should be re-evaluated each time and should be given as short as possible.
Yes, exactly. And basically, this is a step in which we should always take an expert opinion, and we should continue with whatever control treatment we are giving. We should take an expert opinion, and these are the options which are possible along with the expert advice. If a word of caution for low dose oral steroid, if we have added as a step 4 treatment low dose oral steroid, continue it for as short time as possible. Now, Dr. Manish, how will you select a device in this age? Basically, I think
selection of device is age dependent, sir, because the smaller children may not be able to inhale the drug. So if the child is very small, then we would like to go for MDI with spacer and mask. And in older children, we can go only with MDI and spacer. And if you have an older child than 8 years of age, probably he may be comfortable only with MDI.
so. Basically, in this age, the most common device is MDI spacer. If child is less than 3 or 4 years, maybe with a mask. If more than 3 or 4 years, without mask. So this completes our presentation. The take-home messages are: in spite of many advances in diagnosis and treatment of asthma, the diagnosis of under 5 asthma is a dilemma because of its heterogeneous nature. We have to review the response to treatment at each step, and we have stepped down to the lowest possible dose if clear response is there for last 3 months. In young children, if symptoms disappear within 2 to 3 months of low dose inhaled corticosteroid, it is advisable to stop the treatment and see that if the child has not improved coincidentally. And if symptoms recur on stopping ICS, the diagnosis of steroid responsive asthma can be made and a long-term treatment initiated. We can do this 2-3 times before coming to a conclusive evidence. If treatment is stepped down or stopped, we have to schedule a follow-up visit after few weeks. If no benefits are observed to our treatment, it's a time to review our diagnosis, check inhaler technique, and compliance to the treatment. This is a synonym called as RECIPT. Reevaluate the diagnosis, check inhaler technique, and compliance to the treatment. Use of ICS in asthma does not stop progression of the disease, even though it will improve symptoms and quality of life. So remember, we have to use it at as low dose as possible to relieve the symptoms. Any patient showing atypical signs or poor response to controller, try to rule out asthma mimics at each step. High index of suspicion would help in early diagnosis and avoid unnecessary medication. Before stepping up treatment or making alternative diagnosis, always check inhaler technique and compliance to treatment, as well as persistent of triggers. We didn't talk too much on triggers, but since last 2 days, we had been seeing so many discussions on avoidance of triggers. Thank you so much.
Thank you, sir. Thank you, Dr. Vinod Gandhi, sir, and all the panelists for such a beautiful discussion on under 5 asthma and asthma mimics.
See, you're in a take-home message you mentioned it's a diagnostic dilemma sometimes. Okay, I don't think it's a dilemma for a clinician, it's a dilemma for the parents. Okay, and you have said it that there are no diagnostic tests, and including PFT, which cannot be done under less than 5 years. Because announcing the diagnosis of asthma to the parents is like announcing a death sentence many times. Okay, akin to a death sentence. So my question is, that's finally, is because parents want proof and all other diseases have proofs. Okay, here you don't have the proof in black and white. So there are PFT cannot be done. So what about oscillometry? What would the panel say about it?
So impulse oscillometry is a test which can be done at this age, but it is something which is available in very few centers.
The question is not availability. The question is, what would you recommend or would you not recommend? That's the question.
Even if you diagnose on oscillometry that lung function is affected, basically the treatment is to see the therapeutic response.
No,
So
it is not for the, it is for the parents. For the parents, they want proof in black and white. That's what the problem is. That's why I'm asking.
that is the reason we are saying therapeutic trial as an investigation. What Dr. Joshi has to say.
See, what Dr. Arif is trying to say is that if some parents are insistent on a diagnostic test, see, I think it is your skill to convince the parents to go for a therapeutic trial, because that becomes an easier option than to have tests like inhaled nitric oxide or body plethysmography. These are sophisticated tests. Probably we would reserve them for children who are diagnosed under 5 visas who are not responding. So those are the difficult under 5 asthmas, established ones which are not responding. There we would use these tests for assessing the child's severity. But otherwise, it is, I think, it goes without saying that we have been treating asthma in our OPDs for the last 20 years. And I think our parents comply to our suggestions and proper counseling. I think you are also in the practice and you are doing the same thing. So I think we have what always we emphasize in asthma training module is don't just give a prescription, give time. So what you need is to give more time to the patients for parents for counseling, and with your proper understanding, proper explaining, resolving their queries, asthma treatment is not that difficult as what we believe.
So
and
what
it is not a death sentence, sir, please. Yes. It is quite easily treatable.
Sir,
can
in
comment?
ATM, we had always been saying that asthma is clinical. But now we are, the GINA is saying that try to document airflow obstruction. And even in a child of 3 or 4 years, spirometry can be tried. It's not that it is not difficult. Actually, maybe a spirometry.
No, in fact, now the recent GINA guidelines have suggested for an older child, you have to have a spirometry done upfront before, because that is the age group where you can actually give a diagnosis.
Sir,
Yes,
can I
doctor.
comment?
Yeah.
I am Dr. Dhiren Gupta.
Yes,
Kangaram, what I will say, for past almost 12, 13 years, I was doing pulmonology, and the impulse spirometry has definitely added onto your armamentarium, definitely.
Yes.
And in our busy clinic, what is the problem with us is that in busy clinic, we don't have time. So time is the major thing to convince. But even if you have got a time, and if you have got like impulse oscillometry, or what Gina says is that your spirometry is very difficult to, even a 7-year-old, it takes lot of time.
Yes, sir.
So what we clinician require in a given clinic setup, within 3 to 5 minutes, we should be able to perform. Only then it is going to be practical. We talk about all these things on the stage, but when we talk when we are in clinic, there are 10 patients waiting. We always start here, chalne de, baad mein karwa lena. You know, this thing has happened over the years. But what I will say, nowadays we have got portable impulse oscillometer.
They are very easy to perform. It takes 3 minutes and it gives you a lot of insight, not just able to, you are there to convince the parents, but you want to convince yourself what is happening inside. So probably this is the time has come where, like in ventilators, we now know the graphics. So same in the pulmonology practice or allergy practice, we want to know what is happening inside the patient. And in fact, you showed us predictive index.
Yes.
It says that it should be applicable in less than 4-year-old child, that
Yes,
predictive
yes.
index. And look at, they have said that major sensitization against aeroallergen means less than 4 years. Which test you are going to prove it that this is sensitized against aeroallergen? Milk is the second part. It's a minor criteria. So I mean to say, GINA is also changing itself. So probably time has come to change our practice and to go inside the patient, enter inside the patient and start working. That has helped me.
What is the cost of this simple oscillometer?
Sir, a portable one.
That was my question.
Sir, I'm using one. One Dr. Neeraj Gupta has given us. Yeah. Next session hai is pe.
Okay.
Thank you.
Sure.
Thank you, all of you.
Thank you so
Thank
much.
You. Thank you, thank you, panelists, for a wonderful discussion.
I will
and thank you,
request Dr. Gandhi sir and all the panelists to wait on a dais for a photograph. I will also request Arif Ahmed sir to join the dais for a photograph. So Dr. Khatwar sir and Dr. Dhote sir to join for a photograph.
Now we are in the afternoon session of second day of PED ALLERCON. I feel privileged to welcome Dr. Girish Subramaniam sir, our dear and respected Subramaniam sir. This for the talk on the approach to primary immunodeficiency disorders. I will like to invite Chairperson Dr. Sujit Bagde sir and Rakesh Gupta sir on the dais.
Good afternoon. And we all are waiting for you, sir, to start. And we were missing you. So we are happy to see you on the dais. Kindly continue.
Thank you, Suchit. Thank you, Rakesh. Good afternoon, friends. We go from the common to the esoteric. From asthma, we go to primary immunodeficiencies. The purists in this audience might disagree with me and will probably feel that I am wrong by using the term primary immunodeficiency, because now the proper term is inborn errors of immunity. The right term to use for primary immunodeficiency is inborn errors of immunity. There is a change in nomenclature. But does it really matter whether we use the term PED or inborn errors of immunity? Let us take an example. This was a 14-year-old child who was a case of chronic ITP, had not responded to all the first line and the second line treatments, used to have severe bleeding episodes, and it was then planned to give him rituximab therapy. Rituximab is one step before you advocate splenectomy. Rituximab is an anti-CD20 monoclonal antibody, and the protocol when you want to use rituximab is before you give rituximab, you have to check immunoglobulin levels. Because rituximab, if you give rituximab, it will suppress the B cell immunity. And if coincidentally the patient has hypogammaglobulinemia, it will worsen the condition. So the protocol is before you give rituximab, you have to do immunoglobulin levels. And in this patient, we did immunoglobulin levels. And what we found was IgA was low. Sorry, IgG was significantly low. IgA was normal. IgM was significantly low. Once we had this report, then we did lymphocyte subset analysis, which shows that the B lymphocytes, which is demonstrated by CD19 cells, B lymphocytes were normal. So normal B lymphocyte count, low IgG levels, and additionally low IgM level confirms a diagnosis of common variable immunodeficiency. This is a primary immunodeficiency. This patient did not have any history of recurrent infections. Patient presented only with chronic ITP. So the point that I want to drive home is the proper term to use is inborn error of immunity, because if you only concentrate on immunodeficiency, you'll miss out on the fact that these children, apart from recurrent infections, have two important manifestations. One, autoimmune diseases, especially autoimmune cytopenias, and two, early onset malignancy. And this triad of recurrent infection, early onset malignancy, and autoimmune cytopenias and other autoimmune diseases together characterizes the spectrum of conditions known as primary immunodeficiency. Hence, the proper term to use is inborn errors of immunity. But many of you in this audience might wonder, is it really important to discuss PID when it is so rare? To put things in perspective, the prevalence of PID as shown in this graph is much more than the prevalence of type 1 diabetes mellitus, much more than the prevalence of juvenile idiopathic arthritis. Individually, all the PIDs are very uncommon. But as a group together, they are significantly common for us to keep abreast with all the developments in this field. So when do you primarily suspect a child who is having immunodeficiency? A child who presents to you with recurrent infections. And once you have a child with recurrent infections, a systematic evaluation will slot the child into one of four categories. One, he could be a normal child who has recurrent infections. Number two, a child with atopic disease. Number three, a child with underlying chronic disease. And number four, a child with primary immunodeficiency. All of us are aware that most normal children have repeated number of infections in early childhood. And it will be extremely difficult to know whether he's a normal child or whether it's a child who has got primary immunodeficiency. The important point is these infections are short lasting. In between episodes of infection, the child is perfectly normal and growth parameters are perfectly normal. The second group of diseases is atopic diseases. In atopic diseases, especially allergic rhinitis, these children are prone to recurrent episodes of otitis media, recurrent episodes of sinusitis. In addition, they have what is known as pseudobacterial infection, because most of them who have VZ bronchitis are labeled as pneumonias. And it's a common mistake to evaluate a child with atopic disease for primary immunodeficiency. The third group of conditions is a child who has an underlying disease like congenital heart disease, or a child with reflux, or a child who has cystic fibrosis. These children, because of their primary disease, have a number of infections which might make you think that he has PID. But in reality, if you look at the overall picture, the real diagnosis is self-evident. Having ruled out these three, then you start thinking whether this patient has a PID disorder. To fit into PID, you have to have this mnemonic in mind. Children with PID should have one of this SPRU. What does SPRU stand for? The infections in PIDs are severe and refractory. Unlike a normal child who has bacterial meningitis, a child who has primary immunodeficiency, if he has bacterial meningitis, the bacterial meningitis is not easy to bring under control. Number two, they have thrush which lasts for more than 1 year. Beyond the age of 1 year, they can have persistent diarrhea. The persistent bacterial infection, persistent thrush, persistent diarrhea. These children are prone to recurrent infections. And there is a definition for what you call as recurrent. If you have more than 8 middle ear infections per year, more than 1 serious sinus infection per year, more than 1 pneumonia per year, then you call it as a recurrent infection. Start thinking of PID. PIDs also have unusual infections at unusual places. If you have a child who has PCP pneumonia, start thinking of PID. If you have a child who has a liver abscess, every child with a liver abscess needs to undergo evaluation for primary immunodeficiency. These children, as I've already told you, are prone to develop early onset autoimmune disease, As a matter of fact, if you have a child with Ivan syndrome, unless proved otherwise, he has got primary immunodeficiency. Apart from this prove, do not forget the F word. F stands for failure to thrive and a positive family history. So if one of these clues is positive, start thinking in terms of PID group of disorders. Before we go into evaluation of PIDs, let us briefly see how does the immune system work. There are two broad categories of immune system which help us fight infections. First is the innate and second is adaptive. What is the innate immune response? When the microbe enters our body, the body's first response is to get rid of this microbe by phagocytosis, not by antibody production. The first response is by phagocytosis. Somehow this organism has to be eliminated. In simple terms, this process of phagocytosis is innate immunity. Phagocytic cells are neutrophils and macrophages. So the most important cells for innate immunity are neutrophils and macrophages. NK cells which phagocytose viruses and complement which also help in opsonization, which helps in phagocytosis, also constitute innate immunity. So innate immunity is something which all of us are born with. It is immediate, it is non-specific. While adaptive immunity depends on the production of antibodies and depends on T cells. So it is T cell and B cell immunity is adaptive immunity. Now, adaptive immunity is very specific because the antibodies are against the specific antigen. It has immunological memory. So the next time you have that infection, the immunological response is exaggerated. And it is far more effective than innate immunity. The problem is if you were to rely only on adaptive immunity to get rid of the organism, you would all be dead by the time adaptive immunity kicks in. So the initial response has to be innate immunity so that you get some time for the adaptive immunity to take over, antibody production to begin. It takes about two weeks for antibody response to develop. So if you were to wait for 2 weeks, the infection would have killed you by that time. Therein lies the importance of innate immunity. And if you look at this slide, in adaptive immunity, you have B cell disorders, that is A gamma globulinemia and hypogammaglobulinemia. And T cell disorders are always combined immunodeficiency. So some of you might wonder why no specific T cell immunodeficiency. Because T cells are necessary for B cell development. T helper cells help in B cell development. So there is no such thing as isolated T cell immunodeficiency. It is B cell immunodeficiency and combined T and B cell immunodeficiency. So having now suspected that this child has immunodeficiency, you have to first make sure that you have ruled out the causes of secondary immunodeficiency. And in this list of causes, all are self-evident. You would not miss any of them, except HIV. So before you try and investigate a patient for primary immunodeficiency, make sure that he is HIV negative and then proceed with the investigation for all causes of primary immunodeficiency. If you look at standard literature, the classification of primary immunodeficiency is very confusing, and every year the classification keeps changing. There are 7 or 8 categories. But from a generalist point of view, if you remember, there are 2 systems, innate immune system and adaptive immune system. You know that you are dealing with 2 groups of disorders. Disorders of innate immunity or disorders of adaptive immunity. Disorders of innate immunity are phagocytic disorders and complement disorders. Adaptive immunity disorders are either B cell disorders, so hypogammaglobulinemia or A gammaglobulinemia, or combined immunodeficiencies. Let us take a few examples to understand each category. This baby was 10 days old when he came to me with omphalitis. When I did his counts, his total count was 80,000 with a polymorph of 80%. And the CRP was sky high. So we correctly suspected this patient has sepsis. We put the patient on treatment, and over the next 4 or 5 days, the patient significantly improved. On day 7, we repeated his counts, and the count still showed a TLC of 40-50,000 with about 70 to 80% polys. This made us start thinking as to whether we were dealing with something else. When we took a detailed family history, the elder sib had died at the age of 1 year with an undiagnosed problem. He was being treated for sepsis. At the time of his death, this child had a total count of 1 lakh with 90% polys. Before further evaluation could be done, this child had died. Then the penny dropped. We knew that we were dealing with a disorder known as leukocyte adhesion defect. Leukocyte adhesion defect is a classic prototype of a disorder of innate immunity. When the microbe enters the body, enters the tissue, what happens? There is a chemotaxis by which all the neutrophils get attracted to the site of infection. They get attracted, they adhere to the endothelial cells, and then get into the tissue. In children with leukocyte adhesion deficiency, there is a defect in the production of adhesion molecules. And hence the neutrophils, though they migrate to the site of infection, cannot penetrate the site of infection because they are unable to penetrate the endothelial cells, because they are unable to adhere to the endothelial cells. So hence, they will have persistently raised TLC. Even in between episodes of infection, these children will have persistently raised TLC because at some time or the other, we are all having minor subclinical infections with non-pathogenic bacteria. So this is a classical hallmark. And then the various hallmarks of this group of disorders is that these children often have delayed separation of cord. Any child who has delayed separation of cord beyond 2 or 3 weeks suspect a disorder of leukocyte adhesion defect. Secondly, these children have very poor wound healing because for wound healing, you need neutrophils. Thirdly, they have classically absence of pus formation. Severe infections, skin and subcutaneous infection, severe, but when you drain, no pus at all. Because what is pus? Pus is nothing but polymers. So absence of pus formation is the hallmark of leukocyte adhesion defect. So the neutrophils are able to migrate into tissues. There is no LAD. Having migrated, these neutrophils then engulf the microbe and kill the microbe. If this process is defective, you have the next group of disorders, which is classically seen by this case. This 10-year-old boy presented to me with the third episode of pneumonia in the last 2 years. First episode of pneumonia was a severe persistent pneumonia. The treating clinician had investigated him thoroughly. Then, because he was not responding to the usual antibiotics, he suspected probably tuberculosis. The sputum for CB-NAT was negative. Subsequently, he underwent a bronchoscopy, bronchoalveolar lavage for AFB was also negative. Still, because there was no other diagnosis, the patient was put on AKT. The child improved. 5 months after this entire AKT course was over, again presented with pneumonia, again had a severe refractory pneumonia, again the same story, sputum CB-NAT negative, BAL CB-NAT negative. This time the clinician thought probably he's dealing with multi-drug resistant AKT and started the treatment for multi-drug resistant AKT. The child again improved. Third time he again had pneumonia, he came to me. There were two puzzling questions in my mind. Number one, he has responded to AKT, but why was it that both the first and the second episode, AFB could not be demonstrated even on BAL? And the second puzzling question is, okay, if you are not dealing with tuberculosis, how is it that the patient had responded to AKT both times? And that set me start thinking whether this patient had responded to the anti-staphylococcal effect of rifampicin and whether we were dealing with recurrent staphylococcal infections. So I decided that I'll investigate him for primary immunodeficiency. And when we investigate a child for primary immunodeficiency, the first test that we do is immunoglobulin levels. His IgG, IgA, IgM, IgE, all were normal. The next step is lymphocyte subset analysis. In lymphocyte subset analysis, CD3 cells tells you the status of T lymphocytes, CD19 tells you the status of B lymphocytes, CD56 tells you the status of NK cells. This child had normal level of all these three cells. So we were left with the next test, which we did, and that is the NBT-DHR, nitroblue tetrazolium and dihydrorhodamine test, absolutely diagnostic test for the disease known as chronic granulomatous disease. Chronic granulomatous disease is a disease in which the neutrophils are able to ingest microbes, but are unable to kill them. Microbe killing by neutrophils depends on reactive oxygen species being generated by these neutrophils. This reactive oxygen species generation is dependent on NADPH enzyme. These children lacked NADPH and hence they have recurrent infections with these organisms. So a diagnosis of chronic granulomatous disease was established. They present with recurrent bacterial fungal infection of the skin, lung, and lymph nodes. And because these infections cannot be easily eradicated, there is a granuloma formation. Oftentimes, these children are labeled as either lymph node tuberculosis or, as was seen in this case, pulmonary TB, or many times in older children and adults, even in adults, they are diagnosed as Crohn's disease because of the presence of granuloma in the intestine. And a simple test is a DHR-NBT, which will help you diagnose this condition. The next case was a 7-month-old child who presented to me with severe failure to thrive. Birth weight was 2.6 kg. At the age of 7 months was just 3 kgs. Apart from severe failure to thrive, we had persistent thrush, persistently draining BCG abscesses, and small nodules over entire body. It's a telltale diagnosis of severe combined immunodeficiency. This was our clinical diagnosis. We did a simple test, complete blood count. And what does the TLC show? The TLC shows an absolute lymphocyte count of 800 per cubic millimeter. Any child under the age of 5 years, the absolute lymphocyte count is less than 3,000. In the right setting, suspect severe T-cell immunodeficiency, that is a combined immunodeficiency. He had multiple skin nodules all over the body. From one of the nodules, we did a FNAC, and it was AFB positive. So this was disseminated BCG. So this patient, clinical diagnosis was severe combined immunodeficiency. We confirmed it by doing first an immunoglobulin level, and all 4 immunoglobulins, IgG, IgA, IgM, IgE, all 4 were much below normal. Then we did a CD3 count, which is a marker for T lymphocytes. This was very low. CD8, CD4 and CD8 were also low. CD19, which is a marker for B lymphocytes, was also remarkably low. So this patient had a defect of adaptive immune response, severe combined immunodeficiency. When should we suspect SCID? Present very early in life with severe failure to thrive, persistent thrush, persistently draining BCG, disseminated BCG, PCP pneumonia, and history of consanguinity or a positive family history. This was an older child, 7-year-old, who came with recurrent chest infections, recurrent ear infections, and recurrent sinusitis. In view of these 3, the treating clinician has suspected either cystic fibrosis or immotile cilia syndrome. That was a correct suspicion. All the same, we thought that we should first evaluate him for primary immunodeficiency. And when we investigated, all his immunoglobulins were markedly low. And when we did his CD3 count, the CD3 count was normal. CD19, which was for B lymphocytes, was 0%. So we were dealing with A gamma globulinemia, which was a male child. So X-linked A gamma globulinemia, also known as Bruton's A gamma globulinemia. The last case is the case that I've already showed at the beginning. This child presented with chronic ITP, was subjected to immunoglobulin analysis before giving rituximab, which showed low IgG, and we made a diagnosis of common variable immunodeficiency because the B cell count was normal. This patient presented as autoimmune cytopenia. So when you should suspect common variable immunodeficiency, unlike Bruton's A gamma globulinemia, this occurs in older children. It can be familial, but usually it is sporadic and often presents with autoimmune cytopenias. And they have low IgG levels, and either IgM or IgA also has to be low, and they have usually normal B cell numbers. So to summarize, how do you suspect and proceed with the case of suspected PID? First, make sure that he falls in the category of PID, that he is not a normal child, he does not have atopic disease, he does not have any chronic underlying diseases, and he has a sprue category of infections. Having seen that probably he fits in with PID, use the first important screening test. Tier 1 is CBC, which will show you ANC, and if the ANC is low, suspect congenital neutropenia, Costman syndrome. If the absolute lymphocyte count is low, suspect probably T-cell immunodeficiency or combined immunodeficiency. The Tier 2 tests are NBT-DHR, which will help you diagnose a case of chronic granulomatous disease. Immunoglobulin levels, which if it is low, will help you suspect either B-cell immunodeficiency or combined immunodeficiency. Lymphocyte subset analysis, which will show you B-cell numbers and T-cell numbers. And finally, if you are left with an undiagnosed condition, you can go ahead with the genetic test, that is the whole exome sequencing. I said that this is the final test, but for many specialists now, it has become the first test, even before they proceed with other Tier 2 investigations, because it often clinches the diagnosis in the right clinical setting. Thank you very much for a patient's hearing.
Thank you, Girish sir, for presenting the difficult topic in the most simplified way.
Thank you, sir.
We know all Dr. Girish sir as a senior pediatrician in the city and practicing as a rheumatologist since last few years, more than 5 years. And we seek as a dependent academician when we come as a difficult cases as a rescue. We look towards to you. Thank you, sir.
Thank you, Suchit. I'm touched.
Thank you, sir. Thank you.
If any questions, otherwise we are having one more topic.
So,
thank you.
Thank you.
So for the next topic, I would like to invite Dr. Anand Pendrikar, sir, who is willing to speak on aerobiology of outdoor allergen in North and Central India. Welcome, sir.
Hey, Wali.
Dr. Pendarkar sir is the former president of the Indian Academy of Allergy and is the founder vice president of the academy. He is a fellow of the Indian Academy of Allergy and Indian College of Allergy and Asthma and Epidemiology. He is basically an ENT surgeon, but all his professional time is devoted to asthma and allergy. Welcome, sir.
So now on So we will wait for 5 minutes. So we will have a cake cutting ceremony for Dr. Kiretkar sir now. 5 minutes. I will request Dr. Kiretkar sir to be on stage. नहीं नहीं कब है मेरा इसके बाद ही
वही करना है नीचे से तो टिकट बस दो ओडियन ना
I will request all the senior pediatricians to join on stage. Today is sir's 50th birthday. So, tomorrow. Sir.
Please come, sir. Sir's 50th birthday.
अपने लोग
Happy birthday
conference का एक समझे nutrient for conference.
So I will request everyone that we will proceed for our next session. So kindly all of you settle down. So we are going to start our next session.
Thank you. Thank you, delegates. Hello. Thank you, delegates, for joining the ceremony of wishing a very happy birthday to our Maharashtra President of ALLERCON. 50. Okay. On his 50th birthday, which is tomorrow, but as in the running we are having the conference, we have celebrated and joined the 50th birthday of our President, Dr. Raja Kiritkar, and we wish him every success in his life and bright tenure as a President of ALLERCON Maharashtra State Chapter. Thank you. And we will start the next session. Kindly, sir.
Thank you, sir. ये नहीं कर रहा है काम. This is a privilege and additional honor given to me. My friend and colleague, Dr. A.B. Singh from Delhi, he had to do aerobiology of North India and Middle India, Madhya Pradesh. Since he did not come, I'm given this good opportunity, but I will cover aerobiology with the perspective and in the perspective of a clinician and allergy specialist. Aerobiology is the science of the study of the biological content in the ambient air, whether indoor or outdoor. I'm not going into the details of how a sampler is placed, how you collect the pollen data in the air, in the ambient air, but I'm going to cover and give you some information that I think I know on various airborne allergens, both indoor and outdoor, अभी नहीं कर रहा, वहां से होता है पूरा। It's correct. Oh, thank you so much. Good man. यहाँ से. Okay. Okay, His grace be on us. For anybody to develop allergy, one must have the susceptibility, and then one must be exposed to allergen-rich environment. These two are essential for anybody to develop allergy. The susceptibility we have been talking about. Coming to the allergens, we can classify them into basic causes and triggers. We will only be dealing with one component of the major component of the allergens, that are airborne allergens. We'll not talk about injectants and ingestants. So to learn the source of airborne allergens, what are indoor allergens, what are outdoor allergens, and to understand airborne allergens as the allergens in causing atopic diseases, that is the learning objective of this. Coming to, if we classify them, airborne allergens into outdoor and indoor allergens. Indoor allergens are one of the common ones, most common ones. Many of us have pets. For a long time, it was considered that the pet's hair or the dander itself is the allergen. A very interesting study conducted way back in 1962 in Boston revealed that the hair or the dander is only a convenient carrier. It is the dried salivary droplet. These animals lick themselves as a process of cleaning. The saliva is that one that contains protein, and that is the allergen. The dander or the hair only is a convenient carrier to cause an indoor allergen. Cats, which lick themselves by the hour, are a much notorious source of allergy than the dogs are. Then we have fungi. We have fungi both indoor and outdoor. If you have some seepage in the walls, there you will see some black coloration. That is nothing but fungi, molds. And they can become separate and airborne, and they're so microscopic, and they can easily gain access into the respiratory system and cause allergy. Similarly, if you keep some a loaf of bread or cooked rice on your dining table and forget it, and you will see beautiful colony of fungi. So this is one of the common fungi, a micro picture of that. Look at that. This is Alternaria, alternata, which is a common fungi that can cause allergy, and immunotherapy profile for this particular allergen is very good. Then we were talking about house dust. House dust is one of the commonest allergens to be complained of by patients, and when the patient is a child, by the parents, that house dust causes allergy. House dust is a complex substance. If you store the house dust corresponding to the period of storage, the capacity or the strength or the power or the allergenicity of the house dust increases, thereby showing that there is a living, viable material in this house dust. And we know that now that this is a tiny little insect called as a house dust mite. There are so many mites, and among them, there are just a few of them which are clinically relevant, especially for allergy of the airways and even in atopic dermatitis. There are 4 of these species. Lumea tropicalis, which is the most dominant one in India and some other tropical and subtropical countries. Then we have Dermatophagoides carolinus, farinae, and the last one is uroglyphosate. There is a tremendous amount of cross-reactivity between the last three of them. Glumia does not have cross-reactivity between the others, and it has its own independent allergen capacity. This is how it looks when you observe under an electron microscope. These are the dust mites. Then we have insects like ants, mosquitoes, flies, and cockroach. Cockroach, it's not necessary that you should be bitten by a cockroach. Either it's fecal pellets or urinary droplets or dead or alive parts can become airborne allergens. Then we, having understood this much about the indoor or intramural allergens, we come to outdoor or extramural allergens. That means these are the biological material present in the ambient air outside. There also we have fungi, but more than fungi, we have what is called as pollen. Pollen is the male gamete of any plant. Only the airborne pollen that cause allergy are those which are dispersed through air. That means they are called as Anaphylaxis pollen. The size of the pollen is very small and they are non-sticky, and one gush of wind, many of them can be dispersed and they become airborne. And because of the eddies in the wind current, they can travel long distances. This, I will show very quickly some of the examples. This is the cyanodon or Bermuda grass. Then this is another grass common here and also near Pune and Bombay. This is Imperata, another grass. Penicetum is Bajra. That's also a grass. Then we have ZMS, that is corn. ZMS. Also look at the so much of density of the plant when it is in bloom, and they can become airborne. And this is jowar, sorghum. These are all the grasses. Now we have some weeds. I will show you Parthenium or the Congress grass, and then look at the racemes. Amaranthus spinosus, the one that I showed yesterday, that is also another weed. Then we have Artemisia. It also belongs to the same family as Parthenium is, but a different species. Then we have Ageratum. We have, look at the raceme, a close-up of the raceme, how, and the Cockelberg, Xanthium also belongs to the same family. Look at the raceme. Then Canopodium group, there are both album and murale. These are also common weeds and cause of airborne allergy and respiratory allergy, both asthma and rhinitis. As allergy specialists, we must have some information. We must know these things. Then we have brassica. This is saswe, mustard. Brassica campestris. Look at the raceme, close up of the raceme. Then sunflower. Look at the close up of the raceme. Then we have typha, which grows near water bodies, swampy areas. Look at the raceme, close up. Argemone is another weed. And Sveda fruticosa. Sveda fruticosa is also merua. This is another one which is related to the neem. Cannabis, the one that is a source of ganja and hashish. Look at the raceme, close up of it. Then Carica papaya, which is by and large an insect pollinated tree, but its pollen can cause respiratory allergy. Look at the raceme. And Ricinus communis, which is castor plant, grows like a menace in any swampy areas, and the pollen grains can cause allergy. Look at the raceme. Then we have coconut tree, and its raceme can, but not a common one. Casuarina, which you find as a wind cheater nearer to the seashore, is one of the common causes of allergy in these areas. This is prosopis. This is universally present unless you go to very high altitude areas. It's not present there. If there is very cold, it doesn't sustain. This is the raceme. This is Cassia samia, which is right now in bloom. with large yellow, bright yellow flowers. Look at the raceme, how the plant modifies its anther, which stores the pollen grains. The flower is modified in such a way that the anthers are very easily exposed to the air. One gush of wind, lakhs and lakhs of them are liberated into the air. This is Holoptilia. Fortunately, it flowers only for about 2 months during February and March. And when it is in bloom, it is heavily pollinating. It's one of the common causes of allergy, respiratory allergy. And one of our very senior aerobiologists from Birbal Sahni Institute in Lucknow, Dr. Vishnu Mitre, was very severely allergic to this, so much so that during those 2 months, he would actually leave Lucknow and go to another place. This is the close-up of the raceme. This is Azadiracta, another variety of neem. It is possible to get allergic to that neem tree pollen, but not very common. Melia is another one. Albizia, which is also planted as an avenue tree by the authorities, the pollen can cause allergy. Look at the raceme. Eucalyptus is not such a common allergen, but it does. Salvadora is meswak. You see, what you see is in front of Qutub Minar, the tree. Salvadora persica. You can also see this in near Purana Killa, Delhi. And there is another one near in Ahmedabad, near Patang Thabar. I will complete very quickly. Raceme Ailanthus excelsia, a large, beautiful tree, but the tree pollen can cause allergy. And it has also has a very high cross-reactivity with Prosopis. So if you find a patient having positive response to Prosopis juliflora allergen and Ailanthus also, you may as well choose, depending on the patient's place and the topography, you may choose one of them, maybe Prosopis juliflora in many times. I don't want to leave you with an impression that all trees cause problems. No, we need good health-friendly trees. Here is a good example, Taubibia argentia, which blossoms only during about February time, February, March. Actually, it heralds the arrival of spring in Bangalore, which has, this tree has beautiful, large, pedunculated yellow flowers and very, very highly ornamental. And during the other time, it's full of green foliage. It's suitable for any place. This is also jacaranda. It flowers during summertime. Very, very ornamental and health-friendly, good for biodiversity. Please promote these trees in your city of Nagpur. This is rightly called as the pride of India, Lagerstromia. This flowers during summertime, very beautiful, bright pink flowers. That's it. Thank you very much for being a wonderful audience. I think I've completed well in time.
Thank you very much, sir, for taking us to journey to the very picturesque and photographs really in a nature, close to the nature. Thank you for your wonderful talk. And I thanks the organizer for giving us opportunity to chair this session.
Thank you, sir. Thank you very much. Please come forward for group photo.
Yes.
Subramaniam sir.
Sir,
please come photo. Mementos will be available on the reception. Please collect. Thank you, sir. For our next topic, I like to invite Dr. Chairperson, Dr. Vijay Dote sir and Dr. Sagar Wag sir. Our next topic is newer modalities to monitor lung function in pediatrics. For that, I would like to invite Dr. Neeraj Gupta, sir, from New Delhi.
The next topic for today, modality to monitor lung function test in pediatrics. And I welcome Dr. Neeraj Gupta, sir, to deliver the talk. Dr. Neeraj Gupta, he is a Director, Diploma in Pediatric Allergy and Asthma, Fellow Pediatric Intensive Care, Great Ormond Street Hospital, UK, Diploma in Allergy and Asthma, CMC Vellore, Guest Speaker, National Lewis Health, Colorado, USA, contributed over 90 research papers and authorized the book Allergy in Nutshell, a handbook. I welcome sir and ask to deliver the talk.
Thank you very much. And in fact, I am very happy and thank you to the previous session on asthma discussion as the previous group. And I think Dr. Dhiren has also incited a good discussion about a newer pulmonary function test, which is called as oscillometry. So as you demanded about oscillometry, Dr. Arif is also here. So sir, please come forward. So as you demanded about oscillometry, we'll discuss a little bit about oscillometry. So as we understand that oscillometry seems to be the future pulmonary function test. It has been discussed, the definition of asthma includes that we have to really demonstrate about the variability in the expiratory airflow obstruction. Okay, so that means that we need to really demonstrate about the airflow limitation and simultaneously variability. For that, we require a pulmonary function test. And Gina also says that in order to make the diagnosis of asthma, you need to really perform a test or a pulmonary function test to demonstrate it, that whether it is available or it is not available. If it is available, then you will say that, okay, this seems to be reversible airflow obstruction or asthma. And if it is not available, then you will probably search for alternative diagnosis. But we all understand that the gold standard, which we have discussed about spirometry, that there are various shortcomings of spirometry. Those who have performed spirometry on yourself, you understand that how difficult it is a procedure, which is a forceful maneuver. And suppose a small child who has come to you of any age and you ask them to perform, blow in a machine, then at that particular time, it becomes really difficult, really a nightmare. And then it is definitely difficult in younger children, elderly people, more than 60 years, 65 years, 70 years, who do not have, you can say like those neuromuscular reserves. Then there are certain patients who are having some physical and cognitive limitations. Nowadays, we are having increasing proportion of children with some autism spectrum disorders. Then at that particular time, it becomes really difficult to give them the command to perform a forceful maneuver for a reasonable duration of time to perform the pulmonary functions. And then there is also a need that even ICUs, we are working on the ventilated patients. And in ventilated patients, we really want to know about the lung functions, which we right now do not know about them. And then there are many procedures in pediatric age group, which we like to do in the sleep, during sleep, like MRI, CT scan, and all those things. So can we perform pulmonary function test during sleep? So hence, there is a need of search of alternative PFT. So here comes the technique, which is called as an oscillation technique. It's not a new technique. It's an older technique. We started somewhere in 1956. The principle of this is based upon ultrasound technology. So what we are doing is that a person or a patient is taking the normal breath, normal tidal breath, and then with the help of loudspeaker, we are just using the sound waves of various frequencies. And these sound waves are going inside the airways, tiding over the tidal breath, coming back, and then these sound waves are captured back, and then they will tell us about the character of the airway. So if you are using one single sound wave, like for an example, 5 Hz frequency or 10 Hz frequency or 20 Hz frequency at one time, so this particular sound wave will become like a sinusoidal sound wave. And this technique is called as forced oscillation technique or FOT. Whereas if in the interest of time, if you just combine different frequency sound waves, then at that particular time, multiple frequency sound waves go simultaneously inside, come back simultaneously. And at that time, the appearance becomes a square wave pattern. And this is called as IOS or impulse oscillometry. So the basic principle is oscillometry, whether it is FOT, whether it is IOS, practically they both are giving the same information to us, right? And there are different frequencies which have been given by different vendors, different machines. But in practical use, we are using a frequency from 5 Hz to 20 Hz. So this I have already explained. Single frequencies called as FOT. So this side is force oscillation, in which one type of frequency is going at one time. Whereas if you club together different frequencies, ride over them each other, then at that time, they will practically look like a square wave pattern, and it is called as impulse oscillometry. The principle remains the same. So we have discussed that this is working on the tidal breath. And then when it is coming back, then various airway parameters are measured in the form of resistance and reactance at different frequencies. And then resonant frequency will come to these terms. Very simple procedure, very simple instrument. You just require a small table. Probably that much size of table is enough for the instrument. This is the setup at our unit, and in which you just see a small computer screen, small machine, and then the child is able to do it comfortably. And this is recommended after 2 years of age. So this is just a pictorial cartoon in which I am trying to explain you the analogy, how it is actually working. So if you just see what exactly happened, that whenever a person is breathing, that is a respiratory flow, the tidal breath is happening, that is by the spontaneous breathing or on the ventilator. Then on the top of that, here the loudspeaker or the machine hub, this is the loudspeaker. So this loudspeaker is there, and it is producing different sound wave frequencies, which are tided over as different sound impulses over the respiratory flow going inside, like this arrow. If you just follow the green arrow, so they are just tiding over the respiratory flow going inside and coming back. When they are coming back, now it is depicted as a blue arrow, and then signal filtering will happen so that it is not get masked by the normal tidal breath. And ultimately the signal filtering, after the signal filtering, these sound waves are captured by the transducer. So this transducer is here. So this transducer is here, loudspeaker is here, and this transducer actually captures the sound waves. And there are two types of transducer. One is the flow transducer and is the pressure transducer. So flow transducer directly measures the flow at respective frequency, and pressure transducer directly measures the pressure at respective frequency. And then by using the simple Ohm's law, that is resistance divided by flow, we come to know about the, the pressure divided by flow, we come to know about the resistance. So resistance as individual frequency is calculated like R5, R10, R20. Then what is the meaning of this? So as we understand now, what is R5? R5 is basically the resistance which is calculated or measured at 5 Hertz frequency. R20 is the resistance which is measured at 20 Hertz frequency. Now we understand with the principles of physics that lower the frequency, like 5 Hertz frequency, it is having more deeper penetration power. So that is why it is able to reach up till the distal most alveoli. Whereas higher the frequency, like a 20 Hertz frequency, it is remaining only in the proximal airway. In other words, what I want to say that R20 will tell you only the characteristic of the larger airway or an airway which is more than 2 millimeters in diameter, whereas R5 will tell you the entire airway, the total airway, right? And if you are actually interested in the peripheral airway or the small airway, you can just do a simple mathematical deduction, R5 minus R20. So this will give you the total airway, this will give you the proximal airway, and this will give you the peripheral or the small airway, which is R5 minus R20. I hope this is clear. So this is one parameter, which is the resistance, which is measured by oscillometry. And then when comes the question about depiction on the graph. So the graphs are like on the y-axis, this is resistance, on the x-axis, there is a frequency. And if you see carefully, frequency is 5 Hertz, 10 Hertz, 15 Hertz, 20 Hertz. Why we are not taking less than 5 Hertz? If you are taking less than 5 Hertz, it goes much more deeper, ultimately reaches to the pleura, ultimately reaches to the chest wall. Then at that time, and which is not the area of interest, because we are interested mainly in the pulmonary function test. So because of the chest wall compliance and all those factors, ultimately that will get affected. So that is why the minimum frequency used is only 5 Hertz. Similarly, the maximum frequency used is 20. If you use more than that, 25, 30, then at that particular time, that frequency will remain inside the mouth or in the oropharynx, and by the wobbling of the cheeks or by the tongue movement, these will get affected. So ultimately, the minimum frequency is 5 and the maximum is 20. Now, if you just see carefully, so the R5 or resistance at 5 Hertz is slightly higher physiologically as compared to R20. And we understood R5 is telling you the total airway. That means large plus small. Whereas R20 is telling you only the large airway. So large airway resistance is this much, and this is telling you large plus small. In adults, a normal healthy adult, the smaller airways or the peripheral airways contribute very less to the resistance. That is why practically there, the R5 and R20 values are very near. Whereas in children, we all are pediatricians, we deal with the children. So smaller the child, the small airway resistance contribution is more. Then at that time, the R5 becomes physiologically more as compared to R20, right? So this is basically the difference. And then thereafter, you can give the bronchodilator, and then you can see the difference that how much it is getting reduced, right? So in the upper one, if you just see that R5 is only responding, but R20 is not responding. So probably it is reflective of only a small airway obstruction. Whereas in this, both are responding, and the magnitude of response or the magnitude of reversibility of R5 is much higher than R20. That means it is a mixed airway disease affecting both the large airways as well as the smaller airways. Then the second parameter which is used in oscillometry is reactance. Now, what is reactance? Reactance is basically depending upon the elastic recoil. What I mean is that whenever the air is going inside during the inspiration, then thereafter, because of the lung elastic recoil, it is coming back. When it is coming back, so depending upon the elasticity of the lung, it will show you the reactance. So reactance is always having a negative value. And this always starts from below the baseline or zero. So if you just see here, so this is the zero line, and reactance will start somewhere bottom, and then it will go above like this. And this point at which it is cut the zero line, this will be showing you the resonant frequency. And this area, the yellow area, is called as the reactance area or Goldman's triangle. Why I'm interested? Because if there is any problem which is related to the peripheral tissues, peripheral lung tissues, whether it is obstructive or restrictive, then elasticity will be affected. When elasticity will be affected, so this parameter will become more negative. So this red line will be shifted towards downstairs. If the red line goes downstairs, so this value will become more negative, and this value will become towards more right side shifted. So resonant frequency will increase. And that will actually tell me that there is a small airway problem which is happening, right? So you can see here, upper one is the normal and lower one is that it has got shifted downstairs and it has got shifted towards right side. That means there is a small airway problem, but this reactance will not tell us about whether it is obstruction or restriction. If there is a reversibility after bronchodilator, then probably it is an obstructive airway disease which got reversible. If there is no reversibility, then there is a probability either a fixed obstruction or a restrictive lung disease. So this is the total diagram which we have spoken. And now coming to the total interpretation. So a combination of resistance at 5 Hertz, 20 Hertz and R5 minus R20, and a combination of reactance and resonant frequency will actually tell you that whether the person is having small airway obstruction, large airway obstruction, combined airway obstruction, or a restrictive lung disease. And this parameter is much more sensitive as compared to spirometry. So these are the graphs. You are well versed with the spirometry graphs. And these are the graphs which I have just shown you about oscillometry. And this is the comparison among the different type of diseases. This is the table which is highlighting important points, spirometry versus oscillometry, in which what we need to understand that spirometry is directly measuring the flow and the lung volumes. Whereas here, we are not measuring the flow and the lung volumes. We are here directly measuring the resistance and the reactance. So this is one major difference between the two. So one thing is telling you about the flow and the volume, whereas here it is we are directly measuring the resistance and the reactance. Then second thing, which is important, is that it is a forced maneuver spirometry, where it is like a simple maneuver, tidal bath. Even we are using this modality at our institute in those children who are suffering from Duchenne muscular dystrophy, spinomuscular atrophy, those children who are using some chemotherapeutic drug like busulfan, which is known to cause pulmonary fibrosis, and we monitor them on chemotherapy. If there is any change, then we probably try to make some changes. And now we are also doing it in the post cardiopulmonary operated patients also, then post abdominal surgeries also, and there are other different uses which we are now exploring also. And the one important thing, especially with the COVID time and the post-COVID era, as it is going with the forced breath spirometry, so the aerosol generation is quite high in the spirometry, and that is why the spirometry used during COVID time was restricted. Whereas oscillometry, because it is working on the tidal bath, so the aerosol generation is very low. So that's the thing, right? Now, these are different studies which are saying that oscillometry seems to be an excellent alternative to spirometry, or probably used for children, or probably as replacement or so. So this is the suggested algorithm which our unit has made. So this is the only algorithm which is existing in the literature. It is now published, and in which we can just say that what are the indications, what are the prerequisites, and then how to proceed, what are the things. And this is as per the latest technological report by 2020 published in ERJ. So we have modified it accordingly. There are various papers which our unit have come out on oscillometry. So one is this one, the original article, in which we have got almost 356 patients, pediatric patients, and we have told about that. Then we have also got a review article on oscillometry. And now, as I was mentioning about COVID-19 era, so these are certain studies which are saying that more loudly you speak, more forceful you take breath, there are more chances of aerosol generation. Similarly, there are like coughing, then all these things, they will create more aerosol generation. And this is once again the diagram which has been drawn by us, and it has been published. It has been, you can say, like accepted in the literature. On the left-hand side, you see spirometry, so many aerosol generation, because we are working from the expiratory reserve volume to the inspiratory reserve volume, really going to the residual volume, tip of the residual volume. Whereas In oscillometry, we are just working on the tidal breath. So the sinusoidal waves are going over the tidal breath. So the aerosol generation is very less. And hence, it is COVID friendly, COVID safe, can be used to monitor COVID patients in COVID pulmonary fibrosis, post-COVID asthma exacerbations, and all those things. So this we have published in Pediatric Pulmonology. The same thing, it says that oscillometry seems to be a good potential in the current pandemic and afterward to reliably monitor pulmonary functions with reduced risk of disease transmission as compared to spirometry. And then another paper in IJP, which came recently. So COVID-19 is Sputnik movement to revitalize oscillometry. So what we deduced is that oscillometry can be a value addition to spirometry in adults, but it is not a replacement in adults. Whereas in children, it can be a replacement modality in children and elderly. So to conclude, forced oscillation technique is potentially useful tool for assessment of airway reversibility, especially in the pediatric age group, and can provide objectivity during management. Scope for further research, comparison against the gold standard. So gold standard is still spirometry. Comparison against the gold standard spirometry, we require more studies. Utility in restrictive diseases, we need to explore more. And lung function assessment in ventilated patient and during sleep, we have started working on that. Probably will come out probably the next conference. And multicentric studies are required to develop normograms. Take home points, it's an easy to use pulmonary function test, much more sensitive for peripheral airway diseases. Bronchodilator reversibility can be checked, and it is safe in the COVID era. In adults, it can be used as a supplement to spirometry, whereas in pediatric, we can use it as a replacement. And for past 4 years, we at our unit are using predominantly oscillometry in the pediatric age group. We are not using spirometry nowadays. So seems to be like a future PFT. Thank you.
Thank you, Dr. Neeraj.
Well, sorry, sir. Report of spirometry, oscillometry, you want to say? Okay. So these type of reports you get, sir, in So these type of reports you get in oscillometry in which, so typical report I am not having here in the laptop, but these type of reports are there. Yeah, these type of reports are there. So now different parameter, if you just give me 1 minute, just give me 1 minute. Just give me 1 minute. So different type of papers are combining these reports in different methods, different modes. What they are doing is that sometimes they are using the same line and they draw it downstairs, and this purple line will come here. So in the same graph, you will get that one. Then there are other papers, which what they are doing is that they are just rotating it 90 degrees. So the frequency is depicted on y-axis, and this resistance and reactance is depicted on x-axis. So the graph totally seems to be like rotated, but ultimately the information is same. The graphs are like that. Thank you. Sir, please.
Yeah.
Sir.
So when you do a spirometry in an older child,
Sorry? Yeah, but how I can display it here? I can't display it here. Can you please put here? Right. Yes, sir, please ask your question.
yeah. So when you do a spirometry in an older child, as a part of the routine procedure, we check the bronchodilator response.
Yes, sir.
Now, do you do the same procedure while you do an impulse oscillometry in a small child?
Exactly same, sir. Exactly same.
And in what time you expect the bronchoconstriction to get reversed?
Sorry, say again.
No. When you do
Same thing, sir. After spirometry, like if we wait for 15 minutes, like the spirometry, and we do the same procedure.
So
Everything
in
is same.
impulse oscillometry also you repeat it after 15 minutes.
Yes, sir.
and then
Same
compare.
procedure. Exactly same.
Okay,
It is
thank
the procedure is different. Otherwise, rest of the other things, like if you want to go off SABA for 4 hours, off LABA for 24 hours, same thing.
Okay.
Everything is same. All things are same.
And the procedure remains the same. You use the inhalational short-acting beta
Yes,
to
sir.
agonist,
Exactly.
but
The
no
only thing-
nebulization.
No nebulization. Exactly same. But the
Inhaler.
only difference is that as we understand that's why the oscillometry is working on the tidal breath. So that is why any maneuver which might affect the tidal breath need to be taken care of. Like for an example, if a child or an adult is sitting stooping, then at that time the tidal breath will be affected. So he need to be straight enough. Neck need to be a little extended so that the airways are straight enough. Second thing, these cheek wobbling. So the cheeks need to be firmly, you can like somebody should be adhered to them. Nose clipping. This is also important. Then another thing is that if person is sitting on the stool, then at that time legs should not be crossed, because if the legs are crossed, then at that time the diaphragm movement will be affected. So any maneuver which is affecting the normal tidal breathing, that will be creating. Sir.
Just a comment. If you are doing reversibility with inhaler on all, first you do IUS, then spirometry, and after 15 minutes, first do spirometry and then IUS. This is what the Chest Council of India people are doing it, and this is their standard protocol.
So I will tell you the rationale behind it. The rationale is basically spirometry, as we explained, that it is a forced maneuver and it is an exhaustive procedure. So a child will probably not cooperate when you have already done spirometry. An adult might not cooperate once you have already done spirometry and thereafter you are doing oscillometry. So it is better not to disturb the child much. So that is why you perform the oscillometry first, so that is like almost like a non-disturbance to the child. And then you go for a forced maneuver, do the procedure, do the inhalation technique and all those things. Then thereafter you are doing the 15 minutes later spirometry. And why later oscillometry? Later oscillometry because oscillometry is much more sensitive for peripheral airway disease. So it will be able to tell you about the peripheral airway obstruction or reversibility also, which spirometry might not be able to pick up. That is the rationale behind it.
Dr. Neeraj, two questions. One is that there used to be a thought process that in a restrictive lung disease, like interstitial lung disease, can we follow the patient based on impulse oscillometry? That was my question when we started doing it. So I had around 5 patients of restrictive lung disease, and it shows beautiful graphs and means we can follow. So why in adult there is a lot of hitch against IUS? One. Secondly, is it true that we should not do any forceful maneuver before IUS? Because any forceful maneuver can alter the readings of IUS if it is done after that. Is it true? I have read in the literature that in a given day, you should not do any forceful, any maneuver which requires forceful breathing, and that will the impulse oscillometry.
Right.
Last point I want, what I found that like if you ask him to do tidal breathing, right? A given patient takes little bit deep inspiration and expiration, and second patient is exactly takes the tidal breathing, is shallow breathing in the given situation. Can it affect IUS?
Yes, sir. So answer to your first question. 3 questions.
Yeah.
First question. So first question is regarding the restrictive lung disease, as Dr. Dhiren rightly mentioned about it. So we are following in our unit. We are in the same unit. We are following in our unit about the restrictive lung disease. So especially the restrictive lung disease patients came to us from pediatric hemato-oncology, and those who are on those drugs, chemotherapeutic drugs. And yes, we are following for restrictive lung disease. First one, and then if the restriction is appearing, then at that time we ask that offending drug to be stopped for a reasonable period of time, and then we ask them for that incentive spirometry at home, that balloon one and all those things, the ball one game, and then after a reasonable 3 to 6 months period, we once again do the oscillometry, and if the parameters have reversed, then at their time we are following that. So we can do that. So answer to your question is this one. This is one. Second question is that he is asking about that whether a forceful maneuver should be done should not be done previously. So as I mentioned, that oscillometry is a very sensitive test, and anything which might affect that tidal breathing should not be done. Simple. So if a person who has walked upstairs and then you are doing spirometry, this oscillometry should not be done. He should wait till the tidal breathing is resumed. If a person has already done spirometry, which is a forceful maneuver, he will definitely take some time so that the tidal breathing should be resumed. So it's not that you cannot do it, you can do it, but the principle is that the tidal breathing needs to be resumed. So you require a reasonable period of time before any particular activity or anything. The third and the last question was that as it is tidal breath based, so suppose if child is unable to understand and he takes a deep breath in or deep breath out, so no problem, nothing happens because the minimum essential criteria is tidal breathing. But if the breathing is happening above and below the tidal breathing, it is fine with the machine, no problems. Another beauty of the machine is that this machine is so sensitive that whatsoever the cough is there or any inadvertent defect is there in the breath, it discards by its own. So you need not to do it like that. And only breaths required are 10. Minimum breath requirements are 6 breaths.
Sorry to interrupt, we are overshooting the time.
Yeah. Just explain this one, take this one because sir has asked and then I will, we can discuss it.
Thank you, Dr. Neeraj.
I will just explain this stuff and then I'm sorry for that. So, yeah, so this is a little hazy one, but it's fine. So basically what we understand here is that this is like a resistance graph and this is the reactance graph. How we come to know? So in the resistance graph, this bottom line is basically the 0 line in which the frequency is 0, 5, 10, 15, right? And here is the resistance. There are 2 lines which we can see. One line is here, another line is here. So the above line seems to be pre-bronchodilator and the below line seems to be the post-bronchodilator line. And we can see that the R5 and R20 relationship. So R5 is a little higher in the pre-bronchodilator, whereas R20 is a little lower as compared to pre-bronchodilator. And when we have done the bronchodilation, then they both have reversed. On the other hand, if you just see this graph, so this is the reactance graph in which this line is the line of zero. This line which is happening here is the line of zero, and in which what is happening is that the graph is starting like this and then crossing the zero line above. The graph is starting like this, crossing the zero line above. So the bottom line is pre-bronchodilator and the above line is post-bronchodilator. It's like that.
Thank you, Dr. Neeraj, for
Sir,
excellent
thank
talk.
you.
Sir, Vijayji, just one thing.
Sir.
Now, we had a panel discussion before where we discussed this
Yes,
issue.
sir. Yes, sir.
So just let us know in what group of children you would recommend this upfront.
Any
Dr. Dhiren
child,
also made a mention.
any child or adult or elderly or any person who is unable to perform spirometry, first indication. Second indication, if you are doing spirometry, let us say for any age, and you are unable to get the desired results as compared to the clinical condition, because sometimes it happens that the clinical condition is not matching with the spirometry findings, then at that time you need to perform a spirometry.
And last question, would you do it for a garden variety preschool visa where you are intending to give a trial of inhaled corticosteroids before starting this?
Sir, in our unit now we are trying to demonstrate pulmonary functions with oscillometry if we are suspecting any child who is probably requiring any sort of inhaler therapy. If we are unable to do it, then we leave it. Otherwise, we definitely try to do it more than 2 years of age.
Okay.
Thank you, Dr. Neeraj, for the
Thank you,
excellent
sir.
talk.
If we reduce the cost to say 300, 400 rupees, every patient who is entering your clinic, it should be a part of clinical examination. That is my thought process. Yeah. Yeah. So past 1.5 months, I'm not charging any patient, but getting impulse oscillometry of each and every patient in my clinic, not in Gangaram, in other clinics. So that is helping a lot.
Thank you.
Thank you. Thank you, sir.
We are doing it here since last 2 years. The cost is around 1,500 rupees. We charge for 1,500 rupees. Maybe.
Let me answer this cost issue also. So what we need to understand, there are 3 different type of vendors right now in the market. So one vendor is Thoracis, 4 different type of vendors. So the 3 are established one. One is Thoracis, one is Care Fusion, another is Biotronics, right? So all these machines are ranging somewhere in between 10 lakhs to 13 lakh rupees. So this is a one-time investment, and thereafter it's not that, so you will be able to do n number of tests. There is no limit for that. Now, the cost per patient comes is only the filter cost. So when you buy it in the bulk, so 90 rupees per patient per filter, it comes out to be. Now, suppose if you are having a more volume of the patient, then at that time you can probably keep less charges to the patient, because ultimately you have to recover the machine, right? If you are having less number of patients, so to recover the cost of the machine, you need to get more charges. Another point which Dr. Dhiren would like to add, but I will add it. So there is another machine which is the 4th vendor, which is called as PulmoScan. So PulmoScan is a newer machine which has just come up in the market. It is still not available freely in India, available on India Mart. And this machine is costing somewhere around 4 lakhs, 4.5 lakhs. And they claim that it is FDA approved. I have also checked that FDA approval, but we will not recommend that PulmoScan for now, because in our unit, we have both the machines, PulmoScan as well as the standard one. And we are right now comparing the results. So let us compare the result, then only we will recommend. Right now, we will not. Agree, sir?
Thank you, sir. Thank you.
Sir?
Thank you, Dr. Neeraj.
We are right now not doing spirometry. We are very happy with the oscillometry. Yes, yes.
Thank you, Dr. Neeraj, for excellent talk on newer modality to monitor pulmonary function in pediatrics. As we know, the spirometry was the only method to monitor the lung functions in pediatrics since many years. I remember when I was a student in medical college in 1977, in physiology, there was a bigger machine by which we were doing spirometry. As you know, there are some limitations. There are many limitations for the spirometry. Dr. Neeraj has aptly pointed out about the importance and indication of the impulse oscillometry. Though it is a costlier affair, nowadays, Dr. Rajkumar has said it is 1,500 rupees. It is a little costlier for the common patient, and the machines are very costly. We hope it will become cheaper and cheaper in the coming period. Thank you very much. Thank you, Neeraj.
Now the next topic, vaccination in allergy child. I welcome Dr. Sanjay Marathe, sir. He's from Nagpur. Sir is a member of Advisory Committee of Vaccination and Immunization in Pediatrics. He was Organizing Secretary, Pedicon 2018, Chairman Scientific Committee, Pedicon 18, Director, Marathe Child Care Hospital since 94, Director Colors Pediatric and Neonatal Intensive Care Hospital since 2010. Sir was President Maharashtra NNF 2009 to 11, President IAP Nagpur 2005, guest speaker for state and national conferences. I welcome Marathi sir to deliver his speech.
Good afternoon, everybody. It's a pleasure for me to be here once again. Thank you, team ALLERCON, for the excellent conference and the opportunity for me to interact with you all. Thank you, chairpersons, for your kind words. I must say the last discussion was a true discussion, where there was an interactive discussion. And in a conference like an ALLERCON, we must have this kind of an interactive session where all queries can be discussed. Let us think, when the topic was given to me, allergy and vaccines, I thought it's a very big topic, and where to start and where to end is a big problem. So I thought I will try to give you the connection with the vaccine and the allergy and try to give maximum take-home messages for all of us. So what I have done, 4 points which I would like to discuss: vaccines and allergic reactions, which all of us must know, whether the early vaccination predisposes the allergic diseases. Question number 2 to ask. Vaccination with allergic conditions, which is very commonly there are lots of myths and misconceptions, and we do not give vaccines, and we have already discussed this problem during COVID. Anaphylaxis, a separate discussion was already there, so I will just touch upon this point. And vaccine for allergy, which is something new. If you see the first topic, vaccine leading to allergic disorders and vaccine for the allergic diseases, this is something which is interesting for all of us. The hesitancy has become a false perceived risk of adverse events. And unfortunately, in COVID, we have seen the decreased incidence of vaccination or rate was basically because of the lots of unnecessary things in our mind. If you have this allergy, that allergy, something, even the asthma was a contraindication. And now we know COVID vaccine given to each and everybody, and asthma and pregnancy and post-pregnancy period has become a priority for the COVID vaccine. So our concepts are changing very fast. Vaccination represents one of the most powerful medical interventions on global health, which is very safe, sustainable, and effective against infectious and non-infectious. But because of the misconceptions and false perception about the allergic disorder, the hesitancy, we are not able to give you the adequate vaccination, and we are not able to give 100%. Even in a country like America, the vaccination coverage is not 100%. Unfortunately, because of these things, there are 2 harmful effects for this. One is the real threat for the anaphylaxis, which is very, very rare, that we must consider this one. And secondly, because of that, we are not giving the immunization adequately. So friend, take home message for all of us: never ever you start your OPD without confirming that there is an adrenaline ampule and an oxygen in your OPD. I think this is the most important, and every day before you start your OPD, ensure that adrenaline is there. Friends, adrenaline has a very short half-life. See to it that every 6 to 8 months you have to replace the adrenaline from your emergency kit. Now the vaccination and allergic reaction. The WHO has given estimation that for all allergies, the incidence is 1 in 50,000 to 1 lakh. For an anaphylaxis-like thing, the incidence is even much rarer, 1 in 1 million. So don't think that anaphylaxis is such a common condition and you can vaccinate very easily. It is always considered as the anaphylaxis is always because of the vaccine component. But the true fact is that the allergy or anaphylaxis is basically to the other additives of the vaccine rather than the vaccine component itself. And we'll see there were some traces of cow's milk in diphtheria and tetanus vaccine, and there was an anaphylactic reaction for the person who had a milk allergy, or in HPV, which is very commonly given in USA, there was a triggered anaphylaxis to the polysorbate 80, which is commonly added to this. So vaccines too have the potential to cause allergic reactions, but the components are equally responsible. It's very difficult to say the anaphylaxis was because of the vaccine component or the additives. Mild reactions are already there, and which are usually not to be treated very aggressively, but see to it that you must monitor this child, because this mild allergic reaction can turn into an anaphylaxis within 30 minutes. So be careful and monitor. The vaccine components, which all of us know, there are vaccine molecules, antigens, conjugation proteins, adjuvants, stabilizers, and preservatives, which are equally responsible. And these are the major culprits. Those who are interested can just go through the culprits, where gelatin was the most common cause of allergic anaphylactic reaction. Now from the most of the vaccines, they have removed gelatin, they have removed Even the albumin component, which we are going to discuss, is now minimal in most of the vaccines. We have better alternatives. So now vaccination has become very easy, and we can vaccinate almost each and every condition which is possible. There are 4 types of reaction. We'll be interested in type 1, which is hypersensitive reaction, which is IgE mediated, which is responsible for anaphylaxis at the end. Whereas type 4, which is delayed type of reaction, which is very commonly seen with the aluminum hydroxide as an adjuvant, which is commonly responsible for the hard nodule on day 3, day 4. If you get type 4 type of allergic reaction, you are not bothered because it is not going to kill the child, neither it is likely to get repeated in the subsequent doses. So delayed reactions, don't worry. Another type 1 hypersensitivity, which is IgE mediated, the most common clinical features, the allergic reactions, local or systemic, urticarial rash, hives. Then you can have, in serious condition, you can have respiratory distress, stridor, wheezing, abdominal pain, vomiting. These are the red flag signs. The child is likely to go for anaphylactic shock, and you must give adrenaline irrespective of what etiology it is and save the child. Erythema multiforme is very, very rare, so we'll not discuss, but that can be a very serious disorder. We'll not go into this because this is all theoretical and already been discussed. What are the signs and symptoms? We have already seen. The milder reactions can go for anaphylaxis, but there are similar allergic reactions which are called as pseudo-anaphylactic symptoms, where you can have this. Any suspected allergic reaction should be reported to the vaccination center because you are not sure you are dealing with what, whether it was an allergic reaction or it was a pseudo-allergic reaction. Local reaction, the management is very easy. Symptomatic treatment, cold sponging, and you may give paracetamol 15 milligram per kilogram. If it's an allergic manifestation, you can give anti-allergics or steroids. But see to it that whenever there is a case of anaphylactic reaction, adrenaline is the only drug which should be given without doing any investigation at that time. But the saving drug is adrenaline. Now, if there is a suspected allergic reaction, what is to be done? Ensure that you must take a proper detailed history. If the patient has already suffered an ALE after immunization, still you can vaccinate the child safely if you have already investigated the patient. If there is an anaphylactic reaction, you must investigate every patient. Even the subsequent dose of vaccination is not required, preferably after 3 weeks and before the 1 year of that anaphylactic reaction. If you are sure that the anaphylaxis was not related to this, you can repeat this dose even if there was a serious anaphylactic reaction. You can refer this patient to the skin specialist, which we are going to discuss again how it should be treated. From the patient history, we'll come to know what it is and how it should be managed. Latex and yeast allergies are not so common. Latex is now which is usually seen in the rubber or the cover of the hepatitis B vial or HP vial, which has become very, very rare. So latex allergy is no more an contraindication for any vaccine. Type 4, don't investigate the child, you can safely give the vaccine. To be or not to be the big question if somebody comes to you whether I should give a vaccine, it's very simple. Try to give the deeper vaccine subsequently so that the local reactions are less. When there is an evidence of protection and a booster is needed, like a COVID vaccine, you have given 2 doses of viral vector vaccine, and now on the second dose there was a reaction to the viral vector vaccine, and COVID booster is a must. You have ample alternatives available, and you can give either an mRNA vaccine or you can give an inactivated vaccine or you can give an Coavax or Corbevax. There are so many alternatives which are safer. So you can still go for a booster with the alternatives which are available and safely can be given. Suppose if there are no alternatives available and you have to give a vaccine in a situation, you must do a skin prick test. If it is negative, you can give the dose in a 2-phase graded dose formula, 10% and 90% under the supervision in an intensive care hospital. In case of skin prick test is positive, ensure that you are giving a desensitization process and slowly you are giving every diluted factor in every 15 minutes. So gradually you are giving these doses, but still you can give it. Now the second question which comes to our mind, vaccination and allergic disorder, which is very commonly asked to us. Let us see what is the evidence available. There was a big hypothesis called as hygiene hypothesis, which was highly discarded in last 15 years. It was thought that if the child is under a very protected phenomenon, you are giving a very healthy lifestyle and he has never been exposed to the infection, and you are giving lot many vaccinations to prevent the infection, it is going to make the person prone to get allergic disorders in future. But what the evidence says, the birth cohort study which was done for 10 years, they say there is no evidence to say that the adequate vaccination during early childhood has anything to do with the allergic disorder. So you can safely give. This is another take-home message for us. Another thing which was published in Elsevier, very standard journal, vaccination allergic sensitization in early childhood. They say there is no support for an association between an early childhood vaccination and early allergic disorder. On contrary, there is some protective advantage if you have given BCG and MMR. So if somebody has received these two vaccines, it is protecting the individual against the chances of getting an atopic dermatitis or future allergic disorders. So these two vaccines are very important to us. Third, what the World Association of Allergy Association says, a very standard recommendation has come. Standard routine immunization has nothing to do with the allergic reaction. In asthma, flu vaccine neither has precipitated asthma, neither it has been a contraindication, which are going to discuss it separately. Then the BCG vaccination, there is no contraindication, safely can be given. Neither there is a contraindication to the pertussis. So all vaccines can be given safely in the case of atopy or the asthma. Can childhood vaccination increase the risk of allergic diseases in the later life? A recent Allergy 2021 July childhood vaccination and allergy, a systematic review and meta-analysis has refused this. They say there is no correlation. So friends, you can safely go and vaccinate every child. There is no evidence to say that neither the vaccination precipitates the allergic disorder, neither it is an high-risk condition if you have vaccinated the child and give the vaccine. Vaccination prevents allergic disorders in children. Yes, there is some evidence to say that BCG and MMR has got some protective value, and so we should encourage vaccinating every individual. Now there is lot of discussion on egg allergy and asthma, egg allergy and vaccination. Friends, we know egg allergy is the second most commonest food allergy in the Western world. And there are 4 important vaccines: flu vaccine, rabies vaccine, yellow fever, Q fever. Addition to that, MMR and Pulmovax 23. They have got different amounts of egg in their vaccine because of the different processes. Either they are cultured in the fibroblast or they are cultured in the egg embryo cell. Now you can forget MMR and Pneumovax 23 can be given safely. The next slide says, which is more important to us, the study which has come in Lancet 2019, it says allowed albumin content in the vaccine should be less than 2 microgram per ml, and almost all the vaccines except 2, yellow fever vaccine and Q fever vaccines, they are having variable concentration more than 2. So that is the only contraindication if there is a severe egg allergy vaccine. Yellow fever vaccine, you can still give because it's a life-saving vaccination. If there is a severe anaphylaxis to albumin or egg protein, you can still refer it to the skin, do a skin prick test, and what I have said, you can, if it is negative, under the ICU criteria, you can still give the vaccine. If skin test is positive, you can desensitize it following the Munoz-Lano protocol. This is a protocol where you have to give it in a slow concentration. So you can give separately. Flu shots. Now there are enough studies to say that flu shots are not a egg allergy is not a contraindication for the flu shots. CDC has already given you 2 vaccines which are egg-free. So you have, and if there is a history of abdominal pain or non-specific complaint after eating eggs, and if patient can tolerate, you can safely give flu vaccine. Either you can give LAIV or you can give injectable flu vaccine. If there are more than reactions, more than hives, then give the flu vaccine under the supervision of the institute for half an hour, observe the patient. If there are no reactions, go straight away safely. If there is a severe anaphylactic reaction to the egg albumin previously, do not repeat the vaccine in the same patient, but now you have an alternative available. So in these cases, do not give LAIV. You can give injectable flu vaccine. If you are lucky enough and you are in America, you have a egg-free flu vaccines are also available. These are the 2 vaccines which are available in the CDC. MMR and egg allergy, forget about it. Rabies vaccines, there are only HDCV vaccines can be safely given because there is no albumin in it. This is the advice given for all the vaccines. Only you have to be careful about the yellow vaccines and the Q fever vaccines. If you are allergic to peanuts, initially they used to use peanut oil in various vaccines. Now there is no contraindication and you can use safely, because what we feel peanut allergy is uncommon. It's quite common in the Western world also. So you have to be very careful. Vaccination and asthma should be very clear. The recent 2021-22 BSA CI, that is British Society of Allergy and some CI is clinical immunology. It has made it very clear that you can give vaccination. All COVID vaccines can be given very safely and there is no contraindication. All asthmatics should rather be encouraged to take COVID vaccine because COVID can precipitate a bad asthma rather than asthma or a vaccine can precipitate it. So other way. In a steroid, if patient is on an inhaled corticosteroid, no contraindication. If patient is on a maintenance dose of steroid or had an ICU admission, be careful, give the vaccine in an intensive care setup. If recently there was a deterioration, then ensure that either you talk to a allergy specialist or you can go for a desensitization and give the vaccine. There is no harm in giving a vaccine even in this condition. Other childhood vaccine can be safely given in the period. Asthma and the vaccine shots. Flu shots do not worsen asthma, but flu infection does. Safely give flu shots in asthmatics. Either it's a quadrivalent injectable vaccine or an live attenuated influenza vaccine. COVID vaccines are recommended in asthmatics. Encourage them to get vaccinated. So there is no harm. COVID vaccine, in a single statement I can say, all COVID vaccines are safe in all allergic conditions can be given. If there is a severe allergic reaction in a COVID vaccine, you have a better other platforms available. You can go for the other platforms. And CDC has given very clearly that if somebody is allergic, severe allergy to mRNA vaccine, he can go to a viral vector form or any other form. Now the very good safe vaccines are made available. So don't worry, in COVID you must take not only the primary, but boosters are equally important and many alternatives are available. Should we stop the COVID vaccine if the patient is on the allergen immunotherapy or venom immunotherapy? For 48 hours you wait, otherwise you can give the vaccine. Then these are the diagrams which everybody can follow. Those who are interested can follow. Just last 2-3 minutes. Can I get an allergy shot after COVID vaccine? Yes, you wait for 7 days, you give the vaccine. After 7 days, you can give the COVID vaccine shots. The allergy shot, sorry. How to make a... Now, anaphylaxis, I will just go through it because this has already been discussed. Friends, this is the only condition which all of us must know how to manage it. These are the symptoms. Always remember, give adrenaline without thinking even once in your mind. Even an additional dose of adrenaline is not going to kill your patient, but definitely going to save your child if you give adrenaline twice, even thrice. This is the last 2 slides which are equally important. We have started discussing vaccine giving rise to allergic reaction. Then the vaccines in a special allergic situations where should we give. Now this is something which is very interesting. Now they are starting making vaccine to control allergy and which is going to give rise to a permanent solution. In last 10-15 years, lot of discussion, and I was really surprised when I read this. There are so many vaccines which are likely to come in future where they will be given to protect the individual from getting an allergy. And that is something which is very interesting. Allergen specific immunotherapy is based on the therapeutic vaccination with allergen. They will isolate the allergen, purify it to the maximum. Then they will do the genetic coding, try to find out which is the genetic part from which you can make a safe vaccine. They will create a vaccine and then they will give this vaccine to an individual who is allergic or who is likely to be allergic, or there is a family history of allergy. So if there is a family history of somebody who is likely to have allergy, will get an allergy, you can vaccinate them and protect that person from getting an allergy. So this is something which is very interesting. New allergy vaccines will increase safety, efficacy, and convenience of immunotherapy and are currently tested in immunotherapy trials. Vaccination with allergens, term allergen-specific immunotherapy, is the only disease-modifying therapy of allergy with long-lasting effects. This is the way they are making the vaccine. And before the take-home message for all of us, before this is a very important thing. the availability of allergen sequences and structures has allowed the development of new sophisticated allergy vaccines, which have entered successful clinical evaluation and hold promise that more effective, safe, and convenient allergy vaccines become soon available. And it even seems that prophylactic vaccination is on the horizon. So this, where we will be very optimistic to get this kind of an vaccine. The last slide for us, whenever you are giving any vaccine, ensure that you know how to do an CPR. The adrenaline should be there with you, oxygen should be with you. And without this, you should never give any vaccination anywhere. However, you are confident of giving a vaccine and you feel that this is very rare, but one patient of anaphylaxis and if he dies, then you had, that must be the last day of your practice. So last take-home message, friends, vaccinate every child at every opportunity you get without having much fear of allergic reactions, which are extremely rare, but never forget to keep your injection adrenaline ready. Keep vaccinating. Thank you, my friends, for your patient listening. That is only to cover the vaccination coverage, but I'm sure they must be carrying adrenaline with them.
No, not at all.
No, they
Not
don't
at
have
all.
adrenaline.
Very risky.
Not
Very
at
risky.
all.
See what government is doing,
They
I'm not
don't know.
answerable.
They don't know what to do and they don't know how to prick and where to prick.
I cannot change them. The
Then
recommendation
that
that
is
you should see, the practice should be whenever you start your
No.
OPD, see an adrenaline ampule and a syringe. Then start your seeing first patient.
This is.
You
this
never
is-
know.
this-
In indoor patient, you have started ceftriaxone to your patient and he gets an anaphylactic reaction. Then you cannot just go on searching for an adrenaline, which is not there most of the time, which
No.
is a criminal offense. So you must have an emergency kit ready, whether you are in the OPD, whether in an ICU. What ASHA workers are doing is government's.
This is
job.
government doing through ASHA work.
Yes, yes.
How I
So IAP's role is you should prevent the government to go for it.
Do you think that they listen to IAP?
No, not to
We can
listen,
send the guidelines,
but
yes.
at least you should
These are
initiate.
standard guidelines.
You should.
This is not
Yes,
something
sir.
I have taken it from my
Yes.
personal opinion.
No,
These are
that's why this for a mass.
Absolutely.
IAP should at least have a letter to aware the
The
government
point
that
is
what
that
are the practice are going there.
accountability is basically the first. You
Second
are
question.
accountable for the
Yes,
allergic
and
reaction.
second thing, there are so many of allergens. Is there going to be a universal vaccine to the or every allergen will be?
It's very difficult.
Yes, that's
Allergens
the
are
thing.
in millions.
So how
But
the
then,
vaccination will be?
See, there are 101 infections available, but we
Mm.
vaccinate against few conditions which are having lot of morbidity and mortality.
Yes.
Suppose they feel that
So
the
very
pollen
specific.
allergy is the most common.
Yes.
Then
Yes.
try to
Very
find out the
specific
vaccine
then.
against the pollen allergy.
Thank
They
you,
cannot make
Suchi.
the vaccine against everything.
Thank you, Sanjay. Thank you for such excellent talk on the
Thank
allergic
thank you, Suchi.
vaccination
Thank
in
you,
allergic
Sanjay.
child.
Given, that is a policy to be decided by the IAP Central and given this to the ministry. Definitely
We can
will take-
recommend to the
must, at
government, we
least we
cannot
must-
force them to.
Yeah. Okay, thank you.
Thank
Yeah,
you,
one
sir.
question.
Thank
I
you.
would
Thank you, sir.
request.
One question. Thank you, Sanjay, for the excellent talk on the
Sir, one question.
vaccination in allergic
One
child.
question. So
Only
you are-
one point I want to ask to Sanjay
Yeah,
itself.
yeah.
If the child is having urticaria, should we vaccinate him or not?
Yes, urticaria is a very non-specific condition. He has not got urticaria because of taking some
At the time
vaccine.
of vaccination, I mean.
No, at the time of vaccination, why you want to give? If he's having an urticarial rash, you can give it after 2-3 days.
Yes, yes. Thank you.
Because then suppose he gets a reaction, you will consider this urticaria as a previous disease.
Exactly.
So don't give any symptom, any allergic symptom you can avoid.
Yes. Thank you, Sanjay. Thank you very much.
Sir, your said allergy vaccine is a now future. So any trial is going on, you know the name and where it's going on now.
I did not get the name of the trial, but I will certainly search. But this is something which was very interesting, and I
Yes.
thought I should at least introduce this. Somebody might be having this, but at least I have no idea whether some trials are going on. Okay. Yeah.
To give that exclusively to patients who have cat allergy. But the trial has not been successful. They're trying the same thing with Ambe1, which is the key allergen in ragweed. Again, the trials have been partially successful. So I think when we go into molecular immunotherapy, we are going to need more data because we don't know which major allergens we need to combine together to get the same effect as we get from the whole allergen or what we call the native allergen. But that is a very active area of research, and the future is molecular immunotherapy. I'll cover it in my lecture at the end.
Thank you, sir.
Thank you. Thank you.
Also, I want to inform that there are two cars, car number 3047 and 2767, are parked like on a road. And I will request Chairperson Dr. Marathe sir and Dr. Neeraj Gupta sir to be on dais for a photograph. So Dr. Kiratkar sir to be present.
Thank you, Marathi sir, Dute sir and Wab sir. In India, there are egg-free cakes and now egg-free vaccination expert. For last session of this PED ALLERCON, chairperson, I would like to invite Dr. Mustafa Ali sir and Dr. Deep Kumar Sahu sir.
Thank you, Abhishek.
Next topic is by Dr. Dhiren Gupta sir. I would like to invite Dr. Dhiren Gupta sir. The topic is nasal manifestation of allergy, clinical radiology and nasal endoscopy correlation.
Dr. Dhiren Gupta has done his MD Pediatrics and he is Deputy Director, Division of Pediatric Emergency Critical Care, Pulmonology and Allergy Disorder, Sir Gangaram Hospital, New Delhi. He was Chairperson of Pediatric Critical Care IAP in 2021. He is Chancellor Pediatric Critical Care College 2021 and Teacher for Fellowship in Pediatric Critical Care 2004 till date. He has received Vishishta Chikitsa Ratna Award for contribution in the field of pediatric intensive care by the Union Health Minister. And he has also received the Corona Warrior Award by WHO Chief and Central Minister Dr. Harshvardhan on 6 June 2022. So welcome Dr. Dhiren Gupta to Orange City and he will be delivering his lecture. Sir, you
Yeah. Thank you, sir. I don't know whether I deserve all these. You will be thinking that, kya ajeeb sa naam hai? Nasal manifestation of allergy. Yeah, and what I want to say, you know, in 2012 onward, I started doing pulmonology when I found that a lot of money is there, you know, OPD runs through that. And in intensive care, it is more or, you know, effort and there is nothing much. And Dr. Chub left our hospital. So that was the time. Then I thought that, okay, I'm doing bronchoscopy, but I never thought that I'll be doing pulmonology. Then I found that for many years, we were just blind. Means, then we included allergy part. So including impulse oscillometry, skin test. And what I found that previously pulmonologists used to make the things difficult for journalists, like telling them, okay, this is very difficult branch. Then I found that many allergists try to make the things difficult that, okay, this is something very special, this skin prick test. And so what I found that over the years, there's nothing impossible and very difficult. We all are MD and done MBBS. It is just a practice what you do. But you follow the science, and if you grip the science, then it's very easy. And if you're able to intubate, we all are neonatologists to start with. If you're able to intubate, what is about the skin prick test? It is just an interpretation and you are just giving, you're touching and doing the test. Now, with every patient, I used to think whether this patient is having some comorbidity of adenoidal hypertrophy or some allergic sinusitis, because this is a major comorbidity which changes the management totally, right? So I started doing, I started sending the patient to ENT people. Over the years, we used to do X-ray, right? Now, past 2 years, everybody do endoscopy and send the patient to you, oh, this is a significant adenoid and go ahead. This is a major comorbidity. Then I thought, why a pediatrician shouldn't learn this technology of endoscopy, or shouldn't we focus more on nose, which we are forgetting, just keeping our stethoscope on chest, then doing allergy test. That's why I thought that let me share my experience of if we focus on the nose as a pediatrician, most of the pediatricians just focus on the vaccination for years. So during COVID time, all were almost jobless, right? Because we often forgot to take risk in medical science. We thought endocrinology, okay, refer to endocrinologist, rheumatologist, refer to rheumatologist. We all have read Nelson and we forgot to take the risk. And now we are just left with vaccination and we are happy. That is the wrong thing. My ultimate aim is going to be, say, probably by next year, I want a 6-hour module where allergy and respiratory medicine, which we are practicing for years, should be practiced by pediatricians, right? So this should be linked. So pulmonology and allergy should be linked. And same way, I want to introduce a nasal part. So my presentation is going to be on the nose part. We all know that there's a lot of importance of the nose in the management of allergy. And so my aim is going to be clinical, radiological, and endoscopical utilization and correlation. What we know over past 2 days, there is a strong association, means allergy and the asthma. Allergic rhinitis affects 30% of the adult, and beyond 4 to 5 years, it affects 40% of the children, and almost 80% of asthmatic have association with allergic rhinitis, and 50% of allergic rhinitis has relation with your asthma. This I am listening, means I was on YouTube, I couldn't come here. We all know that it's a united airway, means it's a nose, throat, and lungs. This is a part, they are like, I always explain, and in the family, if wife is your lung and then your nose is your mother, so you have to keep balance the nose and the lung part, only then you can manage the patient. We all know that there are systemic inflammatory response, whether allergen is in the nose, it will create systemic inflammatory response. It will lead to asthma-like or allergic symptom in the lung. And same way, it is other way around. And we all know that for many years, we know that it is atopic dermatitis and then your allergy. So probably the march can be skin mediated, march can be transbronchial mediated, march can be transnasal mediated. So there can be lot of areas through your allergen can further promote the problems. And we all know that if nose is blocked, it will lead to mouth breathing. More mouth breathing, it will lead to more infections. And there is a nasobronchial reflex, which can result, if nasal mucosa is irritated, it can lead to bronchial asthma-like condition. We all know that this is a point of research that pollen sensitization and allergic rhinitis, if you are able to control, you may be able to prevent adenoidal hypertrophy that might trouble the patient. And these are the nasal symptoms: sneezing, stuffy nose, runny nose, itchy nose, nose bleeds, and clear drainage from the nose, ear infection, repeated middle ear infection, purulent discharge, and snoring. This all we know that these are the common symptoms. But most important for a pediatrician is a nose block, snoring, and breathing from the open mouth. So these are the most important points which we know that can lead to problem. And these are the common signs and symptoms which may be present in diseases like rhinosinusitis, adenoidal hypertrophy, and rhinitis that can be allergic, that can be non-allergic. I want to just emphasize rhinosinusitis means sinusitis is also there with inflammation of nose. This normally happens in a bigger child, 10-year, 12-year-old. Adenoidal hypertrophy, we have seen around 7-month-old baby also with significant adenoidal hypertrophy, but usually peak age is around 4 to 5 years. It starts from 2 to 2 years onward, and normally 10-year onward, it regresses. And of course, rhinitis, it can be allergic and non-allergic. There can be other differential diagnoses if there is a problem in the nose, like local allergic rhinitis, which classically used to be called as NARS, and it is a local nasal inflammation, not a systemic inflammation. And we all know that allergic rhinitis can coexist with rhinosinusitis, and both can exaggerate the nasal symptom. So as I told you, age relation, if a smaller baby, I would like to look for the adenoidal hypertrophy, then your allergic rhinitis comes, then rhinosinusitis come. So this way it progresses, and it is not a rule. You will find 4-year-old child can have rhinosinusitis. So let's come to know the point, that is clinical examination of nose and the surrounding area. We all know that this is a Danny Morgan creases behind, below the eyes. These are the soft markers for an allergic patient. Allergic shiners is very common, like eyes, around eyes. This is more common than the previous one. And of course, allergic conjunctivitis can coexist with rhinitis. Very important part, just looking at the nose, if you find no inferior turbinate looking protruding in the nose, probably that is normal. But if you are able to find bilateral pink soft structure in the depth of the nose, ask him that, does your child snore? So start from this clinical examination of the nose. What I carry a otoscope like this, which has got a video. So it is a rigid one. I just insert it 1 centimeter inside the nose, and I am able to define the inferior turbinate, and I am able to know the color of this inferior turbinate, because inferior turbinate is considered to be as one of the hallmark of allergic rhinitis. And I look at the throat, and in this patient, yesterday this patient came, I could see the lymphoid hyperplasia in the throat. So that is another sign. When we talk about radiology, there is a lateral soft tissue neck to define adenoid and palatine tonsil. Maxillary sinusitis can be defined, and chest X-ray to rule out ABPA and tuberculosis, which means in a given patient, you cannot rule out a patient is having cough for more than 2 weeks, that tuberculosis is not there. Probably I was given around 25 minutes. Okay, I will try to finish up and in the given time. We all know that how to read in an X-ray. We have talked past many years how to read in an X-ray for the lateral view. The simple way is, if you look at your palate, this is your palate, and this is your airway, this black one. If your palatal size is more than the airway, you call it is a significant abnormality. Also look at the maxillary sinus in one view. If you find this is your orbit, and the ipsilateral sinus is more opaque than the ipsilateral orbit, likely it is here. This is very non-specific, but this helps in a lot. And if I collect my 1,000 patients where I got these sinuses X-ray beyond 10 years with nasal sign, almost in 100% you will find something like this. And that helps in managing these patients. In acute sinusitis, you may find fluid level, but in a chronic sinusitis, more common is your polyp. These are the polyps. So in acute maxillary sinusitis, this is a fluid level, and with fluid cavity, concavity upward, and polyp will have convexity upward. So these are not very insensitive, but they are quite sensitive. In fact, on a plain X-ray also, you will be able to note that there is a turbinate hypertrophy on plain X-ray PNS. So what is the status of conventional radiography? We all know that CT scan in a given case of asthma, in 50% you may find paranasal sinusitis. But if you compare with the gold standard CT scan, even your plain X-ray is 80% sensitive to show you all these changes. Though if you ask ENT people, they say, no, we just believe in CT scan. There's no role of X-ray. No, it's wrong. And also there's a study which was done to compare the sinus radiography with the CT scan. Again, the sensitivity was 80 to 90%. Now we come to the today's topic, that is a nasal endoscopy. Nasal endoscopy is nothing. It is a fiber optic bronchoscope. It's a soft, very soft structure as compared to your usual bronchoscope. Just insert inside the nose and look at There's your inferior turbinate in the depth and adenoids, right? So it is a flexible one. It is rigid. We don't normally, as a pediatrician or a pulmonologist, we don't go for the rigid because it requires a little bit more sedation. So I normally use a flexible disposable bronchoscope that is much softer than normal bronchoscope. You just take in 4% xylocaine, just spray on the nose, take 10 minutes and start doing it. It's an OPD procedure. What I found over the years, pediatricians are very busy. If you ask some patient, okay, you go to that place and then get it done. 50% of time, not only because of the cost, because of so many other factors, you will lose that patient, right? But in a given setting, without moving your chair, if you're able to perform impulse oscillometry by portable impulse oscillometry, same time, if you feel that this patient requires nasal examination, if you are able to perform that, your practice will be totally changed. What we do, we just insert the fiber optic one and insert at the level. This is known as first pass. In ENT practice, if we want to practice our pulmonology and allergy, you just need one pass, not 3 passes. In ENT, there are 3 passes to see middle turbinate, to see the superior turbinate. But here we just, like an NG tube, we insert your fiber optic bronchoscope inside the nose, and it is on the floor beneath the inferior turbinate, and you will be able to view your adenoids and turbinate. Let's see what is the importance. In a small child, I just don't want to look at other parts. I just want to look at the adenoid directly. So it's 15-second job, right? In bigger child, you may be able to, if patient nose is allowing you, if patient is allowing you, you can pass a little bit above to see the middle meatus. I'll show you the normal endoscopy. So in the first one, look at, I'm entering, this is being entered here. And this is on the left side, this is your inferior turbinate. And look at, you're able to see the pharynx, right? And you are able to see the pharynx. And this is the normal pharynx. And this is a small adenoid, you can see. This is small adenoid, and this is your space where your eustachian tube opens. Now look at the second one. This is again on the left side, this is the inferior turbinate. You can view the inferior turbinate. It's entering, entering, entering. At the end, you will be able to view the nasopharynx, where the adenoids are there. Now, you have reached here, right? So this is a part of adenoids, and this is your eustachian tube opening. And means you can make out, I'll show you some one video of middle turbinate. This is your middle turbinate, and it's not easy to reach to the middle turbinate if your inferior turbinate is hypertrophied. And don't try to provoke middle turbinate unnecessary. So you should know our limit, and what I want to know in the patient, that is sufficient for me, right? I want to know the inferior turbinate, I want to know the adenoids. So these are the endoscopic findings expected in a patient with the nasal symptoms. Look at the inferior turbinate. This is a pale mucosa, inferior turbinate hypertrophy. There will be poor space to pass an endoscope. And adenoidal, look at the adenoid. This is your Rosenmoller fossa. Here your eustachian tube opens, and this is your adenoid. Look at the size of this. If your size is more than 2/3 of your concha, that is the posterior part, probably it is enlarged. Now look at another finding which we often miss in bigger child, 10-year-old. You may not be able to find adenoid because that is not a type of, that is not an age for adenoidal hypertrophy, but you may be able to see the lymphoid hyperplasia, right? You can see the pebble stone, and this is almost normal type. So this is an important, you can say, findings. We can grade the adenoid. It's a very simple. It's 1/3, 2/3, more than 2/3. You will be able to judge whether it is adenoidal hypertrophy or not. And even common sense, if you use common sense, look at A1. What do you think? This is an inferior turbinate. This is an inferior turbinate, right? What do you feel? Is it a normal? Is it whitish, bluish, and looks enlarged, right? So even if you haven't seen inferior turbinate properly, you can make out, okay, this is inferior turbinate. right? Sorry. No. This one is the second one. Second one is again little bit more shiny and little not typical red bluish color. This is an adenoidal hypertrophy of grade 3. You can view that this is occupying almost complete part of posterior pharynx. This is a patient with lot of mucopurulent secretion. So likely this patient should not be started on steroid. This patient requires antibiotic for long time. And this is a case of rhinosinusitis. Now, just two cases. I'll take 2 minutes and I'll finish off my presentation. This was a patient who came day before yesterday, case of mucopolysaccharidosis type 1 on CPAP, having recurrent cold cough, right? Having no sign, no history of allergy in the family. I was not able to open his mouth because mucopolysaccharidosis, you cannot open the mouth, right? And he was a little bit obese. So for respiratory assessment, I got a lateral view. In a lateral view, look at, I'm not able to view the adenoids. It looks very hazy, but I could see this rounded structure here, and this must be palatine tonsil. So huge palatine tonsil. This patient was probably unnecessarily getting CPAP. To take away these two things, and patient should be fine. So I thought, let me do endoscopy in this patient. In endoscopy, because I was not able to define the adenoids, and look at the adenoid, it is around 2/3 it is occupying. So you can say next 15 minutes, you're wiser enough to give him an advice, okay, you need to go for adenoidectomy and your CPAP, you should be able to reduce the setting of CPAP. Now let's take more common situation. A 12-year-old with persistent cough for 7 days. He was admitted 2 days, 5 days back for 2 days for fever and cough. When he came to me, sir, cough chalti ja rahi hai. It's not, I'm not able to stop, and especially during night, cough is significant. So you think that during night, either it could be upper respiratory resistance syndrome because of adenoid or some sinusitis, or it could be asthma, right? So I got a lateral view because presently I'm doing study that can I correlate my endoscopy with the radiology? So what I could find that this patient, I am not able to differentiate which is palate and which is your adenoid. Okay, so I went ahead with an endoscopy, and what I found that adenoid was very small. Look at, this is a very small adenoid, and it was all pebble stoning, all pebble stoning. So I gave him nasal steroid and beta-2 agonist. Now patient is absolutely fine. This is another 6-year-old child who came from nearby town. He had got 3rd episode of fever for past 1 month. Every time it is 103, 104, and no nasal symptoms except restlessness during sleep. So on X-ray, I found it is an adenoidal hypertrophy. So should we perform endoscopy in a febrile patient like this? Yes, I did it, and I found that inferior turbinate was a little bit hypertrophied, but more surprising, I could grab the cause of fever. And if you go inside, you'll find that adenoid was full of pus. And this was on 5th day of monoceph. Patient was being given ceftriaxone. And if you look at the, I think it will come. So the adenoid was actually, yeah, now you can make out there is a white discharge on the adenoid. Can you make out that white discharge? So I could grab the cause of fever, and you know that this patient can, further episode can be prevented. So if you look at the studies, all says that there is definitely role of endoscopy in a patient of asthma and allergy, especially for adenoid and adenoiditis. It should be used. There are some study which has correlated X-ray lateral view with nasoendoscopy finding and found that it's quite related in almost 80% of the patient. So I did around 45 endoscopies in 1.5 months. And over 3 years to 16 years, 3 years, it takes a lot of effort to put an endoscope in 3 years. They cry a lot. 5 failed because of too much crying, and I could not get the space. And 10 X-rays were done. I found very good correlation. In 80%, it was inferior turbinate hypertrophy, which is said to be hallmark of nasal allergy. and less than 6 years, almost all had adenodal hypertrophy. So I conclude my presentation. If you find a nasal symptom, which we should look as a, because it is a united airway, it is a major comorbidity. If you control nasal symptom, you may be able to save transnasal march. Radiology versus endoscopy, it all depends on the facility you are available. But of course, we want to save radiation in these patients. And again, if you make these things free of cost as a part of examination, if you invest 1.5 to 2 lakhs in your clinical practice where you can buy an iPhone, so what's wrong in giving that facility to the patient? And impulse oscillometry, these type of settings, if you make them very cheap, probably it is going to be the future, and it is non-radiating. It takes much lesser than the time than the skin prick test, and if it has got a very short learning curve. And thank you very much for the patient hearing. Thank you very much.
Thank you, sir, for a wonderful and lucid talk. Any questions?
Sir, आपका mic नहीं काम कर रहा.
Thank you, sir.
Thank you, sir. Any questions, sir?
Thank you, Dhiren sir, for this wonderful topic. Definitely enlighten our knowledge. For next topic, I invite Dr. Sitesh Roy sir. This topic is allergy curable, immunotherapy, past, present, and future in Indian scenario.
Dr. Sitesh Roy has done his MBBS, MCPS, and MD from USA. He's fellow of American Academy of Pediatrics. He's also a fellowship of American Academy of Allergy, Asthma, and Immunology. He's a super specialist in immunology, allergy, and asthma. He's a founder director of Roy Health Solutions, Multispecialty Clinic, Bandra, Mumbai. Welcome, sir. Sir, can you come?
Thank you very much. It's going to be the final session, and as you can expect, it's a hard-hitting session because everything that we've been discussing in the last 2.5, 3 days ultimately boils down to, can we do something about what we find? So I'm going to take you through the entire gamut, starting from a little bit on the burden, the current options, the evolution of immunotherapy, the currently available immunotherapy, clinical evidence, long-term benefits, and ultimately the guideline recommendations in pediatric allergies, and also a little bit on other immunotherapies other than what we typically think about. So I think this data has been presented already several times, but clearly allergic rhinitis, allergic rhinoconjunctivitis has greatly increased amongst the pediatric population in the last 10 to 20 years. We are now reaching levels where the US was a couple of decades ago, and we will cross them, I'm quite sure, in the near future. And that's literally something that will bring our level of burden for this disease to international levels and more. So once we have a child that we have finally tested, diagnosed with allergies, there are a couple of options, and I've heard all of this from a variety of different doctors, from family physicians to pediatricians to other doctors, and parents coming to us with a lot of different ideas in their mind, but many of them just feel that they can just live with it. Many are told, wait, it will go away. You'll outgrow it. Just wait till you turn 5 or 6, it will go away. And then they're 7, 8, 10, and they're still coming to us with the problem. Let's do something about it. Absolutely. Episodic therapy, it's good, but not ideal. It will give some relief. Long-term watchful management where you do preventive treatment, that's the goal. What you really need is a disease-modifying therapy, something that can actually alter the natural history of a disease. Again, this has probably been presented, but when you treat any allergic disease, there are 4 components. You're talking about patient education, so they know what they have, what they are in for, how long it can go on for, and what they can do about it. Medications, allergen avoidance, and then immunotherapy. Allergen avoidance, I'm sure, has been covered again. Immunotherapy is what we are talking about. So the definition is very simple. It's administering gradually increasing doses of an allergy vaccine. We heard vaccination just a little while ago from Dr. Marathe, to an allergic subject, clinically relevant allergies. That's very important. Reaching a dose which is effective in ameliorating the symptoms associated with the subsequent exposure to the causative allergen. The first published data on allergen immunotherapy was about 112 years ago, 1910, Lancet, Freeman and Noon. Sister went out, collected Timothy pollen from the field. Brother got it home, prepared an extract, a very crude extract, and gave the first injection. Within 6 months, they documented that the patient's hay fever allergies in spring were reduced, or in summer. It's a grass pollen. Since then, we've come a very long way in the last 112 years. I always tell people that immunotherapy actually began in India. If you all know Acharya Chanakya and the story of Chandragupta, he had given, and this is just one example, he had given Chandragupta a variety of different poisons, right from snake venoms to scorpion venoms, because he knew that even orally you could desensitize people from an allergy by giving them increasing doses of it. Some of them almost killed Chandragupta, which we know we have done through immunotherapy. We've had fatalities, so we've gotten a lot better. But immunotherapy didn't begin in the Western world. It began very much in India, which is the cradle of medicine for the whole world, if you look at it. The mechanisms of immunotherapy really begin from the time when we give the very first dose, and the dose is generally a supernormal exposure. So when you have a normal environmental exposure, it's in microgram quantities, probably nanogram quantities. And when you're giving injections, it's in microgram quantities. And that essentially deviates the immune system towards all the Th1 mechanisms, the blocking antibodies, the regulatory T cells, and essentially production of IgG4, which is a blocking antibody. There are defined at least 14 mechanisms by which immunotherapy works. I'm not going to get into those. It's not the primary thing. But even just in the last 10 years, we came to know a new cytokine, IL-35, which has a very important role in modulating the immune system. We knew about IL-10 and TGF-beta for decades now as immunologists, but now we know about this also. This is what was being spoken out in the previous talk, or brought the talk to an end. We know about secondary prevention, where if someone has allergic rhinitis, you don't want them developing allergic asthma, immunotherapy can help. You have one allergen sensitization or 2 or 3. You don't want the 4th and the 5th one to develop new allergen sensitization. So that is your secondary prevention. You have someone who has allergic rhinitis. You don't want them progressing to asthma or asthma with allergic rhinitis. That becomes kind of a tertiary prevention, and you don't want their symptoms to progress. That would be more tertiary prevention. But is primary prevention possible, where you take a high-risk child who either has a sibling or both parents with allergies, you identify that they are already getting sensitized, not allergic yet, and you give them immunotherapy so that you can prevent the development of disease. This is the holy grail of therapy that will come in the future, but it is still a long ways away because this is a very complex topic, and selection of patients is really the hardest point in this. When we look at allergen immunotherapy and what it does compared to pharmacotherapy, it's a loaded scale, as you can see on the left-hand side of the slide, where with drugs, you're largely giving symptomatic care, which works as long as you use the medication. Whereas with immunotherapy, you're looking at long-term changes, you're looking at reduction of symptoms, you're looking at reduction of drugs, you're looking at reduction of exacerbations, you're looking at a long-term efficacy improvement beginning within months of therapy, lasting for years, and even decades after completion of the immunotherapy. I'm going to very briefly go over all these with you in just a second. So we know that the influence of anti-allergic drugs at various points. So while corticosteroids have the maximum benefit, we know that anti-Ig antibodies can actually block the reaction at a very early stage by preventing the mast cell coating by the free-flowing and free-floating IgE. But really, if you can prevent the actual reaction at the very contact, that is where immunotherapy comes in, where the immune system does not see that allergen as a bad guy and is able to tolerate it like a good guy. Allergen avoidance and immunotherapy are the only disease-modifying therapies, according to WHO, when it comes to the management of allergies. These are the various indications where patient preference. So people say it should only be used for moderate to severe disease. I disagree with that. If I have a mild allergic patient who is requiring an antihistamine on a nasal steroid, and the parent does not want the child to stay on medications all the time or frequently, they absolutely deserve to be on immunotherapy. And I think the guidelines also agree with that. And there are very clear indications besides allergic rhinoconjunctivitis, but also stable asthma, also atopic dermatitis in well-selected patients can make a huge difference. House dust mite immunotherapy has literally cured a lot of patients of mine. And then with Hymenoptera venom, which you heard an excellent lecture yesterday by Dr. Narmada, the efficacy can go up to 95 or 99%. So what are the indications we are looking at? Allergic rhinitis, conjunctivitis, the top data and the top level of evidence. Allergic asthma, very good evidence. Large local reactions to insect, that's mostly for adults, not for pediatrics. In pediatrics, only systemic reactions are relevant. Atopic dermatitis. Sensitization should be relevant with the right kind of symptoms. So it can't just be, so I know a lot of labs these days which will send a person to a doctor's clinic and say, don't worry about whether you can diagnose allergies. We'll do the test and we'll give the immunotherapy. There is no contact with the physician of the patient to know whether the skin test has any clinical correlation with the symptoms of the patient. So it's a very, very scary situation going out there. Symptoms should be of sufficient severity and duration, and the availability of high quality antigens. That is really something we are struggling with, but we make do with the best we have and work on it. So this is kind of for rhinitis asthma, right from the moderate to severe intermittent allergic rhinitis, okay, to the mild persistent, the moderate persistent. And then in the same way with asthma, with well-controlled and partially controlled, IgE-mediated allergies being a trigger, you can do immunotherapy. So only the mild intermittent allergic rhinitis and the uncontrolled asthma patients are the two categories where immunotherapy can be done only once you bring the asthma under control. The mild intermittent obviously don't need it. When you compare allergen immunotherapy combined with drug therapy versus drug therapy alone, there is a significant reduction in terms of the medication score and the symptom score that can be seen in patients. And I think this has been proven beyond doubt. This is actually a review paper, but there are multiple papers like this. There are two forms, subcutaneous, sublingual. We won't get into too much details about it, but I'll speak about it. The typical allergens that you're looking at, and these are the same ones that are available worldwide. So the strongest and most solid data that we have for success with allergen immunotherapy, with rates going above 80%, happen for house dust mites and for pollen, variety of pollen. Animal dander comes in at a 2+, as you can see here. Molds come in at a 2+, and cockroach comes in at a 1+. Okay, depending on whose hands it is in, why it is being done, how it is being done, I guess it can be a 2+ also. What are the contraindications for immunotherapy in pediatrics? So there are some absolute contraindications. If the FEV1 is less than 70%, you don't want to do immunotherapy, you want to treat the asthma and bring the FEV1 higher. Have I done it in people lower than that? I have, but then again, I have that much experience to know when I can do it and I cannot. Age less than 2 years, not recommended. Serious immunological disorders, you can read the rest of it. Intake of beta blockers, uncommon in children, but is in the list. Relative contraindications, age less than 5 years, severe atopic eczema, cardiovascular diseases. The youngest child that I have done immunotherapy with was 18 months old and had serious life-threatening fire ant allergy. Okay, to the point that she had been in the ICU on a ventilator both times that she was bitten. And the parents were very clear that they did not want to take a risk for the child to get bitten again anytime in the future. And with a very, very serious, long 4-page consent, we began the immunotherapy. The child by the 4th dose was very happily taking the injections without a single squeal or a cry. And by age 1, by 1 year of completion of the immunotherapy, that child was bitten by 25 fire ants and had nothing more than a little swelling at the site of injection and a few sterile pustules, which are expected to happen. So these are all, as I say, in the context of a large scenario. Allergen-specific immunotherapy for pediatric asthma and rhinosinusitis, the evidence is very strongly supportive that it helps. I'll present more data. There is improved efficacy. I'll go through each of these. So when you look at symptom control, you can see with subcutaneous immunotherapy, done in the total symptom score and the total nasal symptom score. In both cases, the significant improvement compared to the common drugs. From the very first grass pollen season in this study, improvement was seen, which is generally 3 to 6 months within the starting of treatment. And in every aspect of therapy, improvement is seen. This improvement is sustained for up to 10 years after completion of immunotherapy. So there is plenty of data starting from the very first published paper in 1967 by Johnston et al., who showed that you can see improvement for up to 7 years after completion of 3 years of immunotherapy in a child. So when we talk about getting as close to curing a disease, this may be as close as we can get. Are there relapses? Yes, there can be relapses in up to 30% people. There can be with new allergens that were not desensitized before, and re-desensitizing them can make all the difference in the world for them also. This is another data. Again, this is the data from 2007 by Jacobson, where they showed that specific immunotherapy at a 10-year follow-up had a 45% reduction in the chance of developing asthma at 3, 5, and 10 years. That's pretty big. New sensitizations reduced by half in kids who underwent immunotherapy. This is with the allergoids, which we had in India till about 2.5 years ago. Now we don't have the hypoallergenic house dust mite extract, but this was shown to substantially reduce the rate of asthma and reduce the rate of new sensitization even 12 years after completion of the subcutaneous immunotherapy. Reduction of inhaled corticosteroids by a significant amount, 63% reduction in inhaled corticosteroids. That's a very big change when you look at a disease that may require therapy for decades if you are not doing something to change the disease. And this is a very important slide because, again, it's a very tricky topic to say, can you cure allergies? I believe I'm an practicing allergist immunologist for now 22 years. And I can tell you, you can cure specific allergens. You can't cure the innate tendency of the human being to develop atopy, okay? To change the innate nature of the human being to develop atopy, you have to go into their diet, their lifestyle, their stress levels, and a lot of other what I call holistic medicine, which I do in my practice. And you really have to change the nature or the body type of the human being, which is not an easy process and certainly not something that modern medicine easily buys into. But if 60% children could come off their inhaler at the end of a 3-year of allergen immunotherapy, that's a pretty drastic reduction, I would say, for a disease like allergic or pediatric allergic asthma. And that's about as close as we can think of getting with this disease. I believe I was given 30 minutes, so I'm going to continue a little bit longer, okay? The risk factors for allergen immunotherapy, current allergy symptoms and potential allergen exposure, current infection. So if someone is actually infected, we don't start immunotherapy for them. I have delayed this several times. Patients have come in. We've told them if you're unwell, we are not going to start it right away. They still come in thinking we'll begin, but we have to keep them in a healthy state before we give the vaccine. Mast cell disease, because you can get a lot of systemic cutaneous reactions in such cases. Previous systemic reactions to skit or slit, uncontrolled or severe asthma, excess dose escalation, high degree of sensitization, especially with venom and with grass pollen. Systemic reactions and anaphylaxis are known, and they are well described. These are the two classes of allergens you really have to be very careful while desensitizing, especially with the subcutaneous immunotherapy. Beta blockers, poor injection technique, overdose, there are errors. So the staff who's giving the injection needs to be extremely well trained, unless you as the physician are controlling every single dose and making sure it's right. Lack of adherence, and then high intensity physical exercise, because in some patients doing a lot of exercise after the dose can actually enhance the possibility of a massive mast cell degranulation leading to an allergic reaction. Fatalities just in the US, when we look at data in the last big review that was done between 2007 to 2011, there were no deaths that were reported. This is a very positive thing. We have excellent parameters. They are available online for free, and following them and having always all the emergency medications, your antihistamines, your steroids, your adrenaline, oxygen, potentially even further drugs H2 blockers, glucagon, you name the list. It's a good idea if you're doing subcutaneous immunotherapy that you should have all this accessible and regularly reviewed in your clinic to prevent this problem. So what do the practice parameters and the guidelines say? Immunotherapy for children is effective and well tolerated. It is shown to prevent the new onset of allergies in monosensitized patient as well as progression from allergic rhinitis to asthma. Therefore, immunotherapy should be considered along with pharmacotherapy and allergen avoidance in the management of patients with allergic rhinitis, rhinoconjunctivitis, allergic asthma, and stinging insect hypersensitivity. Which group is eligible? 5 and up is the usual recommendation. But as I said, there can potentially be exceptions. I have kids in my clinic who are doing sublingual immunotherapy at age 4 with us because parents are very keen on getting the therapy going. I'm not going to get into too much into subcutaneous and sublingual. This is not the forum or the purpose of this talk, but there is entire lectures and presentations on this with a lot of data that is out there. In short, subcutaneous is a little better than sublingual for now, maybe between 10 to 30% better, depending on which data and which publication and which author you look at. There are guidelines from the Indian Academy of Pediatrics, the WHO, a lot of other international guidelines, which all say that it is effective, safe, and supported by global guidelines. What are the benefits? I've already gone through this. Absolute contraindication below 2 years. I put a question mark because I told you I personally had one, which was an absolute, which I broke the absolute contraindication. Relative contraindications 2 to 5 years, and immunotherapy can easily be given above 5. I'm just going to briefly talk about other forms of immunotherapy because no talk on curing allergies can be complete without talking about food allergen immunotherapy. Food allergen immunotherapy is still experimental. I personally, because I have experience with oral desensitization to milk, egg, peanuts, and tree nuts, continue to offer it to my patients. But understand that this is something that is not officially approved. You all have probably heard of a product called Palforzia in the US, which has been approved for peanut allergy, but all it does is it increases the threshold at which a child can get a reaction. So the parent will be very scared that if the child even comes in contact with peanut, can have a life-threatening reaction. That child can get exposed to 100 or 200 milligrams of peanut accidentally and still not anaphylaxis. That's the benefit of Palforzia. It does not cure the allergy. Now, do certain patients end up having what is called complete oral tolerance to a food? Absolutely, yes. It has been shown with cow's milk. It's been shown with egg. It's been shown with peanut. But recognize that these are all in research protocols where a lot of reactions occur with these patients. And those reactions are managed by people who are dedicatedly following these patients every week or 2 weeks in their clinic, escalating their doses. The escalation takes about a year to happen sometimes. And after that, the patient has to consume the food on a daily basis for a prolonged period of time if they don't get completely orally tolerized. There is future for even gene therapy. When we look at food allergies, people have tried to make genetically modified peanuts. They've tried to make genetically modified soy. See if you can take away some of the major molecular components. A lot of interesting research, but they haven't been successful yet. They've even tried by giving cats immunotherapy to change the cat's saliva and the amount of allergen excreted in the saliva to see if you can reduce and still have the cat as a pet in the house because the family or the patient won't give it up. So there is a lot of interesting stuff going on there also. With venom immunotherapy, I've just put one slide out there. The effectiveness is above 95%. There is no doubt if it is a truly anaphylactic case that that is the way to go. Why does immunotherapy fail? Wrong setup, wrong patient, wrong allergens, poor quality allergens, wrong dose, and ultimately the wrong duration. I have a lot of these, as I said, companies that are cropping up doing immunotherapy, which say you just have to do it for 6 months. Kindly in your own areas and in your own ways, work to create awareness that these things are inappropriate practice. Nowhere in the world is immunotherapy recommended for less than 3 years, okay? Drawbacks of current immunotherapy: frequent dosing schedules, adverse events, low patient compliance, non-standardized preparations, time, and cost. And these are the real dangers of immunotherapy in India, okay? It has taken me the last 11 years of consistently practicing dedicatedly both pediatric and adult allergy in India with a wide group of patients from rural areas to the ultra rich people to recognize what is going on in all of these patients. But immunotherapy is being based on erroneous blood tests or erroneously interpreted blood tests. The quality of extracts are not what they are supposed to be, and there's a lot of batch to batch variation in the extracts. There is a lack of confidence in writing an allergy immunotherapy formula, and hence people rely on companies and organizations to do it for them, which creates a barrier because those people are not seeing the patient or interacting with the patient. There's suboptimal inclusion of relevant local allergens, as Dr. Anand had presented so well. There are so many unique pollens which are not represented on our CRDs or on our immunocaps. And we still have patients who are highly sensitized to them and don't get the immunotherapy because there isn't an extract for it. So there is a lot of work that we have to do with our aerobiologists to work on that. And we are doing work with some groups. Dangers of doing food allergen immunotherapy. I can't tell you how many times I get prescriptions where someone has put a peanut into a mixture of dust mite and cockroach, which is a ridiculous combination. Means if my mentor in America, Dr. Harold Nelson, who's considered the father of allergy in America, would see that prescription, he would fall off his chair. He would say, who is this person and who taught him allergy? Okay. But I see this every now and then, and I see this from a variety of places, because again, there's a big gap between who does the test and who interprets it and who actually prepares the mix. Incorrect dosing and incorrect duration. I mentioned non-allergists prescribing immunotherapy, loss of faith in the physicians and the patients. I had taken over Dr. Nifadkar's practice in talking with his spouse, who was managing his practice for 3 years with me. She said that sir had begun it in the 90s, but had such odd results and unpredictable results with it that he gave it up. So even a physician lost interest, recognizing that the quality of antigens was not great. Poor adherence to the regimens. People are really looking for a quick fix. And so these are some of the issues. Now, coming to a presentation yesterday that you all heard on CRD, and where does CRD take immunotherapy in the future? This is the future, and this is the last discussion that we finished Dr. Marathe's talk on and where it goes. So with CRD, because we can actually identify the actual molecular antigens that are causing the allergic reactions, and we know which are the major and which are the minor, the future of immunotherapy, besides being able to smartly select, because if you look at this list, it's a very complicated slide. I can't explain it to you completely, but you'll see at the bottom, someone got only GAR, someone got birch and ragweed, someone got grass and ragweed, someone got only ragweed. This is because based on the molecular epitopes that were found on their CRD, based on their clinical history, and based on what their potential skin test allergies might be, very smart decisions were taken to choose only what was required, because mixing more than 3 allergens is not recommended in immunotherapy. And there are people who mix 6, 8, and 10 sometimes together. And then the holy grail is if we can find, okay, we take DERPI1, DERPI2, DERPI3, DERPI6, DERPI7, and we combine it into one mix and we create an immunotherapy. So now you don't have to do dust mite cultures because you can recombinantly create the molecular antigens. And you can then give a very specific shot with that. That would be the holy grail. The problem is every allergen has anywhere from 10 to 30 different molecular epitopes that the human immune system reacts to that we know of. There may be more that we have not looked for. And out of them, to know which are the major and which are the minor requires large population studies. And after you do those large population studies, you can have infinite combinations of molecular recombinant that you can make. So there can never be a single product that you can choose. So if immunotherapy now is complicated, if molecular immunotherapy comes in, it may get even more complicated in the future. And so for now, I tell people, go with what you have. The whole allergens have everything that the patient can potentially be skin tested for and desensitized to. And that is the way to go. But this is the future. And eventually, as I said, people are trying different combinations of major determinants to see if immunotherapy can work. So what can we expect ultimately in children? Improved efficacy over symptomatic medications, sustained increasing efficacy, long-term efficacy. And when I say long-term efficacy, I can say freedom from medications, if that comes close enough to cure. Prevention of new sensitizations, prevention of development of asthma, if we can think of it as a secondary prevention, and then reduction of oral steroids, and ultimately cost effectiveness over symptomatic treatment if it is done correctly. all of these are benefits of the immunotherapy. So thank you very much. And if there are any questions, I know they've brought up quite a few controversial topics, but I'll be happy to take them. Otherwise, thank you very much to the organizers, to Dr. Rajkumar and the entire team at PED ALLERCON Nagpur and IAP for inviting me for these programs. Thank you.
Thank you, sir. This was a very nice lecture. So just one question regarding you said, so from here, sir. From this side, sir. From the
Oh, okay.
Yes, sir. So you said that you need to decide whether it should be given for a 6 months therapy or a 3 years therapy.
There is no 6 months therapy. I never said 6
So
months.
how much cost you would suggest, sir, for the
So depending on where you purchase your allergens from in India, so if you go with any of the Indian manufacturers, the allergen immunotherapy cost runs around 1,200 to 2,000 rupees per month. Okay, the way the companies provide it to you. And if you're doing the injections or you're doing the sublingual, the dosages are different. Sublingual is not officially approved in India, so it's an unapproved therapy if you're doing it. With subcutaneous, the average cost is somewhere around 1,500 to 2,000 per month, approximately, maybe less than that also, depending. I've seen very, very weak compositions made to reduce the cost, and understand that dosing, optimal dosing, is the success mantra for a successful immunotherapy. So, but you're looking at a cost of at least 1,500 to 2,000 per month if you're doing it correctly. And if you do it correctly and you do it for a 3-year period, you can multiply and see the cost. Again, as I said, this is with the non-standardized allergens. If you go with the standardized allergens, so when we had Allergoid from Merck, Allergo Pharma in India, the cost of therapy for an entire year of therapy was, if you include the shipping cost, the allergen cost, everything was still working out to about 40,000 rupees for the whole year. So if you divide it into 12 months, 3,500 per month, 4,000 per month. If you use imported allergens, the cost can go higher. If you use local allergens, the cost will be a little lower, not little, significantly lower. But yes, when you explain this to parents, and they understand that there is a potential for their child to be free of that disease or free of a bunch of medications or exacerbations, many of them are open to doing it, is what I can say. But there is no 6-month immunotherapy. Immunotherapy, if done, is 3 years, ideally even 5 years if it's a very highly allergic child.
Thank you.
Yes.
About immunotherapy to cat dander or dog dander for that.
So even in America, there are 4 major allergen manufacturers, and all allergists worth their metal would only buy the cat allergen from one manufacturer. Because even inter-manufacturer in America, the difference in quantity of, so, fortunately for at least 8 to 12 allergens, we know the exact microgram quantity that should go in per injection for successful desensitization to occur. So for cat, that number happens to be 7 micrograms. So in India, the allergens available, okay, from what my experience has been, just don't reach that level. So unless you're going to do really high dose immunotherapy, your success is going to be compromised unless you're using an imported allergen, which is possible if you make the effort. Allergen immunotherapy to pets is very successful done correctly. Okay, it's been shown to horses, it's been shown to cats, it's been shown to dogs. I know you don't consider mice to be pets, but mice and hamsters are pets in America, believe it or not. We consider them as menaces. And they have done immunotherapy to that also and shown that it works. People have even spoken about doing to other animals that are pets, but these 4, there is published data and it works. So as you saw on the list also, there was a 2+, 3+ kind of a range for pet dander immunotherapy, which is successful and proven. But the quality of allergens, that's the key. So you bring up a very important point, and this was one of the reasons why Allergo Pharma left this country, in my opinion, that because some of the regulators said that dust mites in Germany are different than dust mites in India. which is a ridiculous explanation. But the reality is that if you have a certain plant or a tree, so for example, in Kashmir and Himachal, there are a lot of trees that are also present in Europe and US. The latitude belt determines the allergen. It's the same across the globe. It does not matter. But you can't take a cross reactivity that because a company says that don't worry, Parthenium and ragweed are cross reactive, you can use Parthenium if your ragweed comes positive on the blood test. That is nonsense. Okay. So as long as you're using ragweed, because ragweed grows there and ragweed is what your patient is sensitive to, you can very well use imported allergens. So imported allergens for dust mites, for cat, for dog, for molds, the typical ones, for cockroach will work no matter where you are in the world. That's my sincere belief. And I stand by it. I wrote letters to the DCGI when it was required. But there were a lot of other political reasons why it didn't happen. But the reality still stands that allergen that is what I call universal. So difahrinate, deuteronosinus are universal allergens. No matter where you pick them up in the world, they're going to have the same thing. They're going to eat the same human scales. They're going to shit the same feces, and they're going to contain the same DERP1, DERF1, DERP2, DERF2, and the typical antigens. It's been already shown. So people even talk about going with an American cockroach versus a German cockroach versus going with a male cockroach versus a female cockroach. I think these are all semantics. It makes no sense to me, really. You're dealing with an insect. It has a certain gene composition. It has a certain level of allergens. They're all going to work. You just have to be smart about selecting the right patient. The other day, I had a question. Someone was asking me, highly cockroach sensitized, but doesn't see a single cockroach in the house. Okay. I said that that's going to be a tough call for me. If there's no exposure, even if the skin test is highly positive, I'll ask myself, what am I desensitizing to? Now, if the person also goes to school, daycare, and sees cockroaches there, I would do a real investigation to find out other areas of exposure. And being a ubiquitous allergen, I might eventually give immunotherapy. But it's a uber rich person and says that they get, pest control done 3 times, 4 times a year, and they never see a single cockroach and the cockroach comes positive, I'm going to be more likely to believe that it's a cross sensitization with the dust mite that's causing the positive for the cockroach. Thank you very much.
Thank you, sir.
I would like to call upon the chairperson and Dr. Sitesh Roy, sir. Please come forward for the photo, please. Dr. Dhiren Gupta, sir, please.
I will request Rajkumar sir and all organic team to wait for one group photograph here. We will have off the stage.
And
all
I
the
must
organic committee
congratulate
members.
the chairperson and MOCs and all the esteemed faculties for finishing the PED ALLERCON well in a time. Exact what we have in our browser.
Please, everybody come for the group photographs, please. Please stay. Mustafa, please stay. We have to, yeah, ऊपर नीचे सब. हाँ जो वही नीचे रहते. वो नीचे. नहीं सर काही खाली राहत उभे काही वरती सर कुछ नीचे कुछ ऊपर. हाँ तुम्ही सर. हाँ आ जाओ. Come everybody. सर आ जाओ. Please come everybody. ऊपर आ जाओ ऊपर. Please come. Hmm.
ऐसा हो जाए ऐसा
Thank you, everybody. Thank you. Thank you.
Thank you, British.
So thank you once again, all the esteemed faculty all over the India. And yes. Thanks to all the delegates. All are invited for the lunch. Those who have not done till now.
Anybody is going to airport? Any faculty going to airport? नहीं टाइम तेरे को टाइम है क्षितिज का कितना है
अबे तू ते शटडाऊन मारला ना